Thank you. Good morning and welcome to the Thursday, January 28th meeting of the Joint Standing Committee on Health and Human Services. We are assembled around our virtual horseshoe via Zoom. We are live streamed on the HHS channel of the Maine State Legislature's YouTube channel, where you can find the replay of our proceedings should you miss us live. We continue our committee orientation and ongoing presentations from DHHS, over which this committee has oversight, and from various statutory agencies. This morning, we will hear from the Office of Family Independence, Molly Bogart, Director of Government Relations for the department, and from both Riverview and Dorothea Dix Psychiatric Centers. We're joined today, as always, by our OPLA analysts, and I'll allow them to introduce themselves, please. Anna?
Hi, I'm Anna Broom, and I'm one of the nonpartisan staff in the Office of Policy and Legal Analysis.
And Erin?
And my name is Erin Dooling. I'm also with the Office of Policy and Legal Analysis.
Thank you. As well as our clerk, Carrie Withy. Their work is vital to our work as a committee. I would ask the committee members to be sure that you change your name as it appears in your Zoom cubicle to reflect your title. So I'm just looking around to see if you need help with that, there's a little blue box up in the right corner, and you can rename yourself to include representative or senator. So we will make introductions around our horseshoe, beginning with Representative Griffin.
Good morning. My name is Abigail Griffin, and I represent House District 102, which is Glenburn, Levant, and Cadescade.
I am not seeing Representative Connor. He may have another committee responsibility this morning, so I'll go to Representative Craven.
Thank you, Madam Chair. Good morning. I'm Margaret Craven, and I represent District 59, which is part of Lewiston. And I will welcome my intern here today as well, Sasha. Thank you.
Good morning, Sasha. And Representative Madigan.
Good morning. I'm Representative Colleen Madigan. I represent House District 110, which is part of Waterville and part of Oakland.
Senator Moore.
Good morning. I'm Marianne Moore, and I represent Senate District 6, which is all of Washington County, as well as Goldsboro, Winter Harbor, and Sullivan and Hancock County as well.
Representative Zager.
Thank you, Madam Chair. My name is Sam Zager. I represent District 41 in Portland. Good to see everyone.
Representative Lemelin.
Good morning. My name is Michael Lemlin. I represent District 88, Chelsea, Jefferson, Whitefield, and half of Noblesboro.
I'm not seeing Representative Stover, so we'll go to, actually, I'm not seeing Senator Baldacci either. So Representative Perry.
Good morning. I'm Ann Perry. I represent House District 140, which includes Indian Township, Baileyville, Barron, Calais, Charlotte, Robinson, Perry, Pembroke, and Pleasant Point.
Representative Javner.
Thank you, Madam Chair. Good morning. I am Representative Kathy Javner. I represent House District 141, which includes the towns of Burlington, Carroll, Chester, Drew, Kingman, Lakeville, Lee, Lowell, Mattawamkeag, Prentice, Whitney, Springfield, Twombly, Webster, Wynne, Alexander, Big Lake, Brookton, Codyville, Cooper, Crawford, Danforth, Dayblock, Dennysville, Dyer, Fowler, Forest City, Forest Township, Grand Lake Stream, Greenlaw Chopping, Cassuth, Lambert Lake, Meadowbanks, Princeton, Talmadge, Topsfield, Vanceboro, Waite, Barry, Cathants, Edmonds, and Marion Townships.
Thank you for that. I think we've all been waiting for that. And Senator Claxton.
Good morning. Good morning. I'm Ned Claxton. I'm honored to represent the folks in Senate District 20, which includes Auburn, Minot, Mechanic Falls, Poland, and New Gloucester.
Thank you. And I am Representative Michelle Meyer, serving Southern Maine's House District 2, which is Elliott and parts of South Berwick and Kittery, and I'm the House Chair. So
Did
we
Carrie
will
have a chance to introduce herself?
Did
Carrie.
Carrie? She did not. Miss Withy, would you like to?
Good morning. My name is Carrie Withy, and I'm the clerk for the Health and Human Services Committee.
Thank you for that, and I'm sorry for overlooking you. So this morning, I think I'm just going to turn it right over to Molly Bogart to do introductions, and take it away, Molly.
Good morning. I'm Molly Bogart, Director of Government Relations for HHS, and we'll start off this morning with the Office for Family Independence. We have Tony Pilot, who's our Director of OFI, a veteran of the department and a wizard with systems, so he can talk about the programs within OFI. And we're also joined by Jennifer Tankersley, his executive assistant, who's going to help us take some notes. So I will hand it right over to Tony.
Good morning, Senator Claxton, Representative Mayer, and members of the committee. As Molly mentioned, my name's Anthony Pilot. Of course, you can call me Tony. I'm the Director of Family Independence here at Department of Health and Human Services, and I very much appreciate the opportunity to give you an overview of our office and the work we've done. I do have a list of your names here, so even if your titling on the Zoom isn't completely accurate, I'll have a backup. I'm going to start sharing my screen so that we can run through the slide deck that's been provided for today, and then happy to entertain all questions. All right. Hopefully you can all see the slide deck now. Kind of got the first slide out of the way, so I'll just go to the second one. So generally speaking, here at OFI, we administer all the major social service programs for Maine residents. So we're talking about the TANF program, SNAP program, used to be called food stamps or food supplement. And we also do eligibility for the Medicaid program, Maine Care. As you can see, we have a very large office of positions. It's actually down a little bit as far as permanent positions, about 60 or so down from the previous biennial. And we do have some limited period positions that help us fulfill some of our triage and customer service focused areas. Our state fiscal year expenditures, as you can see, were around 300 million. All right, the next slide's pretty important. It's a very busy pie chart, but if the devil's in the details here. You can see that we've broken out the expenditures by all of the social service programs that we administer. These are combined state and federal dollar totals. As you can see, our child support division does quite a bit of expenditure activity. General assistance is also a typical topic that people want to discuss as far as expenditures go. I won't say much more about this. I know we're going to get more into the specificity of our programs as we work through the presentation. So if there's any questions about some of these areas, I'm happy to take those up when you have questions. So this just gives a kind of, again, a little bit more detail around the overview of the services that we provide out of OFI. I've already mentioned the major social service programs that we do, Maine Care, SNAP, and TANF. We also offer, as kind of subsidiary programs, several different employment and training programs that are focused on helping people improve their their economic situation. So of course we have the Aspire program, and we often get asked to tell people what the acronym stands for. So we spelled it out here for you. And then of course we have the SNAP E&T program, which is very important and has been nationally recognized. We have a terrific special projects program manager, Patty Dushuttle, that oversees this effort. There's a little bit more on this later in the presentation, so I won't get too much farther into that. And then another program that we're really excited about is a new one that we just launched at the beginning of last year, right before the pandemic hit. It's called HOPE, Higher Opportunity for Pathways to Employment. There's a slide on that that will give us a little bit more detail about that as well. Just a few other little details about what we do here at OFI. We do oversee and administer general assistance in partnership with the municipalities. So essentially we have a program manager who oversees the administration and policy of general assistance. And then she works very hard to ensure there's some standardization as to the application of general assistance. There's a couple slides on general assistance, as you might expect later as well. OFI also has our child support division, which is a separate grouping from our eligibility branch. And their essential goal is to ensure that child support payments are provided to custodial parents from non-custodial parents. And then lastly, the last division that we have within our office is the Social Security Disability Determination Claims Office. And they process disability claims for Social Security Administration. So they get applications and do assessments on the medical situation for clients, and ultimately render a decision on their ability to carry out certain types of work employment, if at all. So of course, we're all dealing with the pandemic. Otherwise, I'd be sitting with you over at the legislative building, at the table with the funky microphone. This just talks a bit about this in summary of all the work that OFI has done in response to COVID-19. Obviously, our peer office in the Department CDC has the lion's share of communication on that type of activity, but it notes here that OFI was very quick, and over about a 2-week period, we were able to transition about 85% of our workforce from within the regional offices into their homes. We have maintained an open office presence for those clients that feel the need to come in and address urgent issues. And we do that on a rotational basis just to ensure some equity amongst all the staff. We've expanded communication on other channels that clients can take advantage of so that they don't have to come into the office. We've been able to take advantage of some of the federal waivers that allow us to process and complete applications over the phone, and we've set up drop-off boxes and stuff of that nature. So the goal is to continue to provide a high level of service while ensuring the health and safety of not only our staff, but the public. And last note on public safety is that we did dedicate a lot of our staff at the Wilton Call Center to assist with CDC contact tracing. This started about 3 or 4 weeks ago. As you may recall, there was some backlog that needed some additional help, and OFI was glad to provide some additional resourcing to help on that front. So very proud of that staff for being flexible enough to change their work focus to assist the CDC. Another program that started, I want to say around November, December, is the Health Equity Initiative effort, where we're providing social service supports for COVID positive individuals. So as you can see here, it's essentially establishing agreements where we can pass over funding to help community agencies provide COVID-19 supports. I have a couple of great staff from the TANF program that have been putting in a lot of time to overseeing this effort. Alex Lorettson's our program manager for TANF, and she's done a terrific job with this effort. And then, as I mentioned earlier, there have been some opportunities for us to take advantage of improving processing for applications and reviews of benefits. And as you can see here, there's multiple things that the feds have given us the opportunity to take advantage of, and we've taken advantage of every possible avenue to ensure that benefits are getting out to folks that need them, and in a highly safe and thoughtful manner. So for example, we haven't closed anybody off from main care. That's been allowable by our federal partners. We've been doing max SNAP benefits to eligible households since we've been able to. I think April was our first full month of doing max benefit to SNAP recipient households, and we continue to do that through January, and we intend to do it again for February. We did launch a pandemic EBT effort to provide SNAP benefits to school-age children that have been either in a hybrid or online only status at schools. So that's additional money to those households so that they can provide food for their families. And we've also, looked at how we've managed our TANF and Aspire requirements by ensuring that people are afforded as much opportunity to participate if they like, but with health concerns, they've not been, there's been no downside or impact to them, staying healthy and safe at home. And then finally, the executive order on general assistance did allow for additional funding to go to the tribes, and it has provided some additional guidance to municipalities so that they can have an easier go of approving applications for those who need it the most. So we're going to focus in on our main care eligibility determination work. Of course, you probably already know this, but main care in Maine is split between two offices. The Office for Family Independence does all of the eligibility determination. So somebody will apply for main care, and we will then apply all the necessary verification and programmatic requirements to determine whether or not these individuals and their households are eligible for main care. And then once they've been determined eligible, we pass that information over to the Office of Main Care Services claims system. And from there, they handle, the different insurance coverages that these folks are eligible for. As you can see, we received a significant amount of applications in 2020. And you can see over the last 3 years here, the steady increase in main care participation from the public. So that's a good thing for us to see. More people are getting the health insurance coverage they need stay well and healthy. The next focus slide's on SNAP program. And as you can see, we've got about 90,000 cases of 160,000 plus individuals receiving our food supplement benefits. The majority of our food supplement households are 100% federally funded. So we essentially determine eligibility, set the benefit amount, and then the feds provide the benefit to those households on an electronic benefit transfer card. There is a population of state-funded SNAP households, which that money comes from the state of Maine, and they also receive their benefits on an electronic benefit transfer card. We'll talk a little bit more about our SNAP Ed program, which is also a nationally recognized program, and that's also led by our special projects manager, Patty Dushuttle, who does a terrific job with that. We'll get a little bit more into that in a slide later. And lastly, you can see how much money has been expended in state fiscal year 20 in federal SNAP benefits, $260 million to households. That's a large support to the economy. It's money that's being spent on food and provides for a lot of retailers that provide food. So important program. This next slide just shows participation over the last decade plus, and you can see how the program has kind of fluctuated over the last several years, but it's definitely now on an incline over the last couple of years. And of course, I imagine that's mostly attributed to our pandemic situation. More people are in need for SNAP benefits. The next slide is really just a companion slide to the first, which shows a commensurate increase in our benefits to the caseload increase. All right, the next focus slide here is on our Temporary Assistance for Needy Families program, which is the cash program to households. Really, I guess the big thing to say here is that we do get a $78 million block grant annually, and in order to leverage that funding, the state is required to meet a maintenance of effort level of 37 million. And as you can see, a similar trend over the last few years as in our SNAP program, a bit of a dip from 18 to 19, but now we're seeing a bit of an increase again. And I believe, again, that's due to the pandemic situation that's impacting everyone. Moving on to the next slide. This is where we'll get a little bit more into our SNAP employment and training program. But here are several different areas where we try to support families to help them get education and training needed to become as self-sufficient as possible. Many of these supports include, of course, childcare support and transportation. Transportation obviously is a huge barrier in a large rural state like Maine. We also provide support for education courses, so books and tuition fees and stuff like that. So the first program obviously is the Aspire program. So those participants in the TANF program, there is the federal requirement that they participate in the Aspire program. And through case management, we can identify the areas of need that the participant can benefit from, and then they work that plan to assist the individual. And it's a comprehensive plan that's, if in some cases it may be that English as a second language would be beneficial, or it could be that they need to finish high school, or maybe they need help writing a resume. All of those types of things come with the Aspire program. Now, the SNAP Employment and Training Program is it's an optional program for our adults receiving our SNAP benefits. And we have relationships with many vendors across the state to provide similar services to those that I just mentioned in the Aspire program. I'm sure some of you know Goodwill and, of course, Family Futures Down East, great programs. Then lastly, this is the new program. We're very excited about it. The first year launch has been pretty darn good for having launched right before a pandemic. And we've had over about 860 applications. We've had 30 graduates come out of this program. There'll be another slide that gets into a little bit more of those numbers. But as you can see, this goal is to help individuals get into certification programs or secondary education programs, and help them, finish certification and/or degrees that can then help them get into the workforce. Large amount of our graduates are getting into the health industry, as you'll see very soon. And then, just because we want to dial in even deeper to our SNAP Employment and Training program, here's some additional information about how many participants we had in federal fiscal year 21. We had just under 400. It talks about the different types of things that we reimburse. So, of course, job retention services, case management, paying for books, and tools needed if someone takes a particular job and they need help getting tools to be effective in their new role. All of those things are on the table. And here's just another more in-depth list of all the different contracted providers that work with us on this. All great partners. If you're interested, we did post a link here that you can learn more about it, or you can always shoot me an email, and I'm happy to connect you with our special projects manager who oversees this program. All right, next slide just talks about our Family Futures Down East relationship, and most of the funding for this program comes from TANF funding, as well as some SNAP E&T money goes towards this. And the whole approach on this program is to fight poverty by taking a multi-generational approach. So not only are we working with the parent to help them improve their situation, we're also providing supports to young children in the household. So getting them into the right education classes while their parents are getting those additional supports to either get ready for the workforce or maybe overcome some personal challenges like substance abuse disorder, or it's just a very comprehensive program. But the basic gist here is, it's not only working with the parent, but it's also ensuring that the child is able to also break free of that cycle of poverty. And there is a link here on this page that you can learn more about the great work that Family Futures Down East is doing with the TANF and SNAP ENT funding that we provide. All right, here's that promised slide on HOPE, where we have a little bit more detail. Of course, I kind of already summarized the first bullet, so I won't bore you by reading it again. But here, the second bullet's important. It tells you who is potentially eligible for this program. And as you can see, there's many folks that fit into that category. It's currently capped at 500 individuals statewide. We have about 360 folks that are participating, so we do have another 140 slots to fill, and I know that the program manager that oversees this program, her name is Sherry Wilkins, and she's very, very passionate about this program. No one works harder than Sherry, and to implement a brand new program from scratch is just such a significant achievement. So it's not hyperbole when I say that she's done a fantastic job with this. I'm really hoping that she'll hit 500 sometime soon. And you can see here that many of the bachelor's programs that are currently being participated in are focused on healthcare, technology, and engineering. Definitely future economic opportunities in the state of Maine. So that's really good for the future of our workforce. If you want to learn more about the HOPE program, the information's there. You certainly can reach out to me that's a common refrain. Always reach out to me if you have any questions. Happy to run things down for you or connect you with any member of my phenomenal office team. Okay, so the next slide is the next couple of slides we'll get into our general assistance program. This is usually a topic of discussion for folks because you know, it is a state-funded program, and you can see that we pay, you know, a significant amount of the program. It's 70%. The municipalities do have to come up with a portion of it, but we do have the lion's share here. And so you can see general assistance cost over the last, you know, 15 years or so has gone up and down a bit, but again in 2020, a significant spike there. And again, I'm sure you can all figure out why. The pandemic is really increasing the need for services like these. So the next slide, I don't recall where everybody is from. I know I do have my little cheat sheet here of just certainly Representative Kathy, I think it was Kathy Javner, you had a very long list, but on my cheat sheet here, it just says Chester, but clearly that doesn't do justice to the areas that you cover. But anyways, we will see here momentarily a breakdown of the top spending towns. So wherever you are a representative or senator for a particular area, I'm sure that will be of most interest to you. This slide here, though, gives us a sense of where most of the general assistance dollars are spent. This is information that's provided to us by the municipalities. And you can see that housing is clearly the winner here, which is a dubious honor when we're talking about general assistance, obviously. But then, of course, you have emergency housing, significant challenge in many of the municipalities that I've had conversations with. And then, of course, our PFO, Shannon Courtois, she does a fantastic job with keeping track of our budget. And as you can see, she did her best to keep things broken out here over on the side of the non-housing expenditures. But it's always a bit sobering to see where where people's needs are when you're talking about general assistance, which is the very last line of support for families in need. So here's the next slide is the breakout of where much of our general assistance spending goes. Portland certainly gets quite a bit of it, and then it's followed by Bangor, and of course, a few of the other larger locations are very similar in their expenditure. So kind of speaks for itself, I guess. But if there's ever a need to get a little more dialed into a specific town or whatnot, that's data that we can always pull up for folks if needed. So I'll move on from GA to our Child Support Enforcement and Recovery Division. As you can see, they collected quite a bit of money in state fiscal year 2020, and it was all in the effort to help put money into custodial parent hands to provide for children. There's a great leadership team overseeing DSER. Jerry Joy and Kate Rugen have many, many years of experience in child support, and they do a fantastic job at running that division. And I think it's interesting for me, this slide's most interesting, where you can see where the collections by action occur. Most of it obviously is wage withholding, so working with employers to just have that automatic deduction from someone's paycheck. But then of course, federal tax returns are another big area where funds are collected for children. So I'll move to the next slide. And this really just gets into more of the, this is probably not as exciting for you folks, but operationally it takes a lot for an office like ours, where we're always around 900 staff, 3 divisions, dozens of units that focus on specific areas of need. And in order to make that happen, we need to ensure that we have smooth operations. And that's very challenging, again, with so many staff. But I have a great Chief Operating Officer, Dan Cohen, who works with our Central Operations Assistant Director, Jeff Farnsworth, and they do a good job at making sure we have resources deployed where they're most needed. So we do have a statewide phone queue. I'm sure some of you may get occasional complaints about not being able to get through on the phone. As you can see, we take a significant amount of phone calls on an annual basis. 600,000 calls is just incredible. Of our eligibility workforce, not including our long-term care focused folks, we have about anywhere from 212 to 220 eligibility workers at any given point in time that are available to do applications and recertifications. We do about 1/4 of that staff to take, processing questions over the phone. So eligibility questions, processing applications and recertifications, that's their job. We also have the Wilton Call Center. That's an additional 45 staff when there are no vacancies. And their job is to really kind of act as that first line of question answering, like, where's my application? Do you know how much longer it might be? Is there anything I need to submit? They can answer a lot of those questions, but when the need to get into an application interview, they then get passed over to those 55 eligibility workers. So a phone system operation is always very challenging. Another support for our work statewide is our document imaging system. So all the mail that we get, whether it's paper mail or submitted electronically through email, it all gets uploaded to a central document imaging repository. And then my staff statewide in any office can pull that work down and work on someone's application. So someone could live in Fort Kent, but their application recertification could be processed by an eligibility specialist in the Portland office. Farmington could be, a person living in Farmington could be processed in Rockland. And this is just a way for us to ensure that as efficiently as possible, we're handling this work in a timely manner. As you can see, we have a dedicated document imaging staff in Farmington. We have a terrific manager there. Her name's Roxanne Brand. She's been doing this for a couple of years. They have a really great process there. And they ensure that all that mail gets in and is available within a day or two of our receipt. So that helps us process as efficiently as possible applications and recertifications. We also have a workflow management tool called Siebel. It's an Oracle product. And essentially what this does is it queues up work based on a hierarchy that's been established by subject matter experts. So it gives us an opportunity to ensure that staff hit the next task button and the next task they pull is the next most urgent activity that needs to be accomplished. It works pretty well. And I don't know we would be as successful with our statewide processing without a workflow management tool like this. Then lastly, we have our online presence, which is currently my main connection. A little bit more on that in a couple of slides, but my main connection is an online application and recertification process where people can submit an application for SNAP or main care benefits. It then gets packaged up and sent over in an interface to our ACES eligibility system where staff review that information and then process it to an eventual eligibility determination. So that is an overview of our operations. There's a lot more that goes into making sausage. I'm sure some of you if you've ever made sausage before, you know there's a lot more to it, but if you have questions, I'm certainly happy to talk more about it.
Thank you, Director Pilot. An excellent overview. So I'm thinking we've got questions from the committee.
Okay.
And I think what I'll do is I'll go around the horseshoe, and what you can answer here today would be great. And if not, I'm sure Ms. Bogart will take the questions back and
I think
return with
just
answers.
a few more slides, if you don't mind.
I'm flexible, Molly. However, Representative Meyer would like to approach this, I'm fine. If they want to get into questions now, that's okay with me. If it's okay with you.
Sure.
And I mean, I'm free. My time's your time this morning, so.
Thank you. Thank you.
Yes.
Representative Griffin, any questions for Director Pilot?
It's been a wonderful presentation, but I don't have any questions at the moment. Thank you very much.
Well, thank you. Appreciate that.
And Representative Craven.
No, thank you for the presentation, and it was very useful, and I don't have any questions. Thank you, Madam Chair.
Okay. And
Thank you.
Representative Madigan.
Yes, I have a couple questions about GA. What I've seen in my town is that there's an increasing folks who have lost housing. And so I'm wondering, is there any sort of direction you provide to municipalities and how they should deal with GA applicants who can't provide receipts for everything, for instance, what I've heard is, someone doesn't have transportation, so they give someone $5 for gas to take an appointment or, to go shopping, things like that. And they can't give a receipt for that, and they're at risk of not getting GA, and then also kind of not being able to reapply for a length of time. So I'm wondering whether you're giving any direction for that. Is there any allowances for that? Is there anything in the governor's executive order that would help towns manage this?
Yes, that's, thank you for your question. That's been a challenge, honestly, is keeping some standardization and application of general assistance guidance. Our program manager has regular meetings with the municipalities, program manager Sarah Denson. And I think she does a terrific job at trying to ensure that interpretation of things like the executive order, which should provide the level of clarity that municipalities need to ensure they're appropriately following up on applications for services. Now, we do hear in some of our meetings that some municipalities have different interpretations, and when we get those complaints, we do our best to reach out to those municipalities directly, and Sarah often does that herself and just lays out for them why their interpretation may be incorrect and why they need to maybe change things. So there is that level of quality control, if you will, to ensure that some of the things that you're suggesting don't occur if that's not the intent of general assistance.
And just one other question.
Yeah, of course, yes.
We know we receive some CARES Act funding, and of course, there's hope that there's more pandemic assistance coming down the pike. GA is the last kind of resort, and I'm wondering, if there's any plan to increase that 70% reimbursement, or is there any way that towns can be supported more, being as they're dealing with folks that are really at their last chance of help?
Yeah, I've not had any conversations about doing any kind of change on that front. I would note that we did, make some significant changes for the tribes, which I think was really important. But I'm sure that Molly's aware of that, and we've been asked this before from the municipalities themselves, and so I'm sure that's on the administration's radar for further thought.
Thank you.
Yeah, you're welcome.
Senator Moore.
Sorry, I wasn't anticipating that. Just a couple of questions. One of the things I was trying to remember, who do you all contract to administer the Aspire program?
Yes, the company is called FedCap.
So they are still the contracted company then? Because I know
yes, they are. Yep.
Okay. Because I know at one point in time, I think there was conversation about their contract and quality assurance and so forth. So I was curious if they were still doing that. And thank you for the presentation. I'm really interested in that HOPE program. I want to see if I've got some folks from Washington County that are part of it. And the Down East Futures is great. So thank you.
Thank you, Senator. And I know Sherry Wilkins would love to have any kind of time with you to discuss how to get folks from your area enrolled. Thank you.
Director Pilot, would you mind not sharing your screen so we can
of
get
course.
the committee? Unless you've got a few more. Okay. Thank you.
Nope, sorry about that.
No problem at all. Thank you.
I just, I was so excited about seeing my name up there. I just wanted to.
Representative Javner.
Thank you, Madam Chair. No, I have no questions at this time. Thank you.
Thank you.
And Representative Perry.
Thank you. It was a great report. It's also great to hear what you are doing. And and also the help that this is really offering through the pandemic with the SNAP program and else. I have no questions. Thank you.
Thank you. Representative Stover has joined us. Would you introduce yourself and any questions if you have them?
Yes, good morning. My name is Holly Stover. Nice to see you, Tony.
Nice to see
I
you.
represent House District 89, including Boothbay Harbor, South Port Edgecombe, West Port Island, and part of South Bristol.
Representative Lemelin is not with us here.
No, I'm here.
Oh, there he is. I'm sorry.
There we go. I have just one small question. I love all your programs and what you do, and all the hard work and effort. Are you offering training to everyone in the SNAP program that has the ability to go out and work, or do they have to come to you and ask for it? Because I think a lot of people don't even know it exists, that there's training available.
That is the purpose of our ENT, is to get the word out and engage individuals to participate. So if what you're saying is true, then I'm disappointed to hear that maybe we're not doing as good a job in your area as we could be. But yes, there is a expectation that for certain individuals, there's participation in a program.
Okay, thank you very much.
Yes, you're welcome.
And Representative Zager.
Thank you, Madam Chair. Director Pilot, I really appreciate the work that you and the 800 or 900 folks at OFI are doing. I have no question.
Thank you.
Senator Claxton.
Thank you. I had a couple of questions as soon as I get my screen back here. Sorry about that. Can you help me understand, sir, the difference between individual and case count in that bar graph you showed us?
Yes, I can. So we just essentially, a case would be an accumulation of a number of individuals that live in that household and receive the same benefit. So you could have a case of one individual, could be a person over 70 getting main care. That would be one individual. Or you could have a SNAP household of 5. It could be a mom, dad, and 3 children. So that'd be one case and 5 individuals.
Okay, so you're serving a lot more than that screen indicates, because cases can be between 1 and however many.
Yes, sir. The average per case is typically 3 individuals.
Okay, that helps. The other question I had, and I've heard about in the past more than recently, so I don't have current information, but what's the cycle time between the first contact with the office trying to establish access to main care and the individual getting access? I know that's varied over time, so if you could help me with that, that'd be great.
So I think what you're asking is about application processing time, right? Yeah. So we receive the application, and then how long does it take us to gather the verifications and complete, the necessary I dotting and T crossing to get to a determination? And that does vary. Certainly over the summer, our numbers were quite good because of the fact that we had a lot of flexibilities in place that allowed us to take self-attestation, for example. Self-attestation is a situation where the client says, this is what I make.
Right.
And the feds allow us to use that for determination purposes. And then the requirement of us as a state is to follow up and ensure that, but it's at a later point and it doesn't delay the determination of the main care. Right now, we have a significant amount of work from open enrollment that has ballooned our main care applications. So the numbers these days are not as good as we'd like to see them. The general marks that we need to meet is 30 days for any application. And then another key date threshold is 45 days. And the reason why 45 days is important is because if the 45th day there's still no decision and it's through the fault of the department, then we need to open that client up on what's called temporary main care coverage. And that's all state funded dollars until such a time a decision is rendered.
Thank you.
Does that help your question,
does.
sir?
It
Okay.
does, yeah.
And a question from me. I was a member of a committee that met over the interim, and among the testimony that we heard were from folks who had been involved in various safety net programs. And repeatedly we heard about a lack of coordination between programs and recommendations to streamline the process for applying for benefits, maybe create a one-stop resource where programs were communicating, where you could go for an easy to read, understandable application that then would apply to and communicate with the other programs. Have you heard that complaint, and is there any movement towards such a one-stop resource?
I have heard, I think if we're talking just about OFI programs, we run an integrated eligibility system. So whenever somebody comes in to apply for OFI program, SNAP, TANF, main care, the engine, the rules engine, the technology rules engine will give, if somebody just decides they're only there for SNAP, the rules engine will say, it looks like this person's eligible for main care. And at that point, we can offer that to the individual, and that's how our staff are trained. Now, if we're talking about, on a statewide level, better connectivity between a quasi-state agency like Maine State Housing, and ensuring that our folks that are SNAP recipients are signed up for LIHEAP or their electrical assistance program. Those types of things have been discussed, but the real challenge there is primarily two places. One is the technology it takes to set up a data interface or a highway between systems. And that would take money and time, obviously. And then, the policies, the federal and state regulations around the data that's exchanged between a Maine State Housing or a Department of Labor and our department, Office for Family Independence. It may be that, for example, Maine State Housing can take SNAP data and consider it information verified about the individual, but for OFI, we would not be able to take Maine State Housing information and consider it verified for SNAP. So I have heard many conversations about this over many years, and I do think that it's certainly a possibility in the future, but it would take some significant planning.
Thank you.
Yes, thank you.
Any other questions from the committee? Seeing none, thank you very much for being here this morning.
Thank you for the opportunity, and please reach out if you have any questions that come up later. Happy to hear them.
We'll do that. Have a
Thank
good
you.
day.
Take care. Bye-bye.
You too. So we're going to change. We're going to have a minor change here in this morning's agenda, and Superintendent Taylor of Dorothea Dix will present to us next, followed by Molly Bogart.
Great. And thank you. I will briefly introduce Superintendent Taylor, who last time you saw her for orientations was with the Division of Licensing and Certification, but we are very glad that she was willing and able to move over to Dorothea Dix as superintendent and has done just a huge amount of work in the last year and a half or so that she will talk to you about, as well as Dr. Dan Potenza, who's the clinical director for Dorothea Dix. So I will start sharing slides and we'll get going. I'll just make sure I'm sharing the correct PowerPoint. All right. There we go. Sarah and Dr. Taylor, take it away, or Dr. Potenza, take it away.
Thank you, Molly. Senator Claxton, Representative Meyer, committee members, I am Sarah Taylor. I am the superintendent of Dorothea Dix Psychiatric Center, and I am joined today by Dr. Daniel Potenza, who is our clinical director. Next slide. This is a picture of the main hospital. The building was built in the late part of the 19th century and opened in 1901. We are on the historic register of buildings. It is truly a unique institution. Next slide, please. So our mission is to work with individuals with severe and persistent mental illness. And we provide assistance to them, recovery-oriented, respectful, compassionate, and effective psychiatric care, excuse me, in the least restrictive, safest, and most therapeutic environment we can create. Our vision is to really help people develop the skills, increase their knowledge, use their strengths to lead hopeful and autonomous lives. And we devote ourselves to the most timely return of those we serve to a more independent, sustainable, and hopeful life in the community. And I'll reference this later in the presentation, but this is really under the underpinning of what we do. Next slide. So last year, when Dr. Potenza and I did our presentation, we had outlined a number of challenges for 2020. And I wanted to give you an update on how successful we have been in addressing those. So one of those challenges was staffing. And as with all healthcare facilities, we compete for clinical staff in our region. And this continues to be a challenge for us. We are budgeted for 272 positions. We have a 12% vacancy rate. And of the 33 vacancies we have, 21 of those are nurses and mental health workers. We also identified recruitment and retention. At the time we presented last year, we had several what are called locum tenens providers that we had to use to fill gaps. There are a number of issues in depending on locum tenens providers. Not only is it extremely expensive, but you can have a loss of continuity with turnover of the locum tenens individuals. We also knew we needed to look at the compensation and benefits and how we were contracting with our staff. I am very, very pleased that as of today, we have no locum tenens providers at this time. 6 of the 6 physicians that we have here on staff are state employees. And while we continue to contract with our psychiatric nurse practitioners and 1 psychologist, we also have a master agreement in place for payroll services. So there's much more consistency in how we are working with those contracted employees or staff people. I pointed out that our beautiful building is old, and anyone who has an old home knows that there are always renovation projects to be done. Last year, we had identified the key ones as being the HVAC system, roof repairs, and enhancement of our bathrooms. This year in 2020, we finished the HVAC project. I'll talk about that a little bit more later. We have started with our roof renovations, prioritizing those areas most in need of repair, but we have deferred the bathrooms for the time being. Regulatory focus is something that all healthcare facilities must pay attention to. For us, that includes the Center for Medicare and Medicaid Services, or CMS, the Joint Commission, and various state agencies, including the Division of Licensing and Certification. This year, our regulatory inspections really were focused on our new unit. And also, as a result of COVID, CMS has issued a number of waivers. So we have also been focusing on those. And lastly, we talked about the electronic health record. We currently have a mixed model that is part electronic health record and part paper. It is very outdated. It is not efficient. There are a number of underlying problems with the current setup. In 2020, we went out to RFP, request for proposal, for vendors for electronic health records. That process was completed in December and a vendor was chosen. And at this point, we are in communication with the vendor about specific parts of the agreement and contract. And Dr. Potenza was very involved with this, so I wanted to have him speak to that.
Yeah, thank you so much, everybody. The key parts about this are matching efficiencies of business operations, obviously taking care of patients, with the efficiencies that an EMR can bring together. And so we had a very involved response from 4 different vendors vying for the RFP, and was awarded at the end of 2020. And we have now feel confident that we have a vendor partner to work with to help establish an EHR where we maximize our efficiencies and linearization of taking care of patients. And we're very thankful that the state allowed us to kind of participate in this. And I feel very confident about that.
One of the challenges that we faced in 2020, we did not know about in January of last year, and that is the pandemic. And a little later in the presentation, we'll talk about how we have operated within the pandemic. But I will say that I feel very good about our ability to have addressed most of the challenges that we identified last year, even in the midst of the pandemic. Next slide, please. So just to give you an overview, we have 3 inpatient units in the main hospital with 17 beds per unit, or a total of 51 available beds. In 2020, our average daily census was only 29. That's a 57% occupancy rate. And the factors impacting the census were really in 2 major areas. One is the pandemic that started back in March and continues to affect us today. This impacts our discharges, and our options for discharges are limited. We test all patients before they are admitted for COVID-19. We established an isolation unit, which, knock on wood, we have not had to use to date. And in December, we consolidated our 3 units into 2 as a result of an increase in the cases throughout the state and widespread community transmission, particularly in Penobscot County. The second major impact was our HVAC project. And this started in early May and ended in mid-September. I will tell you that the extended time of the project really had to do with COVID and limitations on supplies and materials and impact of staffing. But it did occur over the summer. It impacted all 3 units. The pipes run vertically through the units. It limited the number of admissions because we had to wall off sections of each unit in order for construction to occur simultaneously. It required additional staff to monitor construction and ensure the safety of our patients. And in the hottest summer on record, we had no air conditioning in patient rooms until the HVAC was fully installed in all 3 units. It is a great testament to the resiliency and flexibility and huge patience of our staff and the people and the patients we're serving that we got through this project intact. And we were very lucky. We did not have any safety issues related to the construction. Next slide, please. This is our census, our average census over calendar year 2020. And you can see graphically exactly what I'm talking about in terms of the impact of the census related to COVID, which started back in March and then was impacted again in May as we began the HVAC project. Going into September, we did see an increase in our census. And again, unfortunately, in December, we had to consolidate our 3 units into 2. The other thing that this graph shows is the breakdown of our civil and non-civil patients. And when I say non-civil, those are the individuals who are here and are involved in the justice system. So it may be jail holds, it may be transfers of 60-day evaluations, those found incompetent to stand trial, and we do have some not criminally responsible patients as well. This is always a very dynamic balance between the civil and the non-civil patients. The civil patients are those individuals mostly who are sitting in emergency departments throughout this area of the state. And we are very much committed to try and bring as many of those people in as possible. At the same time, there are imperatives related to the justice-involved individuals. Dr. Potenza, do you want to speak to this as well?
Yeah, I think you did it really good justice. The thing to add, of course, is that, you know, as the committee members notice, as you go left to right, the orange decreases and the blue increases for some of the reasons that Sarah just said. It's really important to note that of that, on the left part of the slide, that orange block represented 2 different sets of justice-involved people. People that were justice involved that had a penetration of mental illness that met hospital level of care. And some individuals who were by court order assigned to come to our state psychiatric facility that did not meet hospital level of care. So in the ensuing months, we worked really hard with correctional officials to work out possible community options for these individuals. So we could really find the appropriate level of care for these folks and not necessarily stigmatize them with an admission to a state hospital that they really did not need from a treatment perspective. And so you'll see the results that despite the pandemic and despite our HVAC inertia we had to overcome, the blue increased, so less people waiting in emergency rooms. The orange decreased, so less people who did not meet hospital level of care needing to be in a state hospital, still leaving the correctional facilities, but having a more community response for their treatment needs.
We have been working very closely with the State Forensic Service with the Commissioner's Office, with County Jail, the Penobscot County Jail, all to look at other options for those individuals who need to be evaluated. Are they incompetent to stand trial? So this is something that has gotten a lot of focus over the past year, and I think is moving in a great direction. Next slide, please. So I wanted to show you our admissions over the last 2 years, calendar year 19 and 20. And as you can see, the trend line is dipping down for the reasons that we discussed. Next slide. And these are our discharges over that same period of time. And while the trend line does move downward slightly, I was really amazed at our ability to continue to discharge as many people as we did throughout the pandemic. Our social work staff, our discharge planning group have been very effective in finding appropriate placements for our patients, even within the pandemic. That being said, it's a challenge, particularly when there are outbreaks, COVID outbreaks in group homes or in nursing homes and some of the assisted apartments that we discharge our patients to. Next slide. And this is our average length of stay. And you can see that that is definitely a downward trend, and that is great. As I mentioned when we talked about our mission and vision, we want people to get back to their lives, to be as autonomous as possible, and to be in the least restrictive environment. And that means the ability to treat them and have them return to the community as soon as possible. So our focus has been on decreasing our length of stay. Dr. Potenza, do you want to talk a little bit about what we've been doing in that regard?
Yeah, there's two major things to point out here, I believe, that would interest the committee. One is that in order to all other things that remain the same, the way to decrease length of stay is to increase treatment efficiency. So as Sarah said, getting people back to their houses and getting back to a lesser level of care, which is our mission. The other thing to point out is that the decreased length of stay means that you serve more people. Those beds turn faster. You're able to serve your citizens much better and much more efficiently. And they're more willing to come into a hospitalized setting if they know they're going to get out quicker and be able to return to their families. So it's really a win-win. And given the challenges that we had with HVAC and the pandemic, the one thing that we had under our control, under our collective roof, if you will, even if it's an old roof, as Sarah pointed out, is the fact that we could do this. And so this represents a ton of work on all of our staff.
And although I did not provide this, I will share with you that we have not had any 30-day readmissions, at least during the time that I have been here. So that is something that we are required to track. And although we have had some people return, it has not been within 30 days. So we know we're being effective in providing good discharge planning. Next slide, please. So we come to COVID-19. Back in February, we began to prepare for the pandemic. And in early March, we implemented our hospital incident command system. This is part of our emergency preparedness and our pandemic plan, both of which existed prior to the pandemic. So we were very fortunate. I felt very fortunate to come into an organization that had already put a lot of thought into emergency preparedness. Our PPE inventory was really quite robust, even at the beginning of the pandemic, in part because the hospital has had a very active emergency preparedness plan. We started screening all of our staff, and we continue to do that. Staff answer questions about whether they have certain symptoms, have they traveled, do they have or have they had contact with a COVID positive individual. We take temperatures and we do pulse oximetry checks every day, every shift. And anyone who does screen out either through the questions or through the temp or oxygen level is assessed by our employee health nurse or one of our nurse supervisors to determine if they can continue to work or whether they need to go home. All of our staff mask. This is something that we are very strict about because it is effective. And our patients are asked to mask if they leave the unit. We have been minimizing cross-unit traffic. Staff are assigned to a specific unit. So just like you talk about our homes being our bubbles, each of our units within the hospital is a bubble. The group therapy sessions, diversionary actions are all unit specific. Now this has been tough for our staff. It's not ideal, but it is something that we have committed to do in order to keep our patients safe. I mentioned COVID-19 testing prior to admissions. So all patients must have a COVID-19 test before they're admitted. And early on, we stopped having visitors to the hospital. Our patients have access to electronic communication platforms and telephones, and throughout the summer and into the fall, we did allow outside visits with family and friends, with everybody masked and distancing, social distancing, which was a great thing for our patients to have that option. Next slide, please. We have limited our community visits for our patients to medical appointments. All of our meetings now within the hospital are conducted via Teams, so we no longer sit around conference rooms and communicate that way. We have consolidated to 2 units, as I mentioned before. We have had 2 cases of positive staff, one in November and one in December. And we conducted the close contact tracing. We tested the close contacts, and fortunately, this did not lead in either case to an outbreak, which is defined by the CDC as 3 or more individuals COVID positive. We've been extremely, extremely fortunate to be given Moderna vaccine, and we have administered that vaccine to 184 staff members who are involved in patient care. This was voluntary, so we did not mandate that staff had to get that, but we certainly have encouraged it because it will make a big difference for us if we can get our staff vaccinated. Next slide, please. The other big thing that we did this year is we opened our new geropsychiatric unit, which we are calling the Annex in absence of a more creative name. But this is a picture of the building. We're very proud of it. It's been a long time coming, and so I wanted to share this picture with you. Next slide, please. I also wanted to share a couple other pictures. Each of the patient rooms, each patient has a separate room. And you can see that we've tried to make it colorful and friendly and warm. We have 2 murals, one on either side of the corridors. So it serves 2 purposes. One, it's very welcoming. But secondly, I'm on this, I'm on the ocean side or I'm on the mountain side. So it helps people with direction finding. And the other picture is just one of our common rooms, our group rooms. Next slide, please. So the annex was designed to care for older patients who have a primary diagnosis of severe persistent mental illness. Oftentimes, these patients have a number of underlying medical conditions. They are often on multiple medications and may have some neurocognitive deficits. So our staff have received training specifically for this population. Referrals come to the main hospital, just as they do for our other units, to determine if the patient meets criteria for admission. We have a great team. We have a full-time nurse practitioner who's duly boarded in psychiatry and family medicine, who has extensive experience in outpatient geropsychiatry. We have a half-time psychiatrist. We have psychologists, nurses, mental health workers, occupational therapists, and social workers who support the annex. Our first patients were transferred from the main hospital on the 4th of January. So 6 people we were already treating met criteria for the new unit and were transferred there. There are 17 single patient rooms. We have a pharmacy on site. We have treatment rooms. We have conference and group rooms. There's a dining and common area, and we have a lovely fenced-in yard with a gazebo. Food services, environmental services, and facilities maintenance are provided by the main hospital. And I would say that the most complicated part of this is the distribution of food, which goes 3 times a day. We have a special transit van, and our food services manager has done a fabulous job in developing processes that ensures that we keep the hot food hot and the cold food cold. And we do make those temperature checks every shift, every time it's delivered. Next slide, please. So what are our goals for 2021? One of my first goals is to open up the unit that we closed down here in the main hospital. And we want to have a census of 15 for each of our 4 units. This will mean doubling our census over 2020. We are using data more to help drive our operations. Every day at morning report, we look at our admissions, our discharges, our length of stay, who's coming in, who's going out, with our team. So the nurse managers, the nurse supervisors, and everybody who's involved in that process. We are reviewing and revising our processes in preparation for implementation of the electronic health record. Having gone through implementation of in EMR and EHR, I can tell you that broken processes are not fixed. They are made worse by an EMR. So really understanding what our processes are and looking at that, and as Dr. Potenza said, looking at it in terms of the EMR is really important. We want to contract with more commercial insurance carriers. We will continue to focus on our regulatory compliance and survey readiness. And as Molly mentioned, my past experience has been with the Division of Licensing and Certification, so it's a subject near and dear to my heart. And we will continue to focus on patient safety, staff satisfaction, and becoming an employer of choice. Dr. Potenza, did you have anything you wanted to add? I'm sorry, I probably monopolized this.
No, not at all. Please monopolize ahead. I mean, I'm so happy to hear, everything in its entirety. I mean, the one thing I'll add really quickly, sorry, of course, Sarah knows I don't like to shut up too well, so I'm going to do my best, is that, when you encumber the idea of opening up a new unit and you have to figure out who you're going to treat and why, opening up a unit and choosing it for geropsychiatric patients allows us to really treat folks that we could never treat before. We had so many people that we had to leave at the doorstep, so to speak, because we could not put more frail elderly folks with mental illness in our more robust inpatient units. And it was heartbreaking at times. And the times we did it, it changed the whole characteristics of the milieu and made things somewhat difficult. It is a bit paradoxical. I mean, we did have this unit in our newest building, although it does serve our oldest patients. But that being said, our ability to do this allows us to treat more people in a way that's much more definitive. And, you know, as we were making the decisions and we looked at the of individuals in each of the 50 states, we noticed that one state actually had the highest average age of all of them, and it just happened to be Maine. So that kind of forestall our decisions. So, thank you.
And that concludes our presentation, and we appreciate the opportunity to share this with you.
Well, thank you, Superintendent Taylor and Dr. Potenza. I'll ask the committee if there are any questions. Use your raise hand function, and I will. I see that Senator Baldacci has joined us and may have a question. So please introduce yourself and ask your question.
Thank you, Madam Chair. Joe Baldacci. I'm from District 9, which is Bangor and Herman. I just want to thank Dr. Potenza and Superintendent Taylor for excellent presentation. Being on the City Council, I've had a long history of dealings with Dorothea Dix. It's been a huge asset to the community. Its closure would have put a huge burden on the area around Bangor. And it serves, how many people in the course of a year pre-COVID were you serving? Was it over 100 people in the course of a year?
Yes, yeah, just about.
Okay. And they are primarily from Eastern and Northern Maine?
Correct.
Right. And I just, and Acadia, which is a great resource as well, having dealt with in the court system, they keep people for a period of time and then they bring them to Dorothea Dix. Isn't that correct?
That is correct. For those people who need a lengthier hospitalization, we really are the site for that.
Right. I just think it's important for people to know that it's a critical part of the area or regional healthcare system. And I applaud what you're doing in terms of increasing the census. I think that will help. It takes patients from all over the state, but the predominance are people north of Augusta, is my understanding. So, but I think your plans are great, and I just want to indicate I'm a big supporter, and I look forward to working with you folks. Thank you.
Thank you so much, Senator.
And Senator Moore.
Yes, thank you very much. I was very pleased to have your presentation, and I'm so excited about the annex. I think that's a great opportunity. I'm just curious, I'm always asking this question. What is your definition of older? What is the age?
Well, we are vague for a reason for that. Dr. Potenza and I have said, you know, we'll have rooms down there soon. It really, and I don't mean to make light of this, but we try not to have a specific age limitation because it really depends more on the patient. You know, you have some people who may be in their 70s and they're very vital and energetic. They have few underlying medical conditions, or you may have somebody in their 50s who, for whatever reason, would benefit more from that environment. So that's why we have not had a specific age cutoff.
Thank you.
Dr. Potenza, would you?
I wouldn't dare. It's a great question, Senator, though.
And Representative Perry.
Thank you. First of all, I'm just so impressed with all of the work that's been done on the building. We had an opportunity gosh, I think it must have been 3 or 4 years ago, to go through Dorothea Dix and all the work you were doing then, which I was amazing to see how well you were able to manage patient care with all of the construction work and everything going on. I'm hoping someday we, things probably have to calm down in terms of COVID, we'd have a chance to take a tour of the facility again. I have 2 questions, actually. One may not be a question. One is, you've got construction going on, but you're also going to be adding an EHR, which is truly, truly going to affect the functioning that you're doing while going through this. You've gotten good with construction. How long and how are you planning to institute the EHR and keep things functioning as you can? That's number 1 question. The second question may relate to Senator Moore's question about age, but I'm really delighted as a provider who has struggled to find places for some of my elder who have mental health problems plus dementia, and not being able to find a place to place them. So I'm delighted that this unit is opening. I'm assuming that that's going to be the major part that you work with. So thank you for that. But my question is about the EHR.
So with the EHR, we're going to plan, do. Planning is so important. And I would rather take a longer time to ensure that our staff understand and are comfortable with the EHR. But then I'm going to kick the question to Dr. Potenza because he's going to be very involved in this.
So you are so right to ask the question, because the worst mistake possible is to continue all the same old business processes and superimpose an EHR on top of it. The whole idea, of course, of an EHR, as you are so stealthily implying, is, which I really appreciate, is that it gets you a way of opening up everything. It's what the EHR can do for you, not what you could do for the EHR, as I always say, to not misquote JFK, but it's a very important concept, but that is the qualitative area that we can kind of work on. But you're right, and I can expand on that, but I would bore the rest of the committee, but it was a great question.
And with regard to your second question, yes, we have seen, we do treat older individuals who have some neurocognitive deficits. And the only thing I would say is the primary diagnosis must be psychiatric. So we are not a memory care unit. We are in no way a nursing home. These are shorter stays, relatively speaking. But one of the challenges we find with those individuals who have both a mental illness and neurocognitive issues is placement for them. Because there are institutions who say, great, we'll take your older patients who have psychiatric problems, but we're not ready to take the people with dementia. And we have memory care units who say, great, we'll take care of your individuals with dementia, but we don't want those, psychiatric patients. So that's part of our challenge, is to be able to work with post-discharge facilities, placement facilities. So they know that, number one, they're not on their own, they're not alone, that we're there to support them. And I really hope that we can have those types of relationships where it's a matter of, I have a patient, I have a resident, they need to be assessed, they maybe need a little top up or medication changes, but then then the facility wants them back, because these are the homes of these residents. So it's going to be challenging. but we've been treating these patients already. This just gives us a better opportunity to do it very, very well.
Senator Claxton.
As somebody who has been the point person in my hospital for several EMR rollouts and minor upgrades and changes, I want to express my sympathy and offer to be part of your support group if you put one together. There is another side of that you can get to where you begin to realize those advantages, but I couldn't help going there. I still, I'm getting treatment for my PTSD, but I'm better. The one thing I did learn though in that whole process that I want to share is that Thursday is a great day for a launch. That gives you 2 days where you can mess up, and then 2 days to be more likely to recover, as opposed to starting on Monday when you have 5 days to really mess up and only 2 days to recover. So I pass that on for what it's worth. My specific questions were, are there things that you've done related to COVID that may become part of your standard operating procedure down the road? And I think that's an opportunity. You talk about opening doors and opportunities. That's one. And did the patients get vaccinated? I understood the staff did. So I just wanted to be clear about that. And then I want to understand better what the interface is between Dorothea Dix and the district court process and how that impacts you all.
Okay, so let me see if I can unpack that. And thank you for the offer for support, because I think we'll probably need it in terms of our EHR. Remind me what the first question was. I'm sorry.
Changes post-COVID, what would you keep as part of standard operating procedure?
Yes. What is it that Churchill said? There's don't waste a good crisis or something like that. And we have found that a lot of what we've been dealing with COVID, we will continue. We have found different ways, new ways of doing things. I'm going to kick this to Dr. Potenza because it's something that he and I have talked about a lot through this process.
So, like everywhere, and in the spirit of Winston Churchill, when you get a crisis, it causes you to really dig deep. What exactly we need to do? What are the things we don't need to do? What contributes to our decrease in length of stay, for example, as we saw on the previous slide? And what are the things that actually are just noise and don't do that? And during the processes, as we created our separate pods to decrease contagion, we noticed certain treatment interventions that didn't have the bang per buck that we wanted them to, that we kind of got lost in our whole treatment matrix. And as we identified and linearized things away, we were left with a core systematic way of addressing folks that came to us. And it allows us to slowly decrease their length of stay, despite of COVID, despite of discharge difficulties in placement because of contagion. And I can lay some of those out for you. They're actually fascinating to me. Which groups are more efficient, how many touches in the beginning of a hospitalization end up prioritizing and decreasing length of stay as opposed to a middle or the end part of it. And what are those touches? Are they individual? Are they group? How aggressive are you with pharmacology? Things like that. And we have been studying this very intently. And finally, we don't have locum tenens. We have a number of staff, including a number of psychiatrists, board certified, who have come specifically to Maine to work here with us. And so when you have that group working together and you all pull on the same rope, you can't help but develop the kind of efficiencies and partnership that you can only dream of having. And I can be more mechanical with my answer if that would be helpful too, about exactly what we did, but that's the spirit.
And it was in the spirit of that I was asking, not for the in the weeds. And I really appreciate that. That's a great opportunity and that you've taken advantage of it. The other thing that Churchill says is that if you're going through hell, keep going. So my other question was,
I have to remember that.
my other question was how you interface with district courts.
Yeah, so that's a good question. And as I mentioned, we have been working with state forensic services and the local jails and the commissioner's office to really kind of help people change their way of thinking that the state hospitals are not the only option for individuals who need to be assessed or evaluated. And as Dr. Potenza pointed out, it doesn't matter whether you come to us through an ED or a jail or from Acadia. It matters that we have the ability to help you as a patient. If somebody has a mental illness, we want to help them. If they don't, and some of the people who have been sent to us in the past do not meet what's known as the criteria, medically necessary criteria. It is not, a state psychiatric hospital is not necessarily a better place for some individuals than the jail. In fact, we have had a number of people who have been admitted here and within the first day or two say, send me back to jail. I don't want to be here with a bunch of crazy people. I mean, literally that's a quote. So I know the state forensic service would like to have a mental health docket. And this is just a work in progress for us. Dr. Potenza?
You answered most of that. I don't want to bore the committee. The issue at hand is making sure that we work with our community resources to make sure that folks that are incarcerated and not getting psychiatric treatment get the right kind of treatment at the right level. And we have competing agendas, Senator, of course. We have the court order, which delivers them somewhere within the treatment continuum. And we have the competing agenda of admitting folks that require hospital level of care and would do really poorly anywhere else, including in an emergency room. And when you go to that prior graph that we showed, our efforts have changed those colors around on purpose. It does have to upstream to the district court. You're absolutely correct to ask that question with that implication in mind. The procedures in district court to help look at the full use of the legal instrument that delivers them to the treatment continuum continually can use some refining with those things in mind. But so that's my best kind of reflection of that. Sorry to drone on.
Thank you for that. Thank you both.
Yes, seeing no further, actually, Representative Lemelin has his hand up. Representative?
Yes, thank you for being there. This is very much needed in the area, and I'm so glad you're there. And it sounds like you're doing a fantastic job, and I love it. I just have one quick question about the EHR. This has not been implemented yet, correct?
Correct.
Okay. And what's the cost of the new EHR?
So part of this is funded through CMS. Our portion, I believe, is $300,000, as is Riverview's. I can't tell you exactly how much it costs, but we are able to do this in part because we are getting federal support for implementing it.
Okay, and lost my second question, so I'll have to bow out. I'm glad you're getting the EHR, and I know you need it badly. So, but like Dr. Claxton said, it's sorry, Senator Claxton, It's tough to deal with at first.
Yes, and it is going to be going through hell and keep going, I think. So hopefully next year we'll have some good news on that front for you.
It gets better with time.
Yeah, it does.
Okay, so we want to thank you once again for joining us today and for the excellent work that you're doing up in Bangor.
Thank you very, very much.
Thank you. Bye-bye.
And we will turn it over to Molly Bogart for her presentation.
Great. I'll introduce myself again. I, do this for the stream, not to patronize you, but I'm Molly Bogart, Director of Government Relations for the department. And I just want to take a few minutes to walk you. Please excuse my geriatric cat. She's very lovely, but I might be sending her to the annex soon. She's just loud. So I wanted to take an opportunity to walk you through the briefing book very briefly and show you some resources on our website that may be of interest to you and constituents. And so I will do that. I really, want this to be of use to you. So feel free to stop me and ask questions or redirect me if there's something else that you'd like us to focus on. But briefly, I'm going to share my screen with the briefing book here. Okay, so this was sent to you all a few, maybe weeks ago now, if not days. And I'm not going to walk you through all of it. It's quite long, but largely I wanted to make sure that you were aware of some of the items that we've put in here that hopefully will be of use to you and your constituents. So obviously the table of contents will walk you through that. But first, here is a map of all of our office locations. And I think the commissioner noted our most recent addition is Calais. And we have, I believe, 16 offices in total across the state, as well as we have some locations specifically in Piscataquis County where we have folks from our offices in non-COVID times.
Sorry to interrupt, Molly. Could you enlarge the print thing?
Yeah, let me.
Thank you.
Yeah. So here's the list of our offices. And we do have some locations that we send staff to, even though we don't have a permanent office. If you ever have questions about where the closest office to you or the best place for your constituents to be served, don't hesitate to reach out to me. And then each office has a section in the briefing book that walks you through all of the programs in even more detail in many cases than what you've heard in the orientations. I will leave it at that, but encourage you to look through those. And if you ever have questions or concerns, feel free to reach out to me for more information. And then the last item I wanted to show you in this briefing book is the last page, and that is, excuse me while I zoom here, resources for constituents. So the top here is crisis numbers and hotlines across the spectrum. We've got mental health, as well as child protective, adult protective. Paul Saucier spoke about the crisis services for adults with intellectual and developmental disabilities, as well as domestic violence, sexual assault, and the Poison Control Center. And then below those, we have specific resources for substance use and additional resources. And that is where constituents can find information about accessing the services that Tony spoke about in OFI, Main Care, SNAP, TANF, as well as get their question, if they're covered with Main Care, get questions about what services are covered and what they may need to do to access them, hear about or apply for the WIC program and find their local office, And we've also included the Consumers for Affordable Healthcare Consumer Assistance Helpline. So especially for folks who are in the income bracket that's near the edge of main care eligibility, they maybe need to explore both private and private insurance and main care consumers for affordable healthcare, which you, I'm sure here as CAKE, often operates an assistance helpline that can be really critical for constituents who are looking at their coverage options. And then we also contract with 211 Maine, and Dr. Pollard, that's through the Office of Behavioral Health. Dr. Pollard will talk about that a little bit more this afternoon, but it's a great resource if it's sort of the no wrong door of resources around social services. So from, you know, heating services to mental or heating assistance to mental health services, 211 can help provide information and referral services for your constituents. And so we certainly encourage folks to reach out to them if they're feeling at a loss for where to go. So those are the few things I wanted to point out in the briefing book. As folks are going through, is there any questions that have come up or additional information that would be helpful? Great. And then what I will do is show
Molly, it looks like Representative Zager has a hand up.
Apologies.
Thank you, Madam Chair. And I often get the question about access to counseling for, especially for opioid use disorder. I recognize there's a shortage statewide, but does DHHS have a resource for that to connect people to, that kind of care?
Yeah, I think 211 would be a great place to start if someone is looking for that kind of counseling service in their area. But you should ask that question to Dr. Pollard this afternoon. She may have some more thoughts about the appropriate place to go there. I know we work a lot with both peer support and certified counselors for opioid use disorder, and 211 will get you there, but there may be a more direct line that she can offer.
Thank you.
Yeah.
Appreciate it.
Great.
So if there are no further questions, we are awaiting the arrival of Superintendent Buffard and his team from Riverview. So I'm not seeing them here yet. So perhaps we can take a 5-minute break and circle back. So it is 5 to 11, and we'll see you at 11. Looks like we've got some of the Riverview team coming in. Don't see the superintendent yet. Go ahead, Molly.
I think they were scheduled for 11:15, so I'm sure they're
Okay.
right around the corner.
Perhaps our analysts have anything for us at this time while we're waiting for Riverview's team?
Not really.
Okay, just checking in. So we'll give it a few minutes.
Representative Meyer, I can show folks some of the data dashboards and things we've added to our website. If folks
Please
are
do. Please do.
Great. Well, I will share my screen here. And for those of you who have been on the committee or in the legislature, you may know that we redesigned our website last year, and we're continuing to work on a handful of the sort of sub sites in the large department, but most of our websites have been updated to hopefully streamline and provide more information that is of interest and make it more easily accessible. But another focus that we've had, why don't I show you this first? This is our homepage, and right up here you can choose offices and divisions, and that will show you a resource to get you to any of our 9 offices that you've been hearing from. So seven offices and 2 hospitals. But what I really want to show you is some of the data that we've been pulling together. You may be familiar with the COVID-19 data dashboard that the CDC produces and updates daily. That is here within the CDC's website and has just a trove of information broken down along a number of different metrics and can give you a good sense of where the state is in our COVID-19 response. Additionally, the CDC, along with the governor's office, has posted this vaccine website to answer questions about vaccinations, keep folks posted on what who we've been able to vaccinate, and answer those frequently asked questions. And so we have a breakdown of the phases that are available with more detailed descriptions if you are interested, as well as frequently asked questions, facts about the vaccine, additional updates. This is where you can find our weekly distribution and where those have gone, and then also information for healthcare providers down here. And just the other day, we posted a vaccination dashboard. So this provides you with some more detailed information on vaccination across the state. This will be updated periodically. It is current as of yesterday and provides breakdowns by gender, age group, race and ethnicity, and also will show you where our vaccination rates per 100,000 are highest. And you can see right now that's Cumberland County, Aroostook County, as well as Penobscot County. And perhaps, no, that's all of Penobscot. I would fail my 7th grade geography class here, not knowing if that was all Penobscot or not, but this can provide you with some good information to keep you updated on our.
That is all of Penobscot, Molly.
It is.
Yeah.
Very I just had to
I
hover.
just
over.
want to make sure I correct it.
Thank
make sure
you.
Penobscot was correctly identified.
Yes. Yes.
Thank you.
Thank you. Thank you. And then, in addition to COVID information, we've been focusing on making a lot more of our data accessible to folks. And so the Office of Child and Family Services has developed what they call their key measures dashboard. And that's a number of metrics across child welfare, children's behavioral health, and early childhood education. And within each of those, there are a number of metrics. So for children's behavioral health, we have number of children receiving evidence-based services, number of children on wait lists, and the average day that they're on those days that they're on those wait lists, as well as residential treatment service numbers. And for each of these, you can choose the time frame, as well as dig down into some of the specific services or service types. For child welfare, we have safety in foster care, and there's always more information here about what those definitions are. And so safety in while in care, means that there have been no instances of victimization. And so that will break down across counties. We'll also have permanency for 12 months, success in permanency. So ensuring that permanency is does not result in children coming back into care. Removals following a closed assessment, as well as the number of children in state custody. And then in early childhood education, we have numbers of providers that are high quality care, our quality rating step levels, numbers of children served by child subsidy program, child care subsidy program, and the number of licensed providers. And I'm moving pretty quickly through these, but I know that these will be of interest to you all as we dig into these different policy areas and address bills that come before you. All right. I think those are the dashboards that I wanted to show you. We also have a dashboard that walks you through the impact of COVID on department services, but I can share that at a later date because I see our Riverview team is with us. So would you like me to jump right into that, Representative?
Yep, please introduce Superintendent Bouffard of Riverview and his team. Thank you, Molly.
Great, no problem. So I'll introduce Rod. He is our superintendent at Riverview and has been there for a few years, has a long history with the state. Rod, in my mind, is really the turnaround guy. He has been with a number of facilities and providers across the state and really does an incredible job bringing teams together, increasing quality of care and staff. And so I'll ask Rod to introduce his staff that's with him today. There's a really incredible team approach that is taken at Riverview. And so we're happy to have a number of his folks with us to talk about the services they provide.
Molly, you can hear me okay?
Yes.
Good. It's always helpful. Anyway, What I'll do is I'll introduce my folks as we go along, and they'll do a very brief presentation on various areas of the hospital. And, you know, first of all, Senator Claxton, Representative Myers, distinguished members of the committee. Obviously, my name is Rod Buffard. I'm the superintendent. And I would like to thank you all for allowing us the opportunity to provide an overview of the Riverview Psychiatric Center. Riverview is a 92-bed hospital. We have 4 inpatient treatment units that provide acute level of care, treatment, observation, and recovery. The 4 inpatient units. Go ahead, I'll wait a minute.
There we go.
Yeah.
Had to catch up with you, sorry.
Yeah, I'm just jumping right in because I'm going to give some other people an opportunity to speak. So the 4 inpatient units, like I said, provide an acute level of care, treatment, observation, recovery. The hospital is really broken down into 2 distinct sections. One section is 2 units, 48 beds, provides or is reserved for folks with that are civilly committed. The other section is 2 units, 44 beds, broken down for individuals who are legal holds. We also have a dental clinic that provides services to all the patients in the hospital and roughly 2,000 patients in the community with mental illness and or developmental disabilities. In addition to that, we have an outpatient clinic in the Augusta area that provides oversight and treatment to roughly 63 individuals living in the community that are NCR or not criminally responsible. We can talk about that a little later. That outpatient clinic continues to grow. About 3 years ago, we had 40 patients there. Obviously, today we have 63, and we fully expect that the services there will continue to develop. Our mission is to provide state-of-the-art care for folks with serious persistent mental illness. Our vision is to collaborate with the community and become a center of excellence for treatment, education, research for individuals with serious persistent mental illness. Our values are respect, patient first, caring, and compassion. Now, one of the things that is said here quite frequently is we always want to do the right thing. And I'm fortunate to be working with a group of people that their focus is truly on doing the right thing and the right thing for the patients. And we always want to make sure that we're treating the patients here just like they're one of our family. So with that, I'll go to the organizational chart. And I'm going to let the organizational chart speak for itself. It's pretty busy. But what I'm going to do is introduce folks as we go along through the presentation. So the first person I'd like to introduce is Amy Brown. She's the Director of Quality Assurance, and I'm going to ask her to speak about regulatory compliance. Amy, are you on?
I'm here. I'm sorry, I was just on mute. So Riverview continues to hold active licensure with the state, certification with CMS, and accreditation with the Joint Commission. Our last survey with CMS had no deficiencies cited. We're due for our next Joint Commission in 2022 and state licensure in 2022 as well.
Okay, so the next person I would like to introduce is Dr. Matt Davis. And we're incredibly fortunate to have somebody of Dr. Davis's caliber. This year, he was awarded the status of Distinguished Fellow from the American Psychiatric Association. Only 2 people in this state were recognized at that level, and it is the highest level that you can achieve as a psychiatrist. So again, we're incredibly fortunate to have Dr. Davis with us, and Dr. Davis is going to speak to some of our accomplishments and demographics. Dr. Davis?
Well, thanks for that very kind introduction, Rod. Good morning, committee members. Thank you for taking the time to meet with us and learn some about Riverview Psychiatric Center. 2020 was a year of considerable accomplishment for us. I'm proud to share some of the major highlights with you all. this morning. I'll talk some about what we've been able to accomplish in terms of containing COVID within the hospital. I'll get to that in just a moment. Before I get there, I want to talk with you about some of our other major focuses and achievements within the hospital. One of our major areas of focus has been on better treating aggression and violence. That's been a major issue, not just for psychiatric hospitals and facilities within Maine, but really throughout the country. And we've taken considerable steps to get a better handle on this. One of the things that we've done is begun a collaboration with a team of experts in California through their state psychiatric hospital system, which cares for over 6,000 patients throughout the state at 6 different facilities. We meet with them monthly for a clinical case conference in which we discuss particularly challenging patients. We learn a lot from them, but we also have been able to share some of our own accomplishments and some of the particularly challenging patients that we've been able to help get through Riverview and wind up back in the community where they've been able to maintain stability and do really well. We've also begun a collaboration with Dr. James Kennedy over the past couple of months. He is one of the gurus in psychiatric treatment planning, and he and I and some others throughout the world are collaborating on developing instruments to better detect and prevent violence and aggression, and in individuals who are prone at times to engage in aggressive behaviors, to more specifically characterize the types of aggression and violence that they're at risk for, and what we can do to target treatment and interventions for these specific types of aggression that we're characterizing. I'm really excited about where that project is going. And I'm hoping that we can ultimately wind up publishing our results on this. Dr. Kennedy has published some psychiatric treatment planning manuals in the past, and we're discussing actually based on our own experiences here and at the other facilities we're collaborating with, developing tools that can be used and disseminated throughout the world, frankly. We've also joined the Harbor Performance Initiative, which is a consortium of psychiatric hospitals, state hospitals, specialty psychiatric hospitals, and psychiatric units throughout the country. Interestingly, it was actually begun through the team at Spring Harbor Hospital in Portland, which is a specialty psychiatric hospital, and has expanded throughout the country over the past few years. And this really gives us an opportunity to collaborate with similar facilities throughout the country to ensure that we are participating in best practices, and also to share our own success stories and our own things that we've been able to accomplish and do really well with. This has been really beneficial during the COVID pandemic because things change so quickly, and to some extent we're learning as we go. But that's not just the case here at Riverview, that's the case everywhere. And one other accomplishment I think is worth noting is we had a publication in a quality improvement journal pertaining to our efforts at monitoring patients who are at risk for developing serious side effects from some of the treatments that we use. Some of the medications that we use that are very effective for treating individuals with psychotic disorders, unfortunately, have side effects such as causing considerable weight gain, causing problems with diabetes and cholesterol and other various issues. And through a collaboration between the medical staff, nursing staff, pharmacy, and quality improvement departments, we've been able to achieve considerable improvement and progress with how we monitor and intervene in those cases, such that we were able to actually publish what we've done in a journal last May. The last thing I wanted to highlight in this section is we've also entered into a work group, a national work group that is contracted with CMS to look at quality performance metrics for inpatient psychiatric units. And we are reviewing measures that are coming out over the next several years because the expertise that we have and sharing our own input into which measures make sense, how we may further refine these measures. If we can move on to the next slide, please, Molly. As I said earlier, just to briefly mention on what we've done in terms of accomplishments regarding COVID, we've tested nearly 200 staff and patients during 2020, and I'm very pleased to report that through the various mitigation strategies that we've implemented, we've been able to not have a single patient contract COVID throughout the facility, which is really a testament to the entire staff here. And we've taken COVID really seriously. We've learned from other institutions in terms of what's worked and maybe what hasn't worked so well. But given the patient population that we have, it's important to note that many of the individuals who are getting treatment here and who live here don't just suffer from serious mental illness, they also have significant medical comorbidities, and they're at considerable risk for developing serious complications from COVID. I'm proud to tell you, as I said, that we have not had a single case in a patient. A couple of other things that I'd like to focus on are some of our facilities improvements. We were able to build a seclusion room in the Upper Kennebec unit that is used for patients who are in acute crisis. And really what that ultimately allows us to do is to increase our admissions here. Upper Kennebec formerly did not have this type of treatment room, and that hampered our ability to some extent to take some admissions, as they could only go to 2 of the other units within the hospital. We have also replaced a couple of sections of roof. We've made a number of changes within the hospital to make the treatment areas and the areas where patients reside safer, to eliminate what are called ligature risks, which are basically anything that can be utilized to that an individual can utilize to attempt to hang themselves. And that has been a major focus of CMS, because actually in-hospital suicides are really a significant issue, and a major way that patients complete suicide is by hanging. And so we've taken that measure head on, and we've really eliminated all of our ligature risks. Lastly, we are working to implement a new electronic health record. Cerner was awarded the contract, and we're going to be working with them to implement that soon. It will be a major upgrade for this facility, as our current medical records a bit lagging. And last, I wanted to highlight on this is that CMS awarded the department funding through an advanced planning document to support the integration of this new EMR. And we're the first and only facility, to my knowledge, state facility that's been awarded this type of funding from CMS. If we can move on to the next slide, in interest of time, I'm going to go over these next few slides relatively quickly, because there are some other parts of the presentation that I want folks to have an opportunity to get to. You can see that our admissions from 2020 were lower than in 2019, but I did want to highlight a couple of things. 2019 actually saw Riverview have the most admissions in its history, and we were on pace through the first or second week of March of 2020 to have even more admissions than we did in 2019. And then of course, COVID hit, and we had to make a number of changes within the facility in terms of having an admissions unit, a quarantine unit, that curtailed our ability to have the same number of admissions that we had in 2019. Our full expectation is that once we're on the other side of this pandemic, that we will ramp up our admissions again. We have an excellent medical staff, and I have no doubt that we will be able to get back to that pace, to frankly outstrip that pace. Nonetheless, after the initial few months when we were dealing with the COVID pandemic, and you can see really in March, April, and May when our admissions were the lowest, we were able to amp up our admissions again throughout most of the rest of 2020. And I'd say it's a fairly similar story with discharges, I really want to credit our social work department in particular, because even though various community resources were difficult to access, and there was some degree of stasis for patients throughout the entire system, our team was able to keep patients moving forward and getting them into the community, which is really beyond safety, our first and foremost goal here. If we can move on to the next slide, the median length of stay, you can see overall, it was a little bit higher during the earlier portions of the pandemic in the spring and early summer, and then it started to dip back down again through the later part of the year. And our goal was to have our median and average length of stay be pretty consistent with average national averages for facilities like ourselves. And I think that we've made considerable progress with that. And again, once we're on the other side of the pandemic, I have no doubt that we will achieve those benchmarks. And similar for inpatient days and average daily census, the data speaks for itself. I'm happy to answer any questions at the conclusion, and thank you very much for giving me the opportunity to present to you today. Oh, and you can see some other data here just in terms of our admission locations. Sorry, Molly. The various different entities that we've accepted patients from throughout the state. We've actually done a number of admissions in 2020 straight from the emergency room, which is great because it means that patients are able to begin treatment far more quickly than if they were, of course, to languish in the emergency room. Still an issue that I think can have some further improvements, but I'm glad to say that we've been able to meet some of those patients where they've been at in the ED. We've also taken patients, as you can see on the next slide, from every county jail throughout the state, as well as the MCC and the IMHU and the prison. And last, I think, my last slide is on admitting diagnoses. Our most common admitting diagnosis is schizoaffective disorder, bipolar type, which very briefly is common psychiatric condition in this setting in which patients suffer from psychotic symptoms as well as significant mood symptoms. Second most common diagnosis is schizophrenia, and third is bipolar disorder. Again, happy to answer any questions at the conclusion of this presentation. Thank you.
I think you might be muted, Rod.
The next person I'd like to introduce is Jen Gagnon. She's a hospital finance manager. Jen, you want to take
Hi,
us through?
everyone. So we wanted to go over a couple of slides of finance. I think that's always worth discussing and always of interest of people. And I'll try to keep a higher level, although being an accountant, sometimes I enjoy getting down into the weeds. So the first part that we wanted to bring up and show you guys was just overall the expenditures by fund type. So disproportionate share, which is 40% of our expenditures, is the federal money that we receive as a state hospital. The other piece of that is general fund. We get that in a couple of different ways. We get it in our match portion, which is the match to the federal share, and then we get it as regular, what we call regular general fund. Small piece of that is reimbursement, which is the other side, the other chart that you see. As we stated, we got recertified in February of 2019. That allowed us to start being able to bill for our inpatients for Medicare and Medicaid and other insurances. And you can see a very drastic difference from 2018, 19, and then to 20. 20 is a little bit deceiving, I will say, simply because due to us being recertified in February 2019, we kind of had to start the recertification process. The reimbursement process. And it took us a few months to get going. And so we, 2020 has a little bit of a catch up, but you can see that we had 3.9 million that we brought in, which is wonderful to us. Again, as Dr. Davis has mentioned, and we all know, COVID took a little bit of hit for us so far in state fiscal year 21. State fiscal year 21, we're at about 1.2 million that we've received. And if you do the quick math, being halfway through the year, we'd only be on point for doing about 2.4 million. So we're still, I think, a few years away from really having a good understanding of how much money the reimbursement will actually be able to bring into the facility to help us out. A lot of that's dependent, as we've discussed, on the type of patients that we have in the facility, whether they come from the civil or from corrections or the legal system. And that weighs in a lot. So I think, to be honest, we're probably 2 or 3 years away from being able to really have a good understanding of what our reimbursement account is going to look like now that we're recertified. But it is fantastic news for us, and it's nothing but positive for us to have the additional funding coming in. On the next slide, we talk a little bit more about a breakdown of the expenditures, which is always interesting as being someone that doesn't work directly in the hospital. You can see that we had a total expenditure amount of 47 million. And an interesting note of that is the personal services piece of that is almost 30 million. So it's actually about 2/3 of total expenditures is on personal services. Sounds like a lot, but when you think of having a facility that runs 24 hours a day, 365 days a year, when we have to have staff and regulations of how many staff we have at the facility working, it makes a little bit more sense that way. And then for the all other piece of that, which is the $17 million, we broke it down a little bit just to give you an idea to see where the funding source is coming from. It's very obvious to see that the professional services is the largest, almost half of the total all other cost. And so I chose to break that down for you guys even more so you could see that $8 million. A lot of that comes from the medical service piece of that, and that is on the medical providers that we're not able to bring on state line. And usually that has to do a lot with pay. So we have to bring them on as a contract employee. And that can range from psychologists to psychiatrists to medical providers to nurses and various things there. But that's a breakdown of that $8 million. And then the other things in the 17 million are just the things that we have to run the facility. We have technology, we have to have power, heat, any of those things. So I'm happy to answer any questions. As I said, I'm an accountant, so weeds are what I like to be in. So if anybody has any questions, please let me know. But that's a very brief overview at a high level of our expenditures for the hospital.
Thank you, Jen. I'd like to introduce Renee Finks, who is our Director of Nursing, to speak about the response to COVID. Renee, do you want to speak to that? And then Amy can speak to the contact tracing and surveillance. But
sure.
Renee, do you want to go?
Yes. Good morning. Riverview began preparing for potential exposure to COVID-19 in March of 2020. The number one goal of this administration is to protect the health and safety of our patients and staff. And we have achieved this in this last several months by how we conduct hospital access, triage, and surveillance. Upon the declaration of the global pandemic, Riverview's Hospital Incident Command systematically changed how we access the hospital. We utilize one entrance and one exit to monitor the flow of traffic, to monitor for social distancing and the proper use of personal protective equipment. All in-person visitation was stopped, and we eliminated access to anyone who wasn't hospital personnel. Patients have been able to stay in touch with their families via Skype, FaceTime, or by telephone. We were allowed a brief reprieve this summer for in-person visits outdoors when Maine's positivity rate decreased below 1%. Any staff who enter the hospital are screened for signs and symptoms of COVID-19 and temperatures are obtained. All direct care staff are assigned to one inpatient unit and floating has been kept minimal. All patients are screened 3 to 4 times daily with temperature checks. Patients have been and continue to receive active treatment, all activities, and their care via telehealth on their respective units to limit cross-contamination. All hospital personnel are required to wear surgical masks, face shields or goggles, and more than 300 Riverview staff have been specially fitted to wear more than one brand of an N95 respirator in the event of a COVID-19 outbreak. Since the beginning of the pandemic, under the direction of Dr. Davis, our providers have been doing a specialized schedule. They work 2 weeks in the hospital and 2 weeks remotely. So we always have healthy providers in the event of an outbreak of COVID-19. Part of our all-inclusive COVID-19 pandemic plan is a emergency staffing contingency plan, so we always have enough direct care staff to take care of our patients in the event of an outbreak. In order to continue to serve the patients of the state of Maine, Riverview designated an isolation/admission unit in the beginning of the pandemic. Admissions are meticulously screened for COVID-19, and they are isolated on that unit until a negative test is obtained. We've been very fortunate to work with Nordex Laboratories, and when we are required to do a PCR test, our results are back within 24 hours. We also have the ability to rapidly test patients or staff who have a sudden onset of symptoms, and we get the results in 15 minutes. In recent months, because the community exposure has increased exponentially, Riverview has implemented a surveillance and contact tracing team. The head of that team, Amy Brown, will now explain the roles and responsibilities that continue our global effort to keep COVID-19 out of our hospital. Thanks so much for your time.
Thanks, Renee. So as Renee was speaking, we do have two teams that we've created, a surveillance team and a contact tracing team. The surveillance team is basically responsible for what it sounds like. They are doing surveillance and observations in person. They're doing camera observations in common areas, and they're also doing some audits at the screening table out front. And so what they're checking for is making sure folks are coming in with their masks, that they have their goggles, that they're utilizing a contact tracing book, which they keep names of anybody that they've come in contact with throughout the day. And then from there, we go to contact tracing. So if there's a person that comes in the building that's had an exposure or a possible positive test, the infection control nurse would then notify the contact tracing team. And we would get started with a bunch of different tasks, basically interviewing the person under investigation to see who they've had contact with in the building during the day or the days prior when they worked. We would look at their contact tracing book to see if they've identified anybody else that they just didn't remember off of their memory. And then we would also look at badge swipes. So where did they go throughout the building through the day, and camera observations. And what we've been able to identify is that they don't always remember, staff don't always remember who they came in contact with, and they don't always write down who they had contact with in their contact tracing book. So the camera footage and the badge swipes have proven to be beneficial and helpful. We recently identified 8 extra individuals that a person had had contact with but had forgotten to put in their contact tracing book. So that's been helpful, and it's been a really good experience so far. We've really been able to track people and see where they've gone through the building, and we've also been able to identify that the goggles and the face shields and the mask are working to help stop the transmission of the virus. Thank you.
Thank you, Amy. Last but not least, Stephanie George Roy, Deputy Superintendent. Steph's going to talk about the goals for 21. Steph?
Thank you, Rod. Thank you, committee members, for letting us have this opportunity today. So our facility goals, this is a highlight of our large goals. We always have many, many smaller goals that we're always working on and evolving. We want to obviously safely continue to increase our admissions and keep the mental health system moving to mitigate wait lists and to make sure that the folks in the state of Maine who need our help get the services that they deserve. We want to keep our patient population and all of our staff safe by continuing to maintain all of our COVID-19 protocols, as Renee outlined in the last slides, and our mitigation efforts. We constantly evolve in this area. Every morning we have morning briefings, and every afternoon we have afternoon briefings to keep on top of the ever-changing information that Rod and other members of this group get on the CDC calls that we attend every day with Dr. Shaw and other members. We're working on replacing the flooring on all the patient care units with state-of-the-art non-carpet flooring that has acoustic qualities that will make it more desirable for the patients and the staff. It also has extra padding in case someone has a fall or anything of that nature. So it's really state-of-the-art flooring. It's, I think it's antimicrobial, right, Renee? It's going to resist staining. It's going to really, really be positive for the facility, and it's going to help out our exceptional housekeeping group, help them maintain the facility. As Amy talked about, we're going to continue with the implementation of the electronic health record. Many of us have been through this several times, so we're very familiar with the rollout. We're also familiar with the amount of time it's going to take and the dedication it's going to take of this team and our staff to keep that flowing with the project manager. We want to ensure the safe placements for residents and staff with the LR 62, which is a bill that's out there for the expansion of the use of the IMHU for folks with who meet the criterion with their mental health needs and some of their more complex presentations of assaultiveness and violence. And obviously post-COVID, we want to restart our commitment to being a community teaching hospital. We've had postdocs, we've had medical interns, we've had nursing interns, social work interns, OT, RT. We miss that, and we've really missed that. And psychology, we've really missed that during COVID, and we hope to get that started up again when it's safe. Thank you, everyone.
Thanks, Steph.
Welcome.
Great. So I think we'll hand it back over to Representative Meyer for questions.
Thank you so much. Thank you, Superintendent and team, for an excellent overview of the great work that you're doing over at Riverview. If we've got questions from the committee, I would ask that you use your raise hand function. I see Representative Zager. Go right ahead. Representative Zager, you're on mute.
Thank you so much, Madam Chair. I really appreciate the vital work that that you all are doing at Riverview, starting with Superintendent Buffard and all the others. That is very impressive to have 0 COVID cases, and I appreciate all the mitigation efforts. My question is regarding the top 3 diagnoses that Dr. Davis mentioned. One of them was schizoaffective disorder, which I think I might have missed it as the slide was going to the next one. It looked like between 2019 and 2020, that diagnosis in particular was much, much less. Assuming that the prevalence and the incidence of that has not gone down, I guess the ACT teams and other community dwelling services are picking up that slack. And so I was just wondering if you have any comment on that. Did I read the chart correctly? And if so, how that is a push in one area affecting a pull in another part of the system? Thank you.
Dr. Davis, could you respond to that?
That's a really excellent question. I don't know that I can offer a particular reason for why that's the case. I would be curious to see how that plays out over the next couple of years. To some extent, that may be because in general, schizoaffective disorder it's a very specific diagnosis within the DSM-5, which is the diagnostic manual that we use in psychiatry. It encompasses so many different symptoms and behaviors, and there's been a focus in recent years, not just within Riverview or Maine, but really within the psychiatric community on making sure that when we utilize that diagnosis, we're being very precise with it. What we've seen historically is at times people have some symptoms of psychosis and some symptoms of a mood disorder, and they get this schizoaffective disorder diagnosis, but that may not actually be an accurate diagnosis. And so I think what I would expect, frankly, is it wouldn't surprise me if we see a leveling off with the lower incidence of schizoaffective disorder, again, not just here, but in general, as there's more focus and attention paid on accurate and precise diagnosis. Does that help answer the question? So I don't know that it's necessarily due to any specific treatment within the community. or although certainly we're fortunate to have to work with some great ACT teams and outpatient programs here.
So you do not. So you're hypothesizing that that's due to a sorting issue of what the actual diagnosis is, as opposed to the treatment going from inpatient to outpatient for those high need cases.
Exactly. And I would consider any of the diagnoses, the three most common that we've seen, and even if you add in unspecified psychotic disorder, which is the fourth most common, or has been over the last couple of years, those are all, there's a lot of overlap between schizoaffective disorder, bipolar disorder, unspecified psychotic disorder, and even schizophrenia. And these are clinical conversations that we have here within the hospital, within our own medical staff, and even frankly, as I discussed earlier, with some of the experts in California, Dr. Kennedy, some of the other venues, even within the Harbor Performance Initiative. So psychiatric diagnosis is, in some ways, it's very simple. If you look at the DSM-5, it makes it sound very clear. If you have 3 of these symptoms in this domain and 4 symptoms in this domain, this is the diagnosis. And it's just often not that clear. And working within psychiatry, we actually like that uncertainty. It's what we find intellectually stimulating. But I think the fact that we don't just use it as this global term, the fact that it has gone down, I think is actually a good sign in the sense that we're being more precise with our diagnoses.
Thank you. I appreciate it. Excellent presentation to all.
Thank you.
Thank you.
So we've got Representative Lemelin, followed by Perry, and then Craven.
Good morning. Thank you for the great presentation. My question has to do with the dental clinic within the center. Is that currently open?
We essentially have had to close it due to COVID. And as the positivity rate decreases in the community, we'll reopen it. Matt, are we taking any people on an emergency basis? I don't think we are at this point, correct?
We've been referring them. Yes, we still have the providers who answer calls from patients because we have historically served a relatively large number of patients, and they've been available to help triage various issues. The clinic was open briefly when the positivity rates were lower, probably for about 2 months or so. But we had to cease operations a couple months ago when the positivity rates really significantly increased in the fall.
So the dental clinic, just for information, the dental clinic is located right in the interior of the hospital. So essentially, to get in and out, we'd be bringing people from the community, essentially right into the center of the hospital. So, if it were located in the community, it might be a little different. But where it's located, it would put some of the other patients here in the hospital at risk.
One last quick question. What level does the rate have to be before you feel it's appropriate to open that clinic up, the dental clinic? I have some people in my district who use it and who are in need. So that's why I'm asking.
Dr. Davis, do you want to respond to that as well?
That's a great question, and we want to meet those needs as quickly as we're able to. I don't know that we have a specific number. It's something that we talk about. We have within administration calls at least Monday, Wednesday, Friday, and one of the items that we look at is the dental clinic. But so our next call will be tomorrow morning, and we will put this on the agenda. And if we can get a more definitive answer on a particular cutoff rate, the other things, of course, that are going to go into the equation are vaccinations within the hospital, within the community. So there's a number of moving parts, but your point is well taken, and it is something that we will prioritize. And if we can get a more concrete answer to you, we will absolutely do so as quickly as we can.
Thank you very much. Appreciate it.
Sure.
Okay, I think I'm next. I have two questions. One relates to the EMHR, the health record, electronic health record, and that relates to, you know, how you're planning to get this through, because that could be very disruptive, especially when you're doing a significant change. And the question that goes with that is, you said you have picked up on Cerna. Has, because you do a lot of coordination with Dorothea Dix, is that the same health record that Dorothea Dix has picked up as well?
So Amy, could you respond to this question, please?
I'd be happy to. Yeah, it is a big endeavor, and we are in the process of hiring a project manager to assist us with that rollout. And beyond that, there's a team of individuals that we've been working with for a very long period. It's been a couple years now at this point with the RFP writing and getting that out to CMS, and an advanced planning document that needed to be sent to CMS for funding. And then working with OIT to make sure that all the parts fit, and also working with DDPC. So they've been involved in this process with us as well. And yes, we are using the same medical record.
Thank you.
Sure.
My second question actually relates to the availability of outpatient care that you send patients out to. Do you find that there is enough available? Is there any difficulty when you are trying to discharge a patient to get a patient into the right treatment?
Stephanie, would you respond to that, please?
I will. We do face difficulty with certain components of discharge. I think our most difficult piece is to find psychiatric med management. We oftentimes are able to work with OBH and find if someone needs a group home, for example, or some type of congregate living. We have a very good process for that. We meet with them weekly. They come into the hospital, a cohort of us. Prior to being the deputy superintendent, I was the director of social work for a number of years. So our biggest challenge is the med management in the community. We work really hard at building relationships with community providers. ACT teams, we can access them more quickly, but many of our patients either don't want that level of care or don't need that level of care. So when we're trying to cobble something together for them, the med management is a challenge. I do know that we are working with many outpatient providers to try to beef that up. I think the general consensus is, and I know Dr. Davis can echo this, is just getting psychiatrists to work in Maine and psychiatric nurse practitioners. It's really a resource deficit, that everybody's really trying to solve.
And if I could just say very briefly, it's going to become more of an issue in the next 5 years. There's a considerable aging out, unfortunately, of psychiatrists throughout the nation, but in particular in Maine. The average age of a psychiatrist is about 60. And the American Psychiatric Association expects that by 2025, so actually, I guess 4 years now, by 2025, there's going to be a considerable shortage.
We'll also be hearing from the Office of Behavioral Health later on today. Representative Craven, did you have a question?
Thank you, Mr. Chair. I did not have a question, but I just wanted to commend the team on this turnaround, because in the past 3 years, it's just been amazing. Not just your clinical work, but also your financial work coming together. And so I am duly impressed.
Thank you.
A lot of folks feel that way. So it's great to have a chance to hear from you about these successes and these changes. And it's certainly hopeful for the future. I know the EMR will be a scramble, but with a couple different organizations working together, that'll also help your intra-hospital community some too. So good luck with that. Are there any other questions before we adjourn? Molly, any particular things that you'd like to add at this point?
I don't think so. Thanks to the team and I'll be back with you at 2:30 with Dr. Pollard.
Molly, can I say one quick thing?
Sure.
It's Stephanie. I'd just like to say that after COVID, we would most definitely enjoy all of you coming over, or anyone who would for a tour. Those are things that we've always really enjoyed as part of this orientation process, is having whoever would like to come over and see the facility and really get a sense of boots on the ground, the type of work that we do here.
Thank you for that invitation. I know that those of us who were able to get to the tour now 2 years ago really felt that was very, very helpful, and a chance to see and understand better how the organization works. Not that there haven't been any changes in the last 2 years. We'd like to catch up with those. Any other comments or questions? Mr. Buffard, are you all set then?
I am all set. I just would add to what Stephanie just said. Throughout my career, I've had the opportunity to either oversee or directly manage every facility in the state, both on the DLC side and on the DHHS side. This, to me, is the most complex facility because of the individuals we serve. And I think, if folks had the opportunity, I think a walk through the building can really provide a lot of insight as to some of the challenges we face and, some of the things that we're doing right. But if anybody on the committee had the opportunity when COVID clears, I think it would be much appreciated. So thank you.
Well, thank you for all of your work. And I hope there's a PR initiative that gets you a chance to celebrate some of your many successes. So hint, hint, Molly, that they deserve lots of kudos. So I'm hoping you've got a way to figure it out to do that. So thank you for your presentation. Thanks the committee for the questions. We're doing spectacularly well for legislative time. So we'll adjourn now until 1 o'clock and reconvene at that point to hear from several of the statutory agencies. And then later on, the newly configured or renamed Office of Behavioral Health. And we'll hear from them, and we'll touch base on the budget at the very end of the session. So thank you all for being here. Get some lunch, and we'll see you at 1 o'clock on the committee members.
Thank you very much.
Thank you. Bye-bye.
Thank you. Just a reminder to step away and mute Are you there, Carrie? Oh, hi there. I just
Hello.
wanted to let, hi, sorry to interrupt your lunch. I wanted to let you know that I was going to set up a Zoom room for a Democratic caucus at 12:45. So do people need to be in the meeting before I can do that? I probably can't assign them if they've signed out, right?
Correct.
Okay. So I can assign, well, yeah, I think it'd just be easier waiting for everybody to sign in and then set up the room. Okay. All right. Thanks. Back to
Okay.
your lunch. Sorry to interrupt.
Hi there.
Hey, you guys.
Hi, Senator. You're on mute, Senator Claxton.
So I think we need to have everybody here before I set up the room. So I'm waiting a little bit here. 1, 2, 3, 4, 5. I'm 6. So we're missing 1 or 2.
Let me see here on Holly. From 12:30 to 1:30, Holly has a meeting, so she will not be joining us.
Expect her.
No,
And I don't know about Sam Zager.
I'm thinking he's going to be back, but I will text him.
So we'll be doing something like this in anticipate before work sessions in the future. So we can all sit around and go over the list of bills to be considered and get a sense about how people are feeling.
So Senator, if either caucus requires either Anna or I or Luke or the department to participate in any of your work caucusing, we're happy to do so, both for your caucuses and the Leeds caucus.
Thank you, Aaron. I checked in with Carrie about setting it up, so I think that part's okay.
Just want to say hi to Representative Madigan. How you doing?
Were our colleagues were the leads going to arrange for a breakout room?
I didn't run that up the flagpole.
Okay.
It was news to enough of them, and I've heard back from. We'll do it in.
Okay. Yep, we'll talk about that.
I'm going to set up the room now, and we'll see if we can.
Can Carrie bring Representative Zager in, or anyone who returns? Can you put them into the breakout room if we go in first?
Here's Representative Zager now.
Great.
Okay, I just added him. 1, 2, 3, 4, 5. I'm 6. Who are we missing off this list?
Holly.
Yeah, but that's 7.
Oh,
I don't see Representative Madigan here. Did you?
She's here.
Yes, she's right there.
Oh, there she is. Okay, she's in the list. All right. But there's
Representative Craven is here.
Yeah, I got her, and I got you and Sam and
2, 3,
Joe.
5, 6.
And me is 6.
So who are we missing?
Representative Perry?
Yes.
Oh, sorry.
All right. So if she shows up and I don't see it, can you give me a heads up or something? And I'll. So I'm going to open up this room, and you all should get invited to room 1. Except it doesn't include me. Now what do I do?
I'll assign you, Senator Claxton.
Thank you. I don't see myself on the list to be assigned. Thank Hi, folks. Sorry to hold you up. We were practicing our urgent caucusing skills, and there needs to be plenty more work to be comfortable with that. So we had a brief caucus before. So as soon as we get to a quorum, we can reconvene this afternoon. 1, 2, 3, 4, 5, 6, 7. Welcome, Ms. Alberry.
Hi, thank you for having me.
Thank you for being here. Yes, Representative Javner, did you have a question?
Thank you, Senator Claxton. I just have a logistical comment. I will have to be jumping out of here at 1:30, and I will be back definitely by 3:30 in order to do the supplemental budget vote.
And at this point, we're talking about language and maybe an amendment. Okay, great. Thanks for the heads up. I had to step away because a dog needed to be brought back in, but I was successful. So 4, 5, 6, 7, 8, 9. Looks like we're at a quorum. We have some guests. We already welcomed Ms. Alberry. We also have been joined by Elizabeth Keene and Candace Powell, and Lauren's here too. So Representative Lemelin and Moore, welcome back. So we'll reconvene this afternoon's session of the Committee on Health and Human Services. We're going to hear from some agencies that exist in statutory agencies. And at the end of that, we'll hear from the Office of Behavioral Health. So we'll start with the folks from the Child Welfare Ombudsman, and she'll be referencing her annual report. So
And just
would it help you to have us introduce ourselves again, or are you comfortable with?
whatever, either way is fine with me. I have all the names on the screen,
okay,
so.
Good, all right. I don't feel obliged.
Okay. Okay, so I just wanted to check in. Does everybody have a copy of the annual report? Yes, okay, perfect, thank you.
So the answer to the question is no. It's available probably on our website, but that's not the same thing as having one, as would have been the case in the old days, like last year. So
I got mine in the mail.
Oh, well, I haven't been out to the mailbox yet, so.
Okay.
So no, you can't count on us being able to follow you by page, I don't think.
Okay, and that's completely fine. I will certainly answer any questions you have at any time, but thank you very much, Senator Claxton, Representative Mayor, and members of the committee for having me here today. And I appreciate you giving me a little bit of extra time as well, because it is a little bit complicated, what I want to talk about. I thought I'd start off with just a review of what my office does, and then we can go from there. So as you said, we are a statutory agency. We are the Child Welfare Ombudsman is created through 22 MRSA 4087-A. And we serve two main functions. First, one thing that we spend about half our time doing, we can take telephone calls. We have a toll-free number. There's a number of different ways to get in touch with us, but we can take telephone calls with anybody who wants to ask questions about child welfare. So we talk to mainly parents and secondarily grandparents, but we get calls from anyone who is connected to a child welfare case, everyone from police officers to attorneys to neighbors to friends to other relatives. And so it's part of the job that I actually really enjoy, because a lot of the time people in child welfare cases are very much adrift, particularly if they're not parents and they don't have attorneys, or it's a part of the case where there's no attorney. So I can go through with them and just talk through the case, talk through the laws, the policies and procedures, and then if I can't help them or I think they're in the wrong place, we can send them somewhere else or refer them to other information. For a smaller number of people who call, we can actually open a case for review. So the way that works is there is, and it's on the annual report. I'm not going to go through it now, but we do have a number of factors that we use to decide whether or not to open a case for a review. But because it's based on just usually one or two phone calls with someone, we never really know what we're going to find. So when we open a case for a review, we sort of ask some formal questions of the department, and then we get all the records, all the confidential records from child welfare cases, and then including, court orders, usually, sometimes mental health records. It just depends on the circumstances. And then we draft a report. That report goes back to the department before it's finalized, because our reviews are paper reviews, they're internal reviews. We don't go out and interview children or, talk to witnesses. So obviously there are things that we miss. So we want to make sure when we talk to the district that's involved with the case, that we're getting everything right. And then they ask us to change things or not. We're generally in agreement, and then the report is finalized, and the department generally follows our recommendations. I think it's a good process because it allows us to look, sometimes if you're in the case doing the work, I think it's hard sometimes to see the sort of forest for the trees. It allows us to, from a neutral perspective, look at the case from a distance and really try and see where things went wrong and see if we can change things going forward if too much time hasn't passed. I should say, when I'm saying this has been a fantastic year because we hired an associate child welfare ombudsman. Her name is Ashley McAllister. She's a former caseworker through the department. She has a master's in social work, and she's been really invaluable for many reasons. So she is, she's not here today. She may be listening. Hi, Ashley, if you are, but she's been great. And so she's jumped right in, and, through COVID and everything else, we've managed to keep it together and going. So that's been fantastic. We are just a couple words on the organization. We are an independent nonprofit. We're it's an interesting hybrid. We're not really a state agency, but there's some parts of us that seem like a state agency, but we just are sort of a regular nonprofit. I have a board of directors, and we receive we basically have a contract with the state. So I don't know, I want to get into the report, but I didn't know if anyone had any questions just about the general process. I know I sped through that part really quickly. And interrupt anytime if you do.
Just a comment, I'm so glad you got some help, Christine.
Yes, me too. Thank goodness.
Yes.
Amen. Any other questions or comments? We're all celebrating that with you.
Thank you.
All right, why don't you proceed?
Okay. So I just all of our reports are available on our website if you want to refresh yourself or haven't been on the committee in the past or haven't looked at them in a while. So unfortunately, just sort of in a broad sense this year, we haven't seen a lot of improvements in practice. And in fact, I feel as though things have maybe just gotten a little bit worse. We can talk about why that may or may not be. Obviously, I don't review every single case that the department, does. I don't think anybody can do that. But the two main areas are sort of areas we've been following for a number of years now. So the department really continues to struggle with practice issues and decision-making around sort of what I consider the two most important points in child welfare involvement. The first is when they're making the decision whether or not the child is safe, basically at the beginning of the case during an initial investigation, whether or not the child is safe in that moment. And then the second part is making the decision whether or not the child will be safe in the home once the child's reunified with the parents. As you know, once a child is taken into state custody, in the vast majority of cases, the department is obligated under law to make good faith, reasonable efforts to reunify the child with the parents. And of course, something has gone wrong with the family. If the child's in state custody in the first place, something has happened to somebody, something is not quite right that makes the child not safe. But trying to decide after a year or 18 months whether that child is going to be safe going home is a very complex decision. And that's where we're seeing sort of the most practice issues at this point. So I can talk a little bit more about that. So just switching back to the beginning of the case, I'm sort of going through the report. So the way the report is set up, if you don't have it in front of you, there are, at the beginning, it just gives you a sort of general information about how many people we talk to, who they are, what kinds of things we do. And like I said, where, how we make the decisions about whether or not to open cases. The sort of meat of the report is in the policy and practice recommendations, and the department does have responses there as well to what we've been saying. So, again, so the initial safety investigations, the department has gone through a lot of changes, and in 2019, there was a new investigations policy and structured decision-making tool that was implemented at the beginning of 2019. It's not, I don't think anyone was expecting that to be sort of the thing that changed everything, but it doesn't seem to have made too much of a difference. We're seeing the same basic investigation practice issues that have been repeated for many years, not recognizing risk to children when the evidence is clear, basic investigation practices, basically the list of things that caseworkers are supposed to do in an investigation are not completed. The caregiver's history warrants a more thorough investigation that was not done. The questions are not tailored to the issues. Safety plans are made and not monitored. Children and parents are not seen regularly during open assessments or safety plans, and children are left without legal protection. I think I can't overstate how important that initial month, essentially, of child welfare involvement is, because if things get missed then, sometimes it can sort of haunt the case if the case stays open, or, worse, the case could close and the child might not be safe. I'm not going to go through it, but there are examples, obviously de-identified examples due to the confidentiality laws of the types of, of some of the cases that we saw this year that involve some of these issues. And then the other part, and this, it's interesting because the reunification part of the cases didn't used to be as much of an issue as they have for the past 2 or 3 years, I'd say. But basically, the issue is how do you measure the progress of a parent? How do you measure the progress of a child and the child's readiness to go back to the parent or to see the parent unsupervised? How do you tell whether or not the child's going to be safe to go home? Is, again, like I said, it's incredibly complicated, but that's where we're seeing some of these issues, the sort of continued issues. So often the department arrives at the end of the case or at other crucial decision-making points, like lifting visit supervision requirements, without enough information to make an informed decision. In order to have the information necessary to make this decision, the ongoing assessment of the parent's progress in reunification is essential. For example, having meaningful contacts with parents, making sure that parents' significant others are thoroughly assessed, talking to service providers periodically throughout the case, including giving the service providers information at the outset of the case. In cases of substance use, which are, as you know, pretty common, completing pill counts and random drug screens. In cases of mental health issues, contacting all providers, providing visit and transition plans, and trial placement is really important. So trial placement is when the child goes home to the parents, one parent or the other or both, depending, but the child is still actually in state custody. So this is it's sort of a test period to see if, usually the parent has made a lot of progress at that point, but you never really know how things are going to go. And so that's a test period, to see how the parent and the child are going to do. And those trial placements, there's, I think, a good policy that requires some pretty intense monitoring. And sometimes we're seeing that they're sort of the idea that once the child goes home, everyone sort of breathes a sigh of relief and the monitoring actually gets less instead of more. So that's, an area of importance, I think. And then the other piece of all of this, of course, is that I'm talking about reunification. We hope that children can reunify. That is the goal. That is what's best for everybody. But when they can't, the court does need to make a decision about whether or not to terminate parents' rights. And the court, I mean, a lot of what caseworkers do, and people don't realize, a lot of what they do is gather enough evidence to provide the court with information about, whether or not this is the right decision for the court to make at this point. Usually the reunifications happen without a court decision, but the termination of parental rights has to have a court decision. So the court needs that information to decide. So as you can see, it's a really complex process, and there are a lot of people involved in all of this: caseworkers, supervisors, program administrators, assistant attorney generals, guardians ad litem. I mean, there's a lot that goes into these cases, and they're pretty complex. So I just wanted to, so there is one case in here I wanted to talk about a little bit. It's pretty heartbreaking. I'm just going to read it to you just so we all know what we're talking about. So it's number 1 on page 15 if you're looking at the report. It says, a child was reunified with a parent too quickly, due in part to lack of ongoing assessment of the progress of the parent and assessment of the new partner. The parent and the new partner had an infant during the open reunification case, and the assessment of the infant's safety was not adequate, and a case was not open for the infant. The infant died due to injuries sustained at the hands of one or both parents a few months after the reunification case closed. The older child re-entered custody. So obviously, this is not something we ever want to see, and not every child death can be prevented. But this case, interestingly, I mean, another point of confusion, I get a lot of questions about this. The Ombudsman's office does not get notified of child deaths necessarily. I came upon this case just through happenstance. Somebody involved in the case referred the case to me. So of course I reviewed it, and it's, truly devastating. I also wanted to talk about this a little bit because the department in their response did state on page 16 that the Ombudsman concluded that reunification occurred before it should have, but there was no recognition of the impact of the court process. In that case, the department had sought termination and was denied by the court with an order to continue efforts toward reunification. While it's true that many things happen in child welfare cases that are outside of the department's control, including absolutely court orders, this specific case is not a good example of that type of situation. It's difficult to talk about case specifics due to confidentiality law, but it should be noted, I mean, the court's order in that case was discussed at length and quoted from in the relevant case-specific report drafted by the Ombudsman. In that case, practice issues before the hearing occurred that led to the denial of the termination and the continuation of reunification. The court's order to continue reunification also did not relieve the department of the responsibility to provide ongoing assessment of the case or new assessment of the safety of the infant. And that report, it went through the same vetting process that all of my reports do, where it was discussed, with many different layers of staff, both over the phone and by email and by Zoom, as a matter of fact, because obviously it's such a consequential case. So I think I'm going to disagree with the department a little bit on that one. I think it's really important to understand the interplay between what the caseworkers do and what the court decides. And I also just want to say, unfortunately, I think the caseworkers bear the brunt of the blame in a lot of these situations. And I will say that this is not an appropriate thing for any of us to be doing. This case in particular, more so than the deaths of, say the death of Marissa Kennedy, was not an outlier in terms of the practice issues that we see. It could have happened in any district in the state. The parents who caused the death, they are the outliers. The department's practice mistakes here were not. These are all the same. The issues in this case were the same that we see in many of the other cases listed here. So I just want to make sure that we all understand that these are not caseworkers acting in bad faith. They're doing their jobs to the best of their ability and the support that we can give them. And no caseworker is making decisions, that are individual decisions all by themselves on any of these cases. So like I said, there's a lot that goes into it. So I don't know. I'm just going to pause again because I know, again, I've thrown a lot of information at you. I know I don't have a whole lot of time left here, but I didn't know if anyone had any questions.
Yes, Representative Madigan.
Thank you, Senator. Thank you, Ms. Alberry, for being here today. Do you think that some of the continuing problems that you've seen and in this report, are any of those related to caseworkers continuing to have caseload levels that perhaps don't allow them to complete that work, complete those assessments?
So it's certainly a factor, I think. There are a couple things that go into it. I think the department said in their response that that is still a factor. I think that, there's a problem of training that, there are many new caseworkers hired, new caseworkers or old caseworkers promoted to supervisor. I think that there is, I think for a long time, there's been a lack of ongoing training in the department in general. Some of that is, they're trying to address it now with some of the contracts with the Muskie School. So I think those are certainly both, I think it's caseloads and training both. I mean, I certainly have seen plenty, I'm not saying anything positive here, I feel like, but there are plenty of cases where caseworkers do a great job in their cases and we send in positive reports. But I think, and the other part of this is I don't know. I mean, I wish we all knew exactly what it was that was causing some of these issues. And I think that we're at the beginning of child welfare reform. Marissa Kennedy and Kendall Chick died in 2018. Feels like a long time ago. It was not. And I think we all need to be flexible and work together to, try and understand what's happening, try to understand what's happened in the past is really important too, so we don't repeat the same mistakes. But certainly continuing to support caseworkers with time and training is, at the top of the list of things that I anyway think will be effective.
Thank you.
Senator Baldacci, did you have a question?
Yes, I also want to thank Christine for her work, her service to the public. Christine, I've been involved as an attorney for probably for 29 years with the department on hundreds, if not thousands, of cases in this area. So I understand what you're saying. From my experience, it seems like we swing one way and then it swings another. There have been times when the department has been criticized as being too intrusive, too controlling, and then there are times when it's being criticized for not being intrusive enough, or however you want to put it. I think those are unfortunate swings that have been going on for a long time. But in terms of staff turnover and wages and training, and I apologize, I didn't have a chance to read your report. I mean, have you made specific recommendations on those type of issues?
So I haven't made any recommendations on wages or turnover. Turnover that's a tough one, and I don't have any information on that. In particular, I have made recommendations that I think the training needs to happen more consistently. It should be in the districts. I think the training is really important. But in terms of the specifics of training, I'm not sure what to say about that. I know that the Muskie School right now is looking at all of the trainings that the department has been doing. I think that the requirements have not been enough for some time, and I do talk about that in here.
Okay. No, I think your office is very important. For my experience, I think your office is very important. The shortcomings I saw was that I don't think the department is not, your office lacks teeth with the department. Mm-hmm. So they will deal with the complaints as they want to deal with them, unless there is more of a public pressure on them. That's all. It doesn't matter who's governor. It's the same culture. So I would like to see at some point, maybe we could have a discussion about more teeth for your office and more resources, because I do think it will be an overall positive influence to have a better oversight that your office can provide to the department. So those are just my 2 cents. Thank you.
Thank you, Senator. That report is available in an email from Anna this morning about 8:45, and it's also on our materials folder on the website. Yes, Representative Javner.
Thank you, Senator Claxton. Your work for this state and for the children of this state, and what the work does for the ombudsman, I cannot overstate just how important that is. And I am so grateful for the work that you do. This, even though it's very emotional, it's very hard, for you to present what you have presented. It is, the importance cannot be overstated. And as we, again, allow us to digest, exactly the information that is found here in your report, there are obviously some issues. I have a question, if I could put in here real quick before I have to jump out. Is there a connection whatsoever that you see in the court systems being shut down during COVID? Even just in specifically, perhaps even this one case that you highlighted, and if not, then that's great. But I am really curious how that has affected, what has gone on with the welfare of our children.
That's a great question, and I apologize. I meant to bring that up. So the case that we're talking about, that we were talking about specifically, the coronavirus did not have an effect on that case. I can't give any more information about the timing, and in general, I will say that I think that we were pretty careful this year to not let, for example, the shutdown from from March to June. I certainly would never pass any judgment or make any recommendations if, caseworkers were scrambling to try and figure out how to visit kids through Zoom and all these different things. I just considered that sort of a wash, and whatever happened was everyone was doing their best to adjust to an unprecedented situation. There are certainly things that are worrisome about COVID that are out of everybody's control, and there are specific issues that the department has struggled with through no fault of their own. For example, visitation with children has been really difficult, and has been really hard on kids, especially younger kids who went for that period of time without seeing their parents, or tried to see them over Zoom, but Zoom does not work for a 2-year-old. That period of time was really difficult. And then, seeing their parents again, having not seen them for a while. And then also there were issues with staffing the visitation agencies, issues with COVID outbreaks. It can't be overstated how difficult that was. And I think continues to be, just because of the lack of resources because of COVID on children in particular. And I think in general, it makes it that much harder for caseworkers to do their jobs. They're going out there, they're exposing themselves. I'm sure that some caseworkers have pre-existing conditions that make it harder for them. Generally, the department staff are not working in their offices. Everyone's working remotely. Some people are going in and out, but there are times when the offices are closed down entirely. So, there's some things that have been better. Zoom family team meetings have actually been quite a boon for the most part, just because it's easier to get everyone together. But, and I know that the courts have done a lot. They started having adoption hearings, during the shutdown, because it was so important to get those kids to permanency. And I know that the courts, and I can't speak to what, their decision-making process, but they've gone through a bunch of different iterations of, Zoom, and some hearings in person, some not, those types of things. So I think the short answer to your question is we don't know yet what the long-term effect of this is going to have on children and families. And it's certainly something that is very worrisome.
So part of me wants to ask you to give the department a grade, but I think that'd be a really awkward position. So let me ask it a different way. If you were had a magic wand, what one thing would you change in the department that would have the greatest impact?
I think that I would, if I had a magic wand, I would put training staff, experienced people in every single district to help teach new caseworkers and new supervisors how to do their jobs.
That's a great answer and not a surprise. And thank you for offering that. Any other questions from the committee? We could take an extra few minutes if you had some stuff that you thought you really wanted to make sure we heard before we quit.
I don't think so. I mean, there's a lot. I mean, I hope you all have a chance to read the report, and you can always call me or email me anytime if you want to, if you have other questions. I guess I just want to emphasize that in general, I do think that there's been a hope that suddenly everything would start to get better over the last couple of years, after, unfortunately, sometimes it takes the death of a child to be a catalyst for change in child welfare, which is what I'm learning as well. But I think that, like I said before, I think we're at the beginning of this, and I think it's going to take a lot of creativity and working together moving forward to really, make the department into sort of a model of child welfare, which is, what I hope for, what I keep hoping for.
Well, I'm sure your contributions to an assessment of their process will only help. So thank you for all your work in general. I also greatly appreciated a couple times when I've been able to contact your office with a concern. And you were right there. So I want to be specific about that, but in general, really appreciative of the amazing work you do and how you keep at it. So thank you for that. It's a blessing.
Well, thank you. And yes, anyone call me anytime if you have, or send a constituent my way as well.
Thank you very much for joining us.
Thank you.
All right. Our next guest is from the Long-Term Care Ombudsman Program. I see a B Gallant person there. So if you want to join us and share what's going on for you in your world, that'd be great.
I'm here, but for some reason, hopefully my video was working and now it's not. I apologize.
Nope, there you are.
Oh, good. Okay. Technology in this Zoom world that we're in. So good afternoon, Senator Claxton, Representative Meyer, and committee members. My name is Brenda Gallant. And as you know, I'm the executive director of the Maine Long-Term Care Ombudsman Program. I really do appreciate the opportunity to meet with you today to tell you about the program and our accomplishments over the last fiscal year. I sent along a couple of program brochures and an annual report, which is really just a summary of the very extensive report that we provide for the department as part of our contract requirements, which I thought would be helpful to you in just outlining the work that we've done. And just for those of you that are new and not familiar with our program, the Federal Older Americans Act is the law that established ombudsman programs in every state in the country. And initially, the program provided advocacy for residents in nursing homes, residential care, and assisted living. And that's true in states across the country. However, Maine's state enabling legislation in the 80s established our program beyond those settings into home care, adult day services, independent support services, which you'll hear referred to as homemaker services. So we're one of 13 ombudsman programs in the country that have this extended role. Also in 2015, there was a commission to study difficult to place patients, and it was known that about 200 people at any given time were in Maine hospitals ready for discharge, but waiting weeks, months, sometimes as much as a year or more to be discharged because they experienced a need for long-term care services and were experiencing barriers to getting those services. And so we stepped up and said we wanted to do this work. And so since then, we have been serving patients in hospitals. You'll see on our annual report that in FY20, we had 200 referrals. We were successful in getting placement for 176 people. And not all of those people were received services either in the community or in a facility and were able to be discharged. Some because they came to us at the end of the year, so we were just beginning to work with them, or they were not available resources to work with them. And I know that you'll be hearing a couple of bills on this problem of people in hospitals waiting. And we have a lot of data that we can share with you, and we can have a very lengthy discussion about our work and what we're seeing. But you do have a summary in our annual report. Now, our program is housed within a nonprofit agency, so we're one of a handful of ombudsman programs in the country that are outside of state government, and that really gives us freedom, I think, to advocate. People were kind of a model program in the country, I think, for that reason. Our services are free and confidential. We have statewide services. We have a toll-free number, and what I've really emphasized is having staff available to answer the phone, because many people just call us with questions about how do I choose a nursing home? Tell me about Medicaid. They may just have questions that they don't want to get an answering machine. So we have a full-time intake staff person. Our admin assistant also answers the phone, so people get an immediate response. We respond to complaints and concerns within a 24-hour period. We have 13 full-time staff, and we have 35 volunteers that we carefully screen and train and supervise. We cover 345 long-term care facilities across the state, and our role is to investigate and resolve complaints made by or on behalf of residents or home care consumers. I want to stress that all of our staff are really experts in long-term services and supports. They know the regulations, they know the programs, they know how to listen to people, and we have a very high success rate in terms of problem solving. And how we do this really, I think, is that we work really collaboratively with state government. I think that's really critical. Maine has this great tradition of people working together. It's been important through the pandemic. It's been important through our work. And I just want to say we work a lot with the Office of Aging and Disability Services, with licensing and certification, Office of Family Independence, Adult Protective Service, Office of Maine Care Services. All of these people know us. They know we're credible, and they work to resolve problems. So collaboratively, we can get a lot done for people. And again, our knowledge of the programs is very helpful. We work with legal services organizations like Legal Services for the Elderly, Maine Equal Justice, Disability Rights of Maine, sometimes Pine Tree. When people receive a reduction, a termination, or a denial of home care eligibility services, we can file an appeal. We will work with these legal services organizations to help people either obtain or retain services. In 2020, we investigated 1,521 complaints across settings. And let me just first talk about facility care. COVID-19, we all know, has been really quite difficult, and that it's had a major impact on residents in long-term care, on their families, and on staff. And so immediately, it was very important for us to respond. The department approached us about applying for a civil monetary penalty grant so that we could partner with Maine Healthcare Association to get funds so that facilities could purchase technology to keep residents in contact with families because of the visitation restrictions that were necessary as a result of COVID. So we did that, and people were given iPads and other technology to enable this. We did an intensive outreach. I told my staff, I want you on the phone. We're reaching out to providers to ask them about staffing, PPE, any other barriers they had, reaching out to residents. We did a Zoom, emails, phone calls, letters, postcards, every avenue that we could think of to reach residents, because for a time we couldn't go into facilities because we're not essential personnel. We worked with the Office of Aging and Disability Services and licensing and certification and Maine CDC to do infection control assessment surveys, which these were developed by the federal CDC We did them in the matter of weeks with all of our staff together in facilities across the state. It was a 10-page survey that was very extensive that really talked about infection control practices, everything from the kind of disinfectant they were using to screening of staff and residents. And these surveys were early on, and they were important in terms of determining who might need some education and help. So we were so really pleased to be part of that. I asked the department early on to extend bed hold during the pandemic, and they did. For people that go into hospitals and have COVID-19, they extended it up to 14 days, and I'm grateful for that. We also knew that in some situations, assisted housing or residential care facilities were reluctant to let home care agencies in to provide services because they know the staff were going from one facility to another. So we worked with the Home Care and Hospice Alliance, the Maine Healthcare Association, to really develop an understanding and protocols and to facilitate access to those services because we knew how much they're needed. And we also said, if you run into a problem, call us and we'll work on mediating it. So that was a very good thing. We worked with the hospitals and Maine Healthcare Association to develop protocols for transition among settings. And we did a lot of outreach with families. We did webinars with Dr. Susan Wary, who's a geriatric psychiatrist, with Maine CDC, with licensing, to reach out to families, to give support, to give information about CMS guidelines. So a lot of outreach there. And then we were hearing a lot from families because really the primary concern for them was the separation of residents from family members. So there is the ability for families to visit residents under compassionate care. And CMS defines this as end-of-life visitation, or if, for example, a resident was cared for at home and went into a facility, that a family ought to be able to have some visitation rights because the resident would really suffer having lost that care, or if there were a close family member that died. We had some situations where facilities where there were some concerns about letting families in for compassionate care, and we worked on that to resolve. I had a family member who wanted to be with her mother as she was dying. It wasn't as a result of COVID, but another condition. And she just wanted to be there with her. And the facility had a concern about that. We were able to talk it out so the daughter could be with her mom, which was so important. And it was a good outcome for this resident, the family, and for the facility. In another situation, we had during the good weather, window visits were allowed. And we had a facility that just they weren't sure they could do that because maybe a lot of families would come all at once to expect these visits. And so I called an administrator on a Sunday afternoon and he responded and we worked together and they allowed the visit for this daughter and it worked out really well and they extended it to all of the other residents and they were so glad they did. So those are some of the things that we worked on, and regular communication with licensing and certification. We meet with them every other week and more frequently, a lot of information sharing and much collaboration and communication with state agencies, which is just ongoing, which has made a big difference. I want to talk also about, we know you've heard about staffing challenges. Even before the pandemic, it was really quite difficult for providers across the continuum to find staff. So with this in mind, I partnered with Maine Healthcare again this year. I know that some of you attended the Excellence in Long-Term Care Awards. It's really important for the direct care workers to be acknowledged for their efforts. I think we had a very nice virtual event to honor them. And right now we're working with the department and Maine Healthcare on a public service announcement that will go out to let the public know about the great need for these workers and where they can go with the website that the department has developed, which is Connect to Care to Jobs in Maine. And so really to foster recruitment of the staff that are so needed. So you'll be seeing that. you want me to keep going? I don't want to talk too much here, but anyway. Okay, home care. So I've talked about facility care. Home care, we have the same staffing challenges. So we've worked with people. We had 247 home care concerns. Some of those were about reductions, denials, terminations. They went to legal services organizations, and we worked with them on merit. For people that didn't have staffing, we worked to get funding for assisted living technology, and to also suggest that maybe a family member could provide care under the consumer-directed option. So we're very active in home care. And I mentioned the hospital patient advocacy. As I said, you'll be hearing some bills. We have an extensive report on the particular issues that people are facing. There's a definite need to develop more resources for those folks. We were asked by the department to facilitate a meeting with the hospital association, with Adult Protective Service, to talk about incapacitated patients and the Adult Protective Service response to assisting those patients. And then it really evolved into a discussion about what are the services that we need to develop in Maine so that people are not waiting in hospitals for a long time. And then I just have two more areas, and then I certainly can answer questions. Transition assistance is really important. People need to know that they have a right to have information, even if they're in a nursing home or a residential care facility or assisted living, to have information about the fact that they could be served sometimes in the community. So we started that work under Money Follows the Person, which is a great program that will continue. But outside of Money Follows the Person, we've worked with, you can see on page 5 of our report, we have continued transition assistance. Outside of that, we had 24 referrals, helped 11 people. We're still working with more. So it's really important that people know they can be served in the least restrictive setting and what the resources are. And then finally, I would just say our volunteer program is, you just can't believe the great people that come to us. And again, we do a very careful background check on these people, and they're just magnificent. And through the pandemic, I've said, please, you've got to reach out, and they've done Zoom calls. We have a resident with low vision, and the volunteer reads to her, and this resident has really benefited by that. We've reached out to Maine Healthcare to say, can you ask your providers if they have residents that don't have an involved family member that we could reach out to? And our volunteers have definitely been a great part of that outreach. And they do enable us to cover the numerous facilities that we have to cover. A couple of things that are not mentioned, we have partnered with the Maine Healthcare Association and Dr. Jabbar Fazeli and Nadine Grazo of Maine Healthcare to establish the Dementia Partnership, which works on reduction of antipsychotic medications in nursing homes. Maine initially was one of the most improved states in the country. We did a lot of education. We did a music and memory program to help residents with dementia improve their cognition and education to reduce antipsychotic use. We developed a toolkit that will be implemented and shared with providers. That work has kind of stopped a bit because of COVID, but it will be resumed. So we're always looking to serve people with whatever issues they have, resolve those issues, but then also look at the systemic issues that need resolution and make suggestions and be part of stakeholder groups and have input. And you'll be seeing me on long-term care legislation. So.
Thank you, Ms. Gallant. As the rest of the committee is seeing, we're being exposed to lots of people with plenty of passion, and I appreciate yours in the work that you do. It's been great to be able to use you as a resource in a couple instances for constituents, and I've heard of other people benefiting from your expertise. So thank you for that. Are there any questions? First is Representative Craven.
Thank you, Mr. Chair. I just wanted to thank Brenda for her work, and so nice to see you. Miss seeing everybody.
I know. I know.
Yeah, some of the follow-up would be easier in the hall if that existed still. Senator Baldacci.
Yeah, I just wanted to also join in the comments of Representative Craven and really thank you for your public service. I want you to know how important this work is for so many people. We have very high aged population in Maine, and so I just want to thank you for all that you do for a lot of people. Thank you.
We love the work. I have to say, honestly, I am so proud of this program because the staff are amazing people and they just know these programs. And again, state government knows that. And so when we ask for something, they respond. And so it's so great to have that collaborative work to get things done for people. So I'm just proud of what we do. And every day you get to go home and say, I did something to help somebody. And that's a really good feeling. So thank you.
That's a good day. So thank you for your contribution to that. So, all right. If there are no other questions, I can attest that she's very available if you have questions. So it's on you from here. But next, we're going to welcome a series of folks related to end of life care. And I think we're going to start with Candace Powell. And no, we're going to start with Elizabeth Keene and Lauren McCalclis. I see Lauren's name here, and I see Elizabeth.
Michalakis is.
Michalakis. I'm sorry. I
Yeah,
really.
no, that's okay. That's okay.
Shoot on that one.
No, that's fine.
Welcome.
Thank you. Thank you. I'm just looking for my colleague Elizabeth. Oh, there she is. There she is. All right. Well, thank you so much to the committee and to Senator Claxton and Representative Meyer for allowing us to spend this time providing an overview of the work of the Palliative Care and Quality of Life Interdisciplinary Advisory Council. I don't know if do we have slides, Anna, or do you want me to put mine up and share? Is that, let me just see.
Whatever you prefer.
If you have them, that'd be great.
Okay, it'll give me just a minute, so carry on talking while I find them, okay?
Yeah.
I have them if you'd like me to share them. That's easier.
If you have them right there, that's great, okay. Elizabeth.
Good.
Yeah. So I can just start by introducing myself. I'm Lauren Michalakis. I'm a palliative care physician. I've been working in hospice and palliative care for over 25 years in multiple programs and organizations in New York State, but mostly in Maine. I've been part of the Palliative Care Advisory Council that we'll be talking about in a minute since we began in 2015. I've known Candace Powell since I moved here, I think something like 22 years ago. So we work hand in hand, we're collaborative, and we'll explain more about that as we go on. But mostly I just want to have Elizabeth take a minute here and introduce herself. My co-chair, we work together. I couldn't work without Elizabeth at my right hand. Yep.
Good afternoon, Senator Claxton, Representative Meyer, and committee members. Elizabeth Keene, Vice President for Mission Integration at St. Mary's Regional Medical Center in Lewiston, Maine. My background in palliative care is from the Baltimore area. I served as a hospice chaplain and bereavement coordinator, and now I'm in administration here at St. Mary's in Lewiston. So thank you.
Great, thanks. So we just want to briefly describe who we are and what we do, or what we've done to help understand a little bit more about us. So we are the result of, Elizabeth, can you just advance the slide for me there? We are the result of legislation passed in 2015, LD 782, an act to improve the quality of life of persons with serious illness. As a result of that legislation, the Palliative Care and Quality of Life Interdisciplinary Advisory Council came to be, similar to what I think 26 other states have established through oversight and collaboration with hospice organizations and ACS CAN. So our charge is to assess the status of palliative care in our state and make recommendations to improve the quality and delivery of patient-centered, family-focused care for patients who are living with serious and life-limiting illness. So we are a council of 13 appointed members by various members of the legislature. We are convened by the Maine Hospice Council with Candace Powell, the executive director, serving as our leader as a non-voting member. To those of you who don't know what palliative care is, palliative care is a relatively new medical specialty with a goal to improve the quality of life to those with serious medical illness. The cornerstones of our specialty are excellent pain and symptom management, skilled communication regarding goals of care, and psychosocial and spiritual supports to manage all aspects of suffering related to serious and life-limiting illness. And any life-limiting illness, actually. I think we have deep roots in cancer, both hospice and palliative care, but actually we tend to patients with all life-limiting illnesses, including end-stage heart disease, lung disease, liver disease, kidney disease, and dementia. So it's always really important to make the distinction that palliative care and hospice certainly have a relationship. Would be fair to say that many of us learned palliative care based on our roots in hospice. But palliative care, when you say it all by itself, is not hospice. However, hospice is palliative care when time is short. Typically, patients are admitted to hospice programs when their prognosis is felt to be 6 months or less. Next slide. So again, legislation, LD 782 passed in 2015, 2016, we convened for the first time. We meet quarterly with our 13 appointed members and supportive involvement by Candace, by the Maine Hospice Council. Probably we spent, it's fair to say that when we first started, we were struggling with exactly what our role should be. We spent the first probably 2.5 years in stages of information gathering, data collection, and then making plans for the future, some strategic planning. So in terms of information gathering, we brought people to our meetings and listened to what the particular needs of the elderly, of our rural communities, of the mental health and homeless communities, certainly special interest groups regarding cancer, dementia populations, Native Americans, immigrants, and LGBTQ. Thank you. Sorry about that. And we also spend a lot of time talking about inadequate payer engagement, and that palliative care is a unique specialty that requires the participation of multiple disciplines and specialties, yet if that's the way we want the care to be delivered, certainly the reimbursement mechanisms aren't aligned with that. We spent some time participating in data collection. We were able to secure a grant from MEHAF with which we surveyed palliative care programs in all hospitals, home care agencies, and hospice programs. And the findings were remarkable in that we found that 27%, only 27% of hospitals with had formal palliative care programs. And most of these programs were in larger urbanized settings like Portland, Lewiston, and Bangor. There were very few home-based programs identified through the survey. And most importantly, we identified that there was no standard approach to program operations, that many times programs worked without physician participation or maybe mere peripheral physician participation. Many worked without the involvement of social worker or chaplaincy. So again, no set standard way that palliative care was delivered at the time that our survey took place. And again, the reimbursement being highly inadequate, only physicians and providers who can bill under Part B, the physician billing codes, were being paid for any type of palliative care. So as we went on, year 2 and 3, we did a little bit of strategic planning after listening to what we identified as needs and unmet needs. We identified the fact that part of the problem for palliative care is many people don't know what it is. So we recognize that there are huge educational needs, both in community and the patient populations, as well as our professional populations. The little bit of palliative care that exists in Maine predominantly exists in the more urbanized areas of Maine, with very little actually being delivered to the more rural parts, most of the rural parts of Maine. We don't have, in those days, I think things have moved on a little bit better, but when in 2016, when we carried out our survey, we found that there was very little palliative care being delivered to pediatric patients. So we identified that as a strategic priority. And I've already mentioned that there really is no established reimbursement for the delivery of palliative care the way it should be delivered in the interdisciplinary team format, similar to hospice. So next slide. I think I'm going to turn it over to Elizabeth, where you can kind of pick it up with what we've done so far.
Thank you, Lauren. So in trying to implement some of our strategic priorities, we did start with education. And through wonderful serendipity, Project ECHO has been spreading across the country as a way to have a learning community, especially for areas with many rural primary care providers. So it's a way to really educate providers in some skills and knowledge for different specialties. So of course, we started one for palliative care. Dr. McLaughlin has really been instrumental in developing it and in facilitating the sessions. It's a collaboration between our advisory council and Maine Health. But interestingly, we have been able to open it up statewide. It's not just for Maine Health providers. It is a monthly session, and attendance has been holding steady, if not growing, to between 30 and 40 people a month. There is a didactic session. It could be something about pain management. It could be about spiritual care. It could be about substance use. And then there's a case discussion so that we are all learning together and from each other. It's been incredibly well received. And I think the other strong benefit from this is that it's really establishing a wonderful community so that colleagues realize they have resources in the state. We also started making plans for a statewide palliative care conference and had some really wonderful funding opportunities for that as well. But we've had to put that on hold right now due to COVID. It may end up being a virtual conference, but we at least wanted to see how things were looking in 2021. In addition, MIHAF has put out an opportunity for an improvement and innovation grant, and we submitted a letter of intent in 2020 to create access for palliative care in rural communities. And so we were excited that it was accepted, but then MIHAF put those sorts of grants on hold due to COVID, but that is going to soon resume. So we're excited for that. And then also some advocacy, some state and federal legislation related to palliative care. On the national level, there's a, all the acronyms, right? It's PCHETA, it's a Palliative Care Education and Training Act, to really make sure that medical students, nursing students, and others have a background in palliative care. And then most recently, we were so delighted that Representative Craven introduced LD 1950 in 2020, an act to advance palliative care utilization in the state. And while it was voted ought not to pass, Health and Human Services did ask that we meet and make recommendations on some payment models. So really, we spent all of 2020 doing that research and talking collaboration. We submitted the report in December and offered some recommendations. And I don't want to take away anyone's thunder. I think there might be a book report on that report coming up. So if so, that's fine. We don't have to discuss it in detail, but I did leave some of the recommendations here on the slide that we can discuss. So that is the work that we've been doing so far. Happy to take questions. I'll stop sharing the slides.
Thanks for doing that, Elizabeth.
Are there any questions from members of the committee at this point? remarkably quiet group this afternoon, so I don't see any questions. So Representative Craven.
Thank you, Mr. Chair. I just wanted to thank you both for your for the amount of work that went into this and the amount of work that you do constantly, and just good to see you. So thanks.
Thank you.
Are there any other questions / comments that people would like to raise? I don't see any. So you're welcome to stick around while we hear from Ms. Powell. And later on, there will be a couple of book reports, as was implied. So no pressure, though, on the book reportees. There's Candace Powell. Welcome, Ms. Powell. How are you?
Doing just fine, Senator Claxton. Nice to see you.
Nice to see you.
My gratitude to you and Representative Meyer and the committee for investing time and energy into hearing what we have to say. The Maine Hospice Council has done a lot of work over the years, for the last 30 years or plus. Actually, we've been in existence since 1984 as a volunteer group, and then we evolved into a more formal structure. And Anna, if you would put up the slides for me, I will, as you say, sing out and let you know when I'd like you to change them. I did put some thoughts in bulleted points just to make things a little bit easier. And for those of you on the committee who are new, just a little bit about my background. I was undergraduate. I had a degree in nursing.
Oh, I didn't do that on purpose.
Oh, that's okay. That's all right. I have a nursing degree, undergraduate degree, and worked right out of college at Boston University Medical Center in a cancer research unit. And I guess I share this with you by way of explaining my passion for end-of-life care is longstanding, probably a good deal of my life, actually, because of some personal reasons. But professionally, when I worked at BU Medical Center, I saw that very little was being done regarding the integration of families and patients into care at end of life. A lot of amazing clinical trials, but not a lot of family meetings, not a lot of conversations with families or patients. And it just underscored the very real importance of pioneering some work in the field. And I just share that with you because that has been my professional life. And the Maine Hospice Council was a group who formed in 1984 because hospice was coming into its own in the state of Maine and nationally, really. And there needed to be some coordination and collaboration amongst the emerging hospice programs. But it was difficult at that time. I was doing clinical work in the field at that time and looking on from the outside back in the late 70s to see what was evolving regarding hospice and end-of-life care. And was it here to stay or not? And so it interested me so much that I started doing clinical work and started a Medicare certified hospice program in the state. And then saw that there were so many other things to do at a more of a system level. And because of that, I was invited by the fledgling state organization. And don't get me wrong, it wasn't a Department of State government. It was and still remains an independent organization, but they needed some leadership to address the challenging system issues that were standing in the way of making progress with end-of-life care, access to and quality of end-of-life care. And so never being one to shy away from a challenge, the third time they asked me if I'd be interested in doing some policy work and program work, I was eager to move along in my own professional career. So as with hospice, it's become an evolutionary process. And it's funny, I like to say, even though we've made a lot of progress, some things don't change. And that's why I shared with you the Institute of Medicine report, because all of the things, all of the recommendations that they talked about in the Institute of Medicine report still are issues before us today that we studiously, in a dedicated, committed way, still work to achieve, and achieve to the point of making Maine just a model of hospice in the nation. And I think all the folks that you know that are involved in hospice, all the wonderful direct service hospice programs have helped make that happen. But we are still challenged by barriers to hospice. Access remains an issue. Quality always remains an issue, even though the direct service hospice programs do an amazing job. And there are many institutional barriers to where we want to go with hospice. There's a mismatch sometimes between needs of patients and families and the services that are available. And you know the challenges today with COVID and people staying with their loved ones at end of life. Inadequate specialist, we don't have enough specialists in the country in palliative care and hospice care. We don't have enough education and training for people, especially in palliative care. Hospice has done a wonderful job over the years, but there is still a lot of issues that our fragmented healthcare system sort of gets in the way of, and for us to make the progress we need to make. So the wonderful, wonderful dedicated people we have in Maine are a beacon for other states, for sure, with hospice. So I applaud them all. Anna, if you just show the next slide, please. This is our mission. We do a lot of innovative programming, and I do say that I want to make a point that after all these years, we still try to do everything on a needs-based format. We don't just one day, I don't drive to work thinking that, oh, wouldn't this be a good program to address? I want to make sure it meets the needs of people in our communities. And so two of the hallmarks of our work are based on what I just said, our outreach to underserved and disenfranchised populations. We've done a lot of programming around that. Now that's a big, huge, comprehensive category, and I can answer any questions that you might have about that. And I'm sure some of you have been familiar with our programs over the year, and if so, thank you for your interest in those. But we do try to be very innovative, incredibly resourceful with the funds that we have and the generosity of our donors. We try to be creative, and we try to do our work by promoting education, doing quite a bit of advocacy, and we do it with our partners, and we do it respectfully and collaboratively. Next slide, Anna, please. So again, we were established in 1984 as a volunteer state organization. We are an independent nonprofit 501c3. We do all of our programming, all of our ambitious program with 1.5 FTEs. And our board is a wonderful group of people. It's a multidisciplinary board. And our money comes from very diverse revenue sources. I learned long ago that the way to sustain an organization is by diversifying the revenue stream. And that really is, compared to some of my counterparts in other states, what has allowed us to continue for these many years. The average nonprofit, small nonprofits existence is between 6 and 10 years. So I guess we've exceeded that and then some. So my hat's off to all the people that have supported us and my gratitude. Next slide, Anna. So just to talk a little bit more about our revenue stream over the years, you can see here that it is quite diversified. And we have been very, very fortunate since 1989 to have an allocation from the Maine State General Fund to support our operational programming. And so if you have any questions at all about any of the revenue sources, please ask them. Sponsorships are something that that's another aspect of collaboration, and that has been ongoing for many, many, many years. Also, estate planning, we have received some very generous donations over the years from people we didn't even know who knew about our work because someone that they knew told them about it. So we get some money from Maine Share, which is a workplace giving campaign. But the primary revenue stream for us all these years has been just writing one grant right after another. And that's also a collaborative effort. And it has generated a lot of professional friendships. And I've met so many colleagues across the country because many of our grants have been for programming that not only, of course, meets the letter of the law with our mission, but many of our grants really have attracted attention. So when we write a grant and develop a program, we want to make sure that we create a template that can be shared and utilized by people in other parts of the country and also our international colleagues, because I've done quite a bit of international work as well. And that's really quite rewarding. Next slide, please. So see, these are some, for those of you who might not be too familiar with our programming, these are some of our partnerships, and they all have many, many dimensions to them, and I could go on and on and on and talk about them, which I truly enjoy doing, to be honest with you, but we don't have the time today. So I'll just mention a few. Right now, I'm working with 3 different students. One is a fellow, she's a physician, and she's looking for some counsel when it comes to her work going forward. And she asked if I would be a mentor for her. And I love to do things like that. I love to work with students and healthcare professionals. And we are going to be doing a lot of work with storytelling, so which is also something I love to do. And I'm also was just invited our organization to work with a former doctoral student that was here with us for 2 years. And she is now a PhD officially. And I received an email from her the other day. She would like to write a grant and do some collaborative work with us. So that's very exciting. And I'm working with another student right now who is going to be doing a stories project with us. So the mentorships and intern opportunities over the years have been numerous and just so rich and rewarding for everyone. And I'm sure that will continue. The Pulse Coalition and our work with the National Pulse Coalition has been an honor and a privilege, and POLST stands for Physician's Orders for Life-Sustaining Treatment. For those of you who are familiar with it, and those of you who are not, it is what I call a sister to the Advanced Directive document and program. And although the POLST program and initiative actually takes advanced directives and the wishes of patients and families and puts them into a medical order form, so they'll have a little teeth. So that's been an honor, and we are now privileged to work with the National POLST program on a new Hillman grant to see about increasing utilization of POLST in rural areas of Maine. And that will be extremely exciting. Not all the T's have been crossed or the I's dotted yet, but that's soon to take place this month. The Maine Pain Initiative has been in force since 1994, and that has evolved over the years and morphed really. Right now, of course, we have such a prescription drug issue in the state that the work we have done over many years with the Maine Pain Initiative, which is actually modeled after the University of Wisconsin, it is ongoing, but it as life changes and as the healthcare scene changes and there are different issues to deal with in the state, so do these programs evolve. The Palliative Care and Quality of Life Advisory Council, you just heard about that program from two very knowledgeable people who are co-chairing the advisory council this year and have for the last couple of years. And I love working with both of them, and we have and hopefully will be doing some very ambitious work going forward. And it's just a pleasure to see this evolve. And I understand the book reports will be presented in a little bit, so it'll give us another opportunity to speak to that. The Hospice Veteran Partnership, we were one of the first states in the country to develop that, working hand in hand with our VA system. And that's also a privilege. I do a lot of work with Pam Brown, who is the coordinator of the Palliative Care and Hospice Unit over at Togus right now, and as well as a lot of the staff over there. And that has really allowed us to do some other innovative initiatives, like the next one on this list, which is a trauma-informed care initiative. I was just on a webinar again with the Department of Veterans Affairs Central Office in Washington. And we were fortunate to get a grant on trauma-informed care. Even during the COVID situation, we managed to make it work. We had to do everything virtually, but we had a very robust webinar that actually attracted 174 people, both in country and out of country, who were interested in this topic. So I'd be delighted to answer more questions about that as well. But our partnership with the VA here in Maine with Togus is ongoing, as I say, ever since 2004. And again, we developed a template that is now used in all 50 states. The rural initiatives, you heard Lauren and Elizabeth talk a little bit about that. Through the Palliative Care and Quality of Life Advisory Council and our opportunity to write a couple more grants. But I've worked with the Jackman area for quite some time on that rural initiative, and we will be working with them probably on pulse utilization too, as a matter of fact, with the Hillman grant. So that's very exciting. I love the people up there. And that's a community, as most small rural Maine communities are, they just help reach out to one another, and they may not have a lot of material resources, but by gosh, they have a lot of resourcefulness, which I always admire. I put the Robert Wood Johnson Community State Partnership Grant in here just to let you know that that one was in 2000. It was a 3-year grant, very ambitious grant with many partners working on many projects. And that still continues in parts and pieces to this day. So again, a lot of the grants that we write and we develop have a longer shelf life because the next grant builds on the one before. And I'm sure many of you do that same thing with grant writing. And because of our international work, I'm fortunate. I was doing a presentation before the Human Rights Conference over in Edinburgh, Scotland. And out of that, and that was about our work at the Maine State Prison, the development of the hospice program there. And because of our work over there, the prison service in Scotland wanted to use our program template to be able to develop end-of-life care in the prisons over in Scotland. So I was asked to be a visiting professor at Robert Gordon University, and I do some teaching over there with their students as well. Anna, next slide, please. We offer many resources. One of the things I do love to do is when families call and they know they need something, but they don't know what they don't know. And just to listen to their stories and help them with resource direction and help them get in touch with their local direct service hospice programs for follow-up. And I love to do that. And it's a time investment, but it's a time investment that really is so appreciated by patients and families, as everyone in healthcare knows. I would like to mention a couple other collaborative programs that we're working on right now. And one is, it's called BEAM, B-E-A-M, and it's when Brenda Gallant mentioned Maine Healthcare Association, they're working on a grant for bereavement education. There's a lot of research out there that shows that the more bereavement support, the more end-of-life support, the more grief support that staff in long-term care facilities have, it really directly correlates with retention of staff. The more supported they feel, the more they probably will stay working for a particular organization or agency. So I'm really pleased to be a part of that. There are many wonderful people throughout the state that are also a part of that, but I was invited to be on their steering committee, so that's wonderful. And then up in the Bangor area, there's an acronym, a group they call Chelsea, which is a community hospice education and learning collaborative. And they have asked me to do a bit of consulting for them on that. So that's a privilege as well. Next slide, Anna, please. So just a little bit about some of the advocacy work we do and the policy work we get involved in. Just for those of you who are not familiar with the hospice licensure law, I just thought I'd put that up here on the screen. Again, that's longstanding for sure. And that was one of the first things we collaborated on. I remember when I first took the job here at the state, it's just such a pleasure. It's not perfect, of course, but it's certainly held its own over the years and given direction and safety and protection to the hospice programs and the hospice philosophy. The other one, the few that I'd like to mention is an act to improve end-of-life care in the state. And that we have been so fortunate to have the support of the Health and Human Services Committee and many of our senators and representatives. It's just been heartwarming over the years to see and feel and hear the compassion that everyone has for better, improved access to and quality of end-of-life care. And the Palliative Care and Quality of Life Advisory Council, of course, you have heard from Lauren and Elizabeth about that, and we'll hear more. And then Margaret Craven, Representative Craven's bill, which Lauren referred to as 1950, LD 1950, and may take on a new title of LR 1160. So more to come about that too. But we do have a role in looking at all types of policy and legislation that might impact end-of-life care. And when asked, we are privileged to weigh in on that with our experience. Next slide, Anna, please. So again, thank you so much for years and years of support from the committee. And we truly appreciate it. Thank you, Anna, too, for the slides. And I'd be glad to take questions from anyone.
Thank you, Ms. Powell, for decades of committed service.
You're welcome.
So Representative Craven, do you have a question yet?
No, I don't, as usual. Thank you very much, Mr. Chair. I just wanted to thank in full disclosure, I actually serve on the board, and thank Candace for all her work and all the information.
Thank you. Thank you.
Anybody else want to offer an affirmation? My wife is a hospice chaplain, so she knows Ms. Powell well and knows of her work. So, yeah. Any other questions? So I think we have been joined by the folks who are presenting the next session. So I was curious to know, sounds like Senator Moore has a succinct presentation, but we want to do justice to it and to Representative Zager's presentation. So why don't we postpone the two book reports, and we can give them their just time, and that'll just be another opportunity to revisit this subject area and let us get a little bit more comfortable with it. So if you won't mind too much, I know you had 13 PowerPoints lined up, Representative Zager, but if you can hold off, we'll schedule these for later on. So thank you again to Candace Powell for, like I said, decades of some impressive work that has benefited a lot of Maine residents, as has the work, the other work that was discussed earlier in the palliative care arena. So thank you all for that. So we've been joined by Dr. Pollard, and did I see there is Molly Bogart, and so those are the two new folks joining us. So I guess I will turf it to Molly for the next step.
Sure, thank you. Molly Bogart, Director of Government Relations for the department, and I am excited to share with you our last, but certainly not least, orientation to an office of the department. That's the Office of Behavioral Health. And for those of you who've been aware of their work or in the legislature, they used to be SAMS and were renamed in the last 2 years. And so with that, I will hand it over to our Director of OBH, Dr. Jessica Pollard.
Afternoon. Thank you for having me. It's my pleasure to introduce you to the Office of Behavioral Health. And I do have a PowerPoint if I can screen share. Mostly to keep myself on track, since I could talk about this all day. So I have a few slides to go through, and then happy to take questions. So I'll give kind of a high-level overview, but happy to go into detail if there are any questions or particular data points that you'd like to examine more closely. That'd be helpful to start with just a brief statement of our mission and vision. to get a sense of what we focus on in the office. So we are not simply interested in reducing symptoms of mental health or substance use disorders. We're really interested in the full continuum from prevention to recovery supports and everything in between, early intervention, treatment, crisis care, housing. And we do that through a variety of ways, through direct funding, through offering training and technical assistance, resources, education, sometimes direct certification of workforce. And our goals are really not just to reduce symptoms, as I mentioned, but to make sure people are living lives of meaning in the community, and that we take a population or whole health approach when thinking about behavioral health. I thought it'd be helpful to start just with a quick overview or snapshot of the behavioral health of the state. This is according to the National Survey of Drug Use and Health conducted by SAMHSA on a yearly basis. So the data is behind by 1 year because it takes them quite a lot of time to survey a representative sample of households as well as compile the data. So these data represent 2019. And just to orient you to this table, where there is a bold font and an asterisk, that means it is a statistically significant change from a prior year. So I'll walk you through just briefly where we stand in terms of some of these high-level stats for Maine compared to the nation and compared to where we were the year prior and the decade prior. So we are in the highest quintile. So the states are broken out into 5 segments from lowest to highest. We're in the highest quintile for illicit drug use. Interestingly, when you break out marijuana or exclude marijuana, we fall closer to the middle. We're more in the middle of the pack when you don't consider marijuana in that list of substances in the statistic. We're right in the middle with respect to cocaine use, and on the lower end with respect to methamphetamine use. And not surprisingly, given what I said at the beginning, we are among the highest in the state. I did not intend that pun. For marijuana use. And that is up from the prior decade as well for us, as well as for the nation as a whole. So, so the marijuana use is increasing both from a decade ago and from last year, but that is true of the nation also. And to make a further point about methamphetamine use, the national trend is for an increase compared to prior year, but that is not true in Maine. We seem to be holding steady. And similarly for pain reliever or prescription pain medication, we are not significantly increasing there, though the nation is. And I think surprisingly to me when I looked at these data, that we're in the middle with respect to alcohol use disorder. I expected that to be a higher statistic given the rates that we do see in Maine, that we aren't on the higher end compared to the nation. When we look at things like whether or not somebody received treatment who would have been categorized as in need of treatment, we are on the upper end of people who didn't receive but needed a specialty SUD treatment in the past year. That is not an increase, that's remained somewhat steady. And in the middle of the pack, similarly with alcohol use disorder. And while the US as a whole is increasing with respect to the proportion of people who didn't receive needed treatment for illicit substances, Maine is not increasing there. We are right on par with the national average for rates of any kind of mental illness or mental health challenge, but we are not increasing the way the rest of the nation is. And when it comes to serious mental illness, we are up from the prior decade, but not from the prior year in terms of the rate of people who would be categorized as having a serious mental illness. And pardon me, I'm just trying to move some things around so I can see my whole screen. We are in the highest quintile, which in this case is in a good way for people who received mental health services. So while we have a high portion of people who need treatment, we also have a high portion of people who are in treatment for mental health. we're somewhere in the middle with respect to the very serious metric of having made a suicide attempt or having serious thoughts of suicide. We are in the highest quintile for that particular measure, but have not increased over time. So in looking at a variety of different data points, I'll just make a few highlights here. We continue to be very concerned about the rates of fatal overdoses, both from opiates as well as a variety of substances that are involved. While the fatal overdoses in the most recent quarter are slightly down from the prior quarter, they are still significantly higher than they were for the year 2019. And that remains, that is also true for the rest of the nation, but that does represent a significant increase. When you look at the trends of use, opiate use, or at least prescription opiate use, is significantly down from where it was about 6 years ago. And thankfully, medication-assisted treatment is showing the opposite trend, which is to significantly increase over time. Moving over to the crisis system, thinking about how COVID-19 may have affected our utilization of crisis services, we do see what represents a significant increase in calls to the crisis line from pre-COVID months to post-COVID months. And what's assuring or slightly reassuring is that the proportion of those calls that were deemed serious enough to be referred to emergency medical services or mobile crisis response isn't increasing. It's actually down slightly. And thinking about what are the dispositions of those calls. So when somebody calls the crisis line and is in need of help and support, what's the portion of those that are so serious that the person is hospitalized even against their wishes? That is 2.5% on average. And the metric of rehospitalization post-psychiatric hospitalization discharge is thought to be an important indicator both of the quality of the inpatient service itself, as well as the availability and quality and handoff to community services. So you can think about this as a proxy for the relative health of the system. That statistic of readmission within 30 days of inpatient discharge in Maine averages 8%, which is significantly lower than the national average, which is somewhere around 17%. BRAP, which is one of our housing programs out of the Office of Behavioral Health, it's a rental assistance program for people with serious mental illness. We are very pleased to say that that has not had a wait list for vouchers in well over a year. When people are issued a voucher, which is on average within a few days, they are housed 77% of the time when they receive the voucher. And of those who are not yet housed, 14% of those have just recently received a voucher. And on average, about 70 are housed within 1 month of getting that service. So to put things in a little bit of perspective, we are concerned when we see any service closures. And I should note that this is not a comprehensive list. This is a selective set of services that I looked at recently. We also saw, though, 12 mental health agency licenses come online. So 12 new mental health agencies opened in 2020. And looking at a select group of services, we saw 27 new service locations. So agencies that maybe were already licensed, but added a new area of service over the past year. And for our mental health block grant, we do client satisfaction surveys. We take a representative sample of people with serious mental illness, or rather we have a company that does that for us. So thousands of people are surveyed. And we're happy to say that all of our perceptions of care domains have increased in the positive or the good direction in this most recent survey. And 90% or most of those measures are over 90% satisfaction. To orient you to the roles and responsibilities of the office, we are recognized federally by the Substance Abuse and Mental Health Services Administration as the single state agency for both substance use and mental health. That means a variety of things in terms of grants, like the block grants, but also having to make public health impact statements on the grants of external agencies who may be seeking funding. SAMHSA, which is the Substance Abuse Mental Health Services Administration, also has designated the Office of Behavioral Health as the state's opioid treatment authority, which largely has to do with oversight of the methadone clinics, or what we call opioid treatment programs, or OTPs. So those require federal certification and a state level oversight. Our general role, I would say, is that we both develop and oversee programs, engage in making sure those programs remain of high quality. We have rulemaking authority and, of course, set state policy. We are the responsible entity for the state's prescription drug monitoring program, of which we'll receive a detailed report, I think today or tomorrow. And we also play a variety of roles around protection and advocacy for people with serious mental illness in terms of the service coverage for people who do not have insurance. We cover the people who are both uninsured and in a few cases underinsured. So they may have an insurance, but it doesn't cover needed behavioral health services. And then for services that Maine Care does not cover, we fund those sorts of services. So an example would be peer-run recovery agencies are not Medicaid reimbursable, so those are funded out of our office. We have responsibility directly for some components of the behavioral health workforce, which I'll talk about on a later slide. But also, generally, we try to enhance the competencies and support to the behavioral health workforce through trainings and other kinds of programming. There's a Baxter, it's not a consent decree, but a kind of class action for abuses that occurred at Baxter School for the Deaf. Our office oversees the funds that pay for the treatment of individuals who experienced those traumas. So we administer that program for funding the therapy of those individuals. We also take a lead role in the work around the AmHi, the Bates versus AmHi consent decree, which I think you will soon hear from the court master, Judge Dan Wathen, about that and some of the recent progress that we have made there. And then some people don't realize that the 211 program that's administered by the United Way is contracted through our office as well. So just a shell of our leadership structure. There are certainly a lot more details than this in our organizational chart, which I'd be happy to walk people through if they're interested in more detail. We have a head count of 76. That spans a number of programs, a data and evaluation team, state forensic service, our driver evaluation education program, or DEEP, the grants, contracts, and finance team, residential mental health services, community mental health, substance use treatment, opioid response, our housing and recovery team, and our intensive case management program. I think those are all of them off the top of my head. So we have a program financial officer who manages the finances. We are very thankful to have two limited period deputy director positions, one of research and evaluation, which is in line with an important initiative of the office, which I'll talk about on a later slide. Deputy Director of Strategic Planning. This position oversees our grants and finance planning, as well as our housing and recovery teams. So we're very fortunate to have two highly capable individuals in those positions. I would say our grants management, we brought somebody on who has over 20 years of experience with grant writing and has literally taught the courses on grant writing and management, which we are especially grateful for these days when we are seeking every federal grant dollar we can. And a highly competent Director of Research and Evaluation who has a significant background in both research, but also medicine and technology, which has been extremely helpful in recent years, or in recent months, I should say, particularly around the enhancements associated with our PMP. State Forensic Services falls under our office. We also have a senior policy advisor who oversees the both rulemaking process, but also grievances and rights of recipients violations out of that team. And new to the office structure, I did a significant amount of restructuring when I came on board about 18 months ago. And we also now have a clinical director position overseeing the office. So there's a lot of detail here. I won't describe all of our programs because, as I understand, I only have 90 minutes. But just to walk you through some of the broader categories, our mental health services have a residential component, but also mirror some of the Section 17 and Section 65 services of main care. So crisis services, med management, sort of community treatment, daily living support services, and so forth. And we also have a few specialty programs, such as the early intervention program for transition age youth in the early stages of psychotic disorders, and a veterans case management program that we finished a pilot phase of last year and decided to continue due to the successes of that program. Our SUD services are wide ranging from counseling services, coaching, all the way to residential or detoxification services, and certainly spanning our intensive outpatient and include a fair amount of naloxone distribution through a network of distributors that we've set up over the past few years. We have a variety of housing programs in our portfolio. I mentioned BRAP, which is Bridging Rental Assistance Program. We also administer the HUD-funded Shelter Plus Care. We are just entering our second year of a recovery residences pilot, which we offer a subsidy to programs, recovery residences that are or become MAR certified. So those are certification standards that ensure quality and safety and a variety of other standards. So we work with the Maine Association of Recovery Residences to provide that certification, training, and quality oversight. We have our PATH program. We have a straightforward rental subsidy, it's kind of what it sounds like. And then we have our PATH program, which is programs, oh goodness, now I have to remember that acronym, programs for assistance to transition from homelessness. That is a program we get a small amount of funding from SAMHSA, and then the rest comes out of our state general fund to help individuals who are literally homeless access housing. We've been working with Office of Main Care Services around supportive housing initiatives, and I can talk a little bit more about that. We have the House pilot, which is Homeless Opioid User Service Engagement. That is a pilot program arising out of previous legislation for people who are challenging to engage. We're using opiates and include one rural site and one urban site. So it's a small number of individuals who are getting highly intensive and specialized services. And then we have a few specialty residential level SUD programs, the Florence House and Macaulay House. I am pleased to say we have expanded our staffing and resources dedicated to our recovery programs. So we have a variety of different peer services. So peers being somebody who has lived experience. Typically when I say peer, I'm referring to somebody with a self-identified mental health condition who has a particular training or certification, training and certification. Sometimes the term is used more broadly for anybody with a behavioral health condition. Usually we make the distinction of peers being mental health and substance use being recovery coaches, but that could be used interchangeably in some instances. We provide peers, mental health peers, and recovery coaches in emergency departments. So we have expanded both of those programs significantly over the past year. We fund a variety of recovery centers around the state, both mental health and substance use. So these are important places for people to go to receive support, assistance with employment, developing important life skills, and having a sense of community. We administer and fund supported education and supported employment programs, some of which is in collaboration with Department of Labor. We know that work is therapeutic. There is a lot of research that demonstrates for people with mental illness, sometimes outcomes even surpass the outcomes of medication management when somebody is supported in working. We work with our Consumer Counsel System of Maine around policy and developing different initiatives and looking at different areas of programming, getting feedback from a network of consumer councils across the state. We provide family support and education in a variety of ways. We have a small non-emergency transportation for people to access supports, to access transportation to get to services that are in their treatment plan. And then we also fund the Intentional Peer Warm Line, which is a 24/7 support line staffed by people who have lived experience with mental health conditions. A portfolio of criminal justice related programs. So as I mentioned, we have the State Forensic Service. We also have an intensive case management program. So we have 18 intensive case managers at present. When I came on board, they were initially doing jail reentry work, so supporting people who were incarcerated or who were coming out from incarceration to connect to supports in the community. Over the last several months, we've made a transition to some of that work being, or some of that resource being dedicated to pre-booking diversion, so trying to assist people before they get to the point of arrest and incarceration, working heavily with our mental health courts. And you'll see that we have a budget initiative for what we're calling our Justice and Health Team, which is an expansion of that intensive case management program to cover more components of where people might intersect with the criminal justice system. And then in a variety of ways, we support the mental health courts and drug courts. We help fund the Department of Corrections MAT program. We fund the crisis intervention training for police and the driver education evaluation program. In terms of workforce, I mentioned peer certification. So we have training and a certification process. The model that we employ is intentional peer support. We are interested in exploring whether or not other certifications might be of value to peer professionals in the state, and have had a series of conversations regarding the possibility of opening up to additional models. We have oversight of the mental health and rehabilitation technician certification, of which there are 3 types. That is in cooperation with the Muskie School. We have recovery coach training. We've trained, I think at this point, close to 500 recovery coaches. We offer a number of conferences, trainings, fidelity monitoring, and have recently made some investments in medication management workforce, as that is one of the most challenging areas of workforce in really all of medicine. It ranks up in the top 1 or 2, or among the highest, most challenging to recruit professions nationally. So a quick list of some of our priorities and initiatives before we go into the details of them. I will say that I didn't include specifically a slide on addressing racial and ethnic disparities. That is something we're trying to weave throughout the initiatives in which we're engaged. But specifically, we've done a lot of work around our Strengthen Me program, which I'll talk about, and engaging with community health workers as a way to connect with individuals who might not be best served or feel most comfortable with the traditional mental health system. And that's work we're interested in continuing and expanding. And then I have a few more details about each of these initiatives. So I think you'll hear soon from Gordon Smith, our state's director of opioid response. So I won't go into all of the details on our very lengthy state strategic action plan on our opioid response. I will highlight the options initiative, since that is relatively new and may not be familiar to the members of this committee. It's our overdose prevention through intensive outreach, naloxone, and safety. We are very pleased with how this program is rolling out. It involves 2 major components: teams in each of our 16 counties and a public health campaign. So you can see more about the campaign at knowyouroptions.me. That launched a couple of weeks ago across radio, TV, bus stop, physical ads, social media. And that campaign has both a public-facing component as well as targeted to people who are affected by opiate use disorders. And there are some very important calls to action in the campaign. We know from the data from the Office of the Chief Medical Examiner that there's a significant portion of overdose fatalities of people who are alone at the time of use. And so there's no one there to administer naloxone or call 911 and have a chance of reversing the overdose. So one of the very important messages in the campaign is helping people recognize the danger of using alone, as well as developing alternative strategies to using alone or safer use. So a really important harm reduction component in the campaign, and as well as the teams, which I'll talk about in a moment. Continued messaging around how to get help, whether that's recovery supports, treatments, or harm reduction, depending on where the person is in their journey. The importance of having naloxone on hand, which is a continuation of our prior Have It On Hand campaign, both educating people about naloxone, although we were pleased to see in the evaluation of that campaign, there's pretty good public understanding about naloxone, but also where to get it, how and when to use it. And we also want to make sure that we remove any hesitation or barriers to people calling 911 when an overdose is suspected. So the Good Samaritan law is a key part of that public health campaign to make sure people understand that law and that they can call 911 when an overdose is suspected, even if opiates are on the scene, without fear of arrest. Some of the key components of the more boots on the ground part of the Options Initiative, the teams that are in the counties, those are staffed by substance use clinicians, as well as supported by recovery coaches and harm reduction professionals. So it's a combination of evidence-based strategies, including co-response with first responders. So in some counties, that's law enforcement, in some it's EMS, and some it's both. So that's been developing nicely with the agencies that are involved in the options program, the behavioral health agencies, developing these really strong partnerships. We've been very pleased to have the support of the Department of Public Safety and really getting enthusiastic response from the community on this program. The goals are really to follow up post non-fatal overdose. So when there's an SUD related call or an overdose call, there's both a co-response component as well as follow up a day or two or more after, or a continued engagement after the non-fatal overdose, because we know that individuals who've experienced a non-fatal overdose are at significant risk for a fatal overdose, as well as proactive outreach from referrals from the community or other sources when people are not necessarily actively engaged in treatment. So for example, homeless outreach, since we know that the proportion of people who are among the individuals we lose to opiate overdose who are homeless has increased. This also includes specifically connecting people with a warm handoff to different resources and naloxone leave behind. So while there are a variety of ways that the general public can get or obtain naloxone, we want to remove any possibility that somebody doesn't have it when they need it. So among the support systems of people who've experienced a non-fatal overdose, we want to make sure that they have naloxone on hand. So the program includes a naloxone leave behind component. Just a visual of the stat that I mentioned, or the two stats I mentioned before, to show the decline in the prescribing of opiates over time. And the increase of buprenorphine or Suboxone over time. I will say that we continue to be concerned about the illicit opiates, of course, especially the unpredictability of the supply, the high likelihood of fentanyl and other substances being involved when we see the overdose fatalities. We have an initiative we call Map and Match, which has three primary goals: keeping people out of higher acuity settings and out of incarceration. We want to make sure that people have timely access to the right service or what's appropriate for them at the time, And then identifying where we might see gaps in the array of services in the continuum, as well as where there are gaps geographically, where there is a service need that doesn't exist in a particular county or community. We have a number of activities involved in this initiative, but I'll just highlight a few of them. We have a service locator. I don't know, I should have checked to make sure Director Probert talked about this when she presented MaineCare. But we just made that award for what we are calling a service locator. The platform is Open Beds. We're really excited about the potential of this resource. So it will give people much more targeted searches for finding what the right level of care, what the right type of service is. So we see that when people use, for example, 211 or the SAMHSA treatment locator tool, a couple of things can happen. We don't see a lot of detailed breakdown in the existing SAMHSA treatment locator tool, so they're pretty broad categories. The 211 platform doesn't necessarily give people guidance on what kind of service might be appropriate for the level of severity they're experiencing. So the Open Beds tool has screening functions, and it has the potential, if we can get this rolled out within the provider community, real-time capacity information. So not just searching and getting a list of who are the treatment providers in your area, but who are the treatment providers in your area for the level of service that you've been screened to need, and who have an opening or who are declaring that they're accepting new clients. There's a lot of functionality in the tool that we're exploring, such as referral to referral, provider to provider referral, and self-referral and communications with providers through this interface. We are working with our partners at 211 so that they know how to use this tool, so that when callers call 211, they can also get more specialized assistance if they're not comfortable using the web-based tool. What this will also do is give us behind the scenes data of where the pain points are in the system. So a lot of the data that we have available to us now is really about who's already getting services. And then we have this national level data that I showed you at the beginning about who by self-report needs treatment but isn't getting it, but we don't have really specific breakdown of that information in order to know in what parts of the state is there more of a need than there is of a supply for a particular service. So behind the scenes, we can look at these data to see what are the searches that are coming up empty and what can we do to fill in those gaps. So this really, I think, has the potential to be a game changer. You'll also see a budget initiative that we have in to expand the diagnostic categories that are part of our existing intensive outpatient program, or IOP. So currently under MaineCare, the only diagnosis or primary diagnosis that is that has an IOP is substance use. So one of the first things that was that I noticed in stakeholder engagement when I came on board is there's no mental health intensive outpatient in the array of services that we cover. So collaboratively with MaineCare, Office of Child and Family Services, and the stakeholders in our state have developed mental health intensive outpatient, which includes some specialty populations, eating disorders, a partial hospital program, dialectical behavioral therapy component, IDD, and geriatric components, as well as adolescents. So this will make our intensive outpatient offering in MaineCare much more robust and complete. We want to continue to increase access to MAT. So there are a number of prescribers, but not necessarily who have very many patients per prescriber. And there are some areas of the state where it is very difficult to directly access MAT within the community or medication-assisted treatment. Some of the other goals and activities we're working on is to increase the residential programs for substance use services. So you may have heard about our substance use disorder 1115 waiver, which will allow us to expand the number of beds per facility, developing rate and increasing the availability of early intervention services, the coordinated specialty care that I mentioned earlier, So looking at that as kind of a package of services and in collaboration with the two large health systems around how to provide statewide coverage of that evidence-based service. And then the telehealth component, this, if you would want to think about what might be a silver lining to the pandemic, you could really look at the success of telehealth. We know that not everybody is comfortable with telehealth or even able to access it due to resource limitations. But for a state of our size and challenges around access to transportation and childcare and just the sheer distance, the fact that the telehealth uptake during the pandemic was so significant, at some points, a 90-fold increase in main care telehealth claims over pre-pandemic averages, that has the potential as well to significantly improve access. So our criminal justice, improving criminal justice outcomes. I mentioned that we have an initiative, a budget initiative that we're calling the Justice and Health Team. So this expands our existing intensive case management program to pre-booking diversion, mental health courts, or community-based diversion, so not just the jail-based work that we've done historically. We are very close to or actively developing community placements for competency restoration and other times where it may not be necessary for an individual to go inpatient in order to have an evaluation or other forensic service. So the person may not meet an inpatient level of care, but a judge may not feel comfortable having the person be completely unsupervised in the community. So we've developed some concepts around residential placements that we think will dramatically ease the strain on the system in a variety of ways. We are excited about the continued work on our crisis center implementation. That has a component that will give law enforcement an alternative to bringing somebody to jail or to the emergency department if law enforcement is involved in a situation where there is a behavioral health crisis. I may have alluded already, we have a variety of supports within jails and the Department of Corrections, so medication-assisted treatment as well as peer supports, the crisis intervention training, and then I think this morning you heard from my colleague, Superintendent Buffard, about the Act to Increase Availability of Mental Health Services for IST defendants. And we also have an LD that is really related to when an evaluation may be necessary for somebody who is found not competent and not restorable. We had a lot of work to do to improve the quality and integrity of the data that we collect out of our office, as well as the range of data that we make available to ourselves and to our stakeholders. So I mentioned before, that's a new position, Deputy Director of Research and Evaluation. We have engaged in a pretty significant undertaking to automate data collection that should be rolling out really any time. The interface itself is ready to go, but we're trying to be mindful of the lift of provider training associated with that. The good news about it that I think will make this something that the providers will appreciate is that it gets rid of duplicative systems. So we had a variety of places where we had to ask or require providers to enter data in order to be in compliance with federal regulations and federal grant reporting, both on the mental health and SUD side. So some providers may have been entering information into 3 or 4 systems. We really thought it was important to reduce administrative burden to providers. So you may have noticed if you looked at details on the curtailment initiatives that we eliminated a few licenses, software licenses, and that is because we've moved the data collection into the Kipro Atrezo system, where a lot of providers, or almost all providers, any who receive main care services anyway, already have to go to do a lot of the work associated with billing for main care. So seeking prior authorization, registering clients in the system, continued stay reviews, and so forth. So that both eliminates redundant data collection. So we know the data points that are already in KeepRow and can very selectively add the ones that we need to. And also, we hope fits in better to provider workflow since they use that system anyway. Work around consent decree compliance. I think Judge Wathen will be presenting to you soon on the new standards that we've developed. I'm happy to say we finally have a supervisor of data and research as of a week or two ago. We have our OD map tool, which I'm happy to talk about in more detail if people are interested. That is a system that allows us to monitor overdoses and issue spike alerts. Anyone can sign up for this. So it is used by emergency response to enter that information so that we can see at least some, not all, but some of the overdoses around the state. There's very good participation in that project, and anyone who's interested can sign up to get ODMAP alerts. We have a partnership with Portland Recovery Community Center for a recovery data platform. We are just about to launch an opioid response dashboard, which will give people easy access to a variety of important metrics. And just in general, working on overhauling our performance measures for the purposes of quality assurance. So they really needed a lot of revamping in our contracts to make sure that the performance measures we are collecting were really tied to meaningful outcomes and goals. And a lot of these things that I've mentioned where we're overhauling systems also just selfishly lead to significant efficiency for our office, which means our staff will have more bandwidth to engage in some of the high quality work that is otherwise sometimes crowded out by the fact that we have been doing things via email, fax, paper. It's just not terribly time efficient. So we mentioned some of the statistics on BRAP. So we continue to want to improve housing outcomes, so decrease the number of individuals who are homeless and maintain stable housing once people get housed. So people are probably familiar at this point with our change to BRAP policy, where we lowered the income contribution requirement to make the BRAP program more affordable for the individual receiving the voucher. So taking a smaller portion of their income, which has been very well received, to allow people to afford their other living expenses. We've expanded, or just about to expand, our PATH program. Over the years, we've expanded from 1 provider to 3, but in collaboration with the providers of this program, I think we can scale this up even further to add staffing so that we have more people engaged in outreach and case management around housing specifically to people who are literally homeless. I mentioned we're continuing our recovery residence pilot with Maine State Housing Authority. That has led to an increase in the number of certified homes, and I believe we're currently supporting 13 or 14 recovery residences. We're working with Maine State Housing on development of a permanent recovery housing. So like we do on mental health, try to have a continuum of housing options, same on the SUD side. Maine Care may have mentioned this in Director Probert's presentation, but they engaged in an innovative accelerator program with CMS to develop a unique rate for permanent supportive housing health home. So this would be for individuals who really struggle with chronic homelessness to get tailored supports that will help them maintain housing once they access housing. That should be rolling out in the next couple of months. That, I think, will cover a gap in policy that existed. We've, in a variety of ways, offered support, behavioral health supports in shelters. I mentioned the house pilot, and we are, because of our role in the Shelter Plus Care program, participating in the rollout of coordinated entry to make sure that there's a kind of coherent process for how people access different housing programs, which is a directive of HUD. Crisis services. So we want to make sure that we have a complete continuum. According to the SAMHSA best practice guidelines for crisis care, we have many or most of the key components of crisis services. So we have a statewide crisis line that is 24/7. that's connected to mobile crisis response. So if the issue cannot be resolved by phone, then is referred to a regional mobile crisis team. We have we've divided the state into 8 regions. And I should add that the tribes have also recently developed a crisis service. So the 8 public health districts plus the 9th tribal district. And then we have crisis stabilization units for people who maybe need extra support rather than waiting till next appointment in the community, but who don't need an inpatient level of care. So those are some of the essential ingredients to a complete crisis continuum. Some of the pieces that we have been missing are what are sometimes called receiving center or crisis center. So no kind of 24/7 walk-in access. And we also don't have what sometimes is called care traffic control, or an integrated system that allows you to track a person through crisis all the way to the point of handoff to ongoing services post-crisis. So I described the options program. I won't repeat that, but we want to look at some areas for performance improvements. So the data in some ways look pretty good in terms of crisis response, but we want to take a deeper dive into these data to see if there are areas where we might want to target some improvement. So for example, it's a small, yes.
Dr. Pollard,
Yeah.
can I give Senator Baldacci a question?
Oh, sure. I'm happy to. I could have opened up for questions at any point. Absolutely.
Thank you, Ms. Pollard. The question I had, as you probably know, Bangor is a center of a lot of medication-assisted treatment. And what I would like, in the interest of time, because we could spend about a week just going through this stuff in more depth. But if there's a possibility you could work up a memo or something, I would really appreciate some of those statistics that you had on drug abuse and substance abuse focused on the Bangor or Penobscot County area. I'd also like to get information in terms of the amount of money we're spending in treatment in the Bangor, Penobscot County area, and whether there are any other sites other than Bangor where medication-assisted treatment is happening in Penobscot County. I'd like to get some statistics, essentially kind of focused on my district or general area. This has been an issue of concern, if you will, for the greater Bangor area. Many people, and I've served on the city council, feel that we're have an inordinate burden in terms of the location of the treatment. I don't know if you've heard that argument before, but it's been discussed many times over the past couple of years. With that, but I'd like to get statistics on Bangor and Penobscot County in terms of those issues, if we could, and also about drug abuse. It might be helpful for further discussions. Thank you.
Certainly, we have a lot of statistics that we can share about substance use in a regional distribution, both in terms of the individuals who are suffering from substance use disorder, as well as where the treatments are located and the expenditures around that.
I think all of us would welcome that kind of more local information if you could provide that. Representative Madigan, did you have a question?
Yes, I had 2 questions. I'm allowed 2. First one is you mentioned the 12 new agencies and 27 new locations, Dr. Pollard, and thank you for being here today. I'm just wondering if we can have information about where those agencies are located. I'm interested in learning about, there's been a lack of services in some of the more rural areas, so I'm interested in learning where that's going on to see whether that's actually improved coverage for folks that really need it. The next question I have is just about the biennial budget, the 7.5 million more for behavioral health funding. If there could be more specifics about that. I know we've talked about rates. I'm glad to hear about, IOPs and things like that, but if we could have an idea about kind of, is that new initiatives, is that going towards addressing rates so that some of the workforce challenges could be addressed, and then just money from the next COVID package. You know, there's upwards of, I think, over 30 million possible for that. So how are we going to address kind of the mental health challenges of the pandemic? Thank you.
Representative Craven.
Thank you, Mr. Chair. I would like to know if you have any culturally sensitive programs underway. We are having a lot of substance use disorder here in Lewiston, but really having difficulty with services that would be inclusive for people who have language barriers or who have other kinds of cultural needs. Thank you.
Shall I hold my answers or just?
Why don't we let you finish up your presentation, and then I understand you have a limited number of slides left, and then we'll go around and make sure everybody's had a chance to ask questions, and between you and Molly, we can get done whatever we can get done within the time remaining.
Sounds good. I will hold in mind workforce, new expenditures, and culturally specific services. And thankfully, I have some slides about that already planned. So on the crisis continuum, we have increased supports within emergency departments. And then I just also want to make sure everyone is aware of the 988 rollout. So this has been a long time coming at the federal level. People may be aware it is difficult to get a 3-digit number, but thankfully, after a lot of efforts, 988 will be the replacement for the 10-digit National Suicide Prevention Lifeline. People may be aware that though the number is an 888 national number, those calls ring locally. Maine has among the highest answer rates in the nation, meaning we take care of callers from our own area code. And I really think that a 3-digit number could be a game changer. We know that despite having a 24/7 mobile crisis line, people still present to emergency rooms or they call 911. And maybe that, at least in part, is because it's an easier number to remember when you're in a crisis. It's hard to remember a 10-digit number. So we are excited to have gotten a small planning grant for this, and we'll be rolling out a stakeholder engagement with Department of Public Safety, our crisis providers, and others to make sure implementation goes as smoothly as possible to transition to that number. And just a quick data snapshot I mentioned, so this is just the visual showing the increase in number or volume of calls to the crisis line, but relatively steady, if not decreased, acuity of those calls over time. And then I think sometimes we hear a lot about the outliers or people who are waiting a really, really long time for crisis response. But in terms of the data, the majority of the responses are within 1 hour, and then up to around 78% in under 2 hours. So I think I'm wrapping up here pretty quickly. The behavioral health workforce, I already mentioned our 2 certification programs and a variety of other ways in which we're supporting the behavioral health workforce development. I think that, I think we have to acknowledge the challenges of workforce in general. So while there are some areas that I think acknowledge that rates are a challenge in terms of workforce recruitment and retention, I think it would be unhelpful to see that as the entire explanation of the situation. We have an understanding that there's about 2/3 of our psychiatric physicians who are nearing retirement age in the next 5 to 10 years. We already know that's a national shortage. Same with psychiatric nurse practitioners being among the most sought after for recruitment categories. And then we have an older population. A higher proportion of our population are older adults, so harder to get that younger workforce. And we're competing among other industries who also, up until relatively recently, enjoyed lower unemployment rates. And I have seen in some areas, even when we are kind of paying cost, so rate is not really a factor there because we're paying the cost of delivery of the service, still having challenges sometimes in staff recruitment and retention. So I think there's a more kind of comprehensive set of solutions that are needed there. And we're exploring a variety of different potential options, including CCBHC model and other kind of thoughts of, or kind of creative policy solutions to increase recruitment into the field. There was something mentioned about COVID response. This is obviously a lot of detail. We have engaged in a wide range of activities in order to respond to the pandemic. Into these categories, I would say, maintaining access, making sure we had clear, frequent communication, getting financial supports out, monitoring metrics, particularly around some of the crisis services, and then tying into the question that was asked, I think a couple of questions, but our COVID specific mental health and resilience response, I want to talk about, because that answers a couple of questions. So that initiative is called Strengthen Me. We obtained a $4.7 million FEMA SAMHSA grant to roll out this initiative. It involves around 19 community partners, a significant portion of which are ethnically based community organizations that deliver services in the languages of the individuals who have been, who are served by those agencies, but also who have been disproportionately impacted by COVID-19. So we are, I think, in 7 languages and staffed through community health outreach workers. So people who are trusted and known in their communities, who we've trained in a model that you could think of as emotional or psychological first aid. So we have offered, this slide is a little out of date, over 27,000 contacts, or have made over 27,000 support sessions through Strengthen Me. We've been ranked one of only 15 states who are deemed as on target for behavioral health response to COVID-19, according to the National Safety Council. And there's a lot more information about that on our Strengthen Me website about that initiative. We also were thankful to recently receive the $2 million emergency COVID grant that we applied for back in April, but has since been made whole in the federal appropriation and awarded to Maine. So this is just a visual talking you through, or walking you through some of the layers of our COVID response. So people who are most directly affected have the, so people who are COVID-19 positive or quarantine exposed, we have particular supports around that. And then, as I mentioned, disproportionately affected groups. So different racial and ethnic groups, elderly individuals, teens, the workforce that is most on the front lines of the pandemic. We have specialized supports for all of those populations. And then kind of getting out to the outer layer, people who may be predisposed to being more affected by high stress situations or distress vulnerability. So those are our transition age youth who we serve through the NAMI Teen Text line, the expansion of our intentional warm line, which had a volume increase of over 40% since the onset of the pandemic, and then additional supports out to our behavioral health agencies, as well as our public health campaign. We have a website for that, but are just about to issue our RFP for the ongoing broad public health work associated. We have some small pieces that have rolled out. Maybe you've heard our sponsorship on public radio, but our robust campaign has not yet launched for that. And with that, I think that this is my last slide. And so I don't know if that answered your question, Representative Craven. We do really feel good about the work of the variety of organizations that we've worked with to deliver services that are culturally specific and in people's native languages or people's preferred or in some cases only language. We've translated a bunch of our materials, but I think really it's important to know that work has been happening face-to-face out in the community with the Strengthen Me program and those partner agencies. And we have a strong interest in trying to continue that kind of work even, after disaster or after the need for the Strengthen Me campaign goes away, since we recognize that not everybody accesses services in the same way. I think.
Thank you. My concern was mostly regarding substance use treatment locally, where people can attend and get service. Thank you.
And whether that's a, sorry.
Excuse me. Go ahead, Dr. Pollard.
I was just going to say, and it sounded like you were also interested in whether or not that would happen in people's language if English is not a first language. There are tribally specific substance use services. I can't tell you the details off the top of my head about the few programs that are developing around SUD in different BIPOC communities. Certainly a lot of stigma challenges to overcome there in terms of treatment access.
Representative Stover, did you have a question?
Thank you. And thank you, Dr. Pollard, for the great presentation. I appreciate that. I recently met with a group of healthcare providers down in my area. And one of the subjects that came up, which won't be a surprise to you, are the number of adults, even during COVID, who are showing up at the EDs, that is not new. However, they're staying for long language stays. One was mentioned that had stayed in the ED for 2 weeks. And I'm just wondering if any of your new initiatives and or housing initiatives, especially for some of those more, you described them as being more system involved, any of the new initiatives might assist with this and alleviate some of the stress that is being reported from the emergency departments. Thank you.
Yeah, for sure. I think the crisis center is one that is an alternative to going to an emergency room. I think intensive outpatient level of care helps avoid people getting to the point of crisis, as well as gives people a more ready path to discharge from inpatient, which keeps the flow of those inpatient beds moving a little better. So sometimes when someone's stuck in the ED, it's because there's not an inpatient bed available. So really kind of keeping things moving through the system. And then, in terms of residential placements, we've seen an increasing number of beds in our PNMI system. So that's been encouraging. I think we've had at least 10 in the past several months open up and have another almost 16 coming online within the next few months. So those residential placements will help. And then I also think, kudos to some of the providers and the partnerships they've forged. So I think a good example is recently having discussions with Acadia Hospital and the Community Health and Counseling's relationship, where they're trying to make sure they're making use of available crisis residential beds and kind of checking on a frequent basis to see who they could move around between their two types of care that they offer to make sure people aren't getting stuck when there may be kind of repositioning that can happen to facilitate movement.
Thank you.
Are there other questions from the committee? Dr. Pollard, did you want to try and answer some of the other ones that you haven't answered yet, or do you want to work on that with Molly and get back to us?
Well, you are testing my working memory, but I think I did not answer Representative Madigan's question. So I think the question is, there are a few parts to it. I think one is what might be in the relief package. So there is a level increase in the substance abuse prevention treatment block grant for the regular appropriation, but a close to or around 66% increase to the block grant via relief component of the package. Similarly, on the mental health side, there is a doubling of the appropriation. However, it's not clear how the relief portion of the mental health block grant will be administered. So SAMHSA is furiously working on trying to develop those guidelines for how the funds will be distributed. We do understand that at least half of the relief portion of the community mental health block grant will be discretionary grants to providers directly. Because we don't have a lot of state operated services in Maine, very, very few. Most of the vast majority of our funds that we receive through the block grant do go out directly to provider subrecipient grants. As far as any other relief, I mentioned the 4.7 for the Strengthen Me program. We are in process of renegotiating our plan with SAMHSA for the $2 million COVID SAMHSA grant, because originally when we applied for that, we did not have the Strengthen Me funding, which now thankfully we do. So we're looking at how to repurpose those funds. And I'm not sure if I addressed all of the components of the questions, but I think some of the initiatives you asked about in the budget, so that includes the crisis center, the intensive outpatient expansion, which that is based on a new rate study. So to your point about rates, that has been developed with a lot of provider participation in the sessions, not so much on the rate survey. So we're doing as much cajoling as we can to get the information from providers in order to develop an appropriate rate for that service. And then there are other pieces in there that are really about our infrastructure and our ability to take the strain off the system. So for example, through our justice and health team, because I think, to Representative Madigan's point, we want to think about this really as a tiered system. It's not a one size fits all system. There are people who have very severe challenges that need highly specialized care. And there are some individuals who may be completely sufficiently supported by primary care and not need specialized behavioral health services. So I think an important part of our strategy is making sure that we think about those tiers and how they may need to be, the reimbursement mechanisms and structures may need to be different depending on the populations that we could put in those kinds of different tiers. So that's the kind of thinking that we have in approaching the questions about rates and the specialty services. I think you also asked about, it might not have been you, somebody asked about basically location of new licenses and service locations.
It was me.
It was you. And I'm really nerdily excited to tell you that we have geo mapping for our licensing data. So we have maps that we can show you that show you 2019 capacity through licensing data, and then mapped onto the state for the current licensed facility data. So we're really excited to find out licensing had that in longitude and latitude, which makes it much easier for us to feed it into the Tableau mapping system. So it'd be quite easy for us to throw that onto a few slides and show it to you.
Thank you. I would appreciate that.
Representative Zager had a question or two.
Thank you, Mr. Chair. And Dr. Pollard, thank you. That I had no idea, some idea, but I didn't have as many details about how broad the responsibilities of OBH is. I have a couple of questions, but I think in the interest of time, I'm just going to submit them, in writing to the clerks, and then we can get an answer that way. I appreciate your presentation, and I learned a lot. Thank you.
Those can go to the clerks, and Molly will get back to us with the answer. Besides, Molly's also your peripheral brain, Dr. Pollard. She writes things down so we don't lose anything.
I'm thankful for that. And I think Representative Zager is just trying to test my written communication abilities, and that's fine. I'll be happy to demonstrate those as well.
Are there other questions from the committee? So thank you for high level and as well as a detailed look at the areas of responsibility that you and the OBH are responsible for. So glad you're in the seat, and glad it sounds like there's progress being made.
It was my pleasure.
Thank you. So I think what we'll do is we'll take a 3-minute break and start at 3:45 with, we've been joined by, did I see Benjamin Mann is here. Thank you for being here. And then he can walk us through the language portion of the budget work. Is that the plan? All right. And Mr. Wiley's back too. Welcome. So let's just take a 3-minute break, stand up, move around, and then we'll start at 3:45. Luke, we're right at the end of a very short break and people are regathering. So thank you for joining us.
Though I wasn't here on Zoom, I was listening. So,
Well, I know you were listening. You always show up at the right time. I thought it was magic when I first started here, but now I get how it works. All right. So I think enough of us are back from a brief break. Thank you for coming back so promptly. So as I understand, what we're working on from here is the language portions of the budget. Do the analysts have anything to contribute at this point? Anything you want to say?
You can find the language pieces of the budget on the committee materials website.
Okay. And thank you for joining us too, Mr. Mann. I understand there was some machinations about being able to free you up, so thank you.
Yes, I apologize in advance if you can hear my kids in the background.
We would understand that. Between your kids and Molly's cat, there's plenty of background. All right. So do you want to start, Luke? Is that the next step? Yeah.
I'm ready, so I will share my screen and bring up the language for everyone. So here we are. We have the first piece of language that relates to HHS is Part N. I don't plan to read the full language because, as you can imagine, there's a lot of changes in it. So I will read the summary and then leave it to you and the committee for discussion. So Part N summary reads, this part changes eligibility for transitional transportation to include families who are employed and have income less than 200% of the non-farm income official poverty line. It also allows the department to use up to $1.4 million annually in the TANF block grant expenditures to support employed families who have transportation costs and have income less than 200% of the non-farm income official poverty line.
Could you characterize transitional transportation for us?
That might be a question for us. Sure,
Okay.
currently, I don't know if Ben wants to.
Yeah, so the program is building off of the TANF program. So when folks are on TANF and they are transitioning off, this program supports them. We're building that out further so that it would provide a bridge for the broader population that has the appropriate income and the other specific eligibility requirements to help them access employment services or allow them to pursue whatever employment they are looking to do, and this would support them through the transportation reimbursement.
So this could be buses or whatever.
It would primarily be mileage reimbursement, but there are other considerations. But bus passes would be under potential benefit as well.
Okay, thank you. So I see a question from Representative Lemelin. I lost track of you there, Representative Lemelin. Are you still there? Did you have a question, sir?
Yes, sorry. I hit the button twice instead of once.
Okay.
My apologies. Yes. One, why does it say non-farm income? And number two, are you trying to say that someone who makes 200% above the poverty level, let's say, for a family of four or so, which is around 34,000, so they're making close to 70,000 a year, and to transition, we're still going to subsidize them for transportation? Is this the way I'm taking this?
The non-farm income piece is just a definitional piece that helps, that will better define the income eligibility. I'd have to follow up if you want more specifics beyond that. The 200% of FPL is in line with what the prior program was looking at as well. I believe Working Cars for Working Families envisioned 185% of the federal poverty level. The 70,000 for family 4 sounds a little high to me. I would have to check the data to see what exactly the level would be for that family of 4.
And Senator Moore, did you have a question? We're still not hearing you.
The holding the space bar down did not work. Sorry about that. I was just going to try to hold it down for a minute because I was trying to see it. I had that question about the non-farm because I couldn't find a chart that reflected what that was. I have the federal poverty levels for 2021, but I never could find the non-farm. So I just didn't know where that came from. That's a term that I've never heard before. So that was really my question there in that regard. And I think we don't know.
Senator Baldacci had his hand up a minute ago. Did you get your question answered?
Yes, I'm all set. Thank you, Senator.
Representative Javner.
Thank you very much, Senator Claxton. I just have a quick question then. Do we know why it is going to be set at 200% instead of the 185% of the previous program that was mentioned?
I think, again, I mentioned on Tuesday, I think it's within the ballpark. I think the 200%, it might be flexible, but again, this would all go through rulemaking and comment periods. So both residents in Maine and providers would be able to offer their feedback in terms of what the official, that income threshold should be.
And this is, as I read the last line above the summary, is federal money from the TANF block grant.
That's correct.
Are there any state dollars involved with this?
No.
Okay. All right. Any other questions? Yes, for Senator Moore.
I guess my question would be is there another program that we could use that federal block grant monies for as opposed to this? Can it be used for something else because we have such a shortage?
I think if your question is getting at making trade-offs and choosing priorities of what to spend money on, I think there's I think we wanted to hew to the original goal of the legislation of Working Cars for Working Families. Transportation in the state is obviously and make affordable transportation is an issue we're mindful of. So I think this is something that we would like to pursue as a policy direction to help support that. And the block grant side of TANF we can pay for it using those resources.
I do think it's important to note that the TANF block grant has very limited and specific uses. So this is obviously within those uses or we wouldn't be proposing it, but we also have balances in those accounts from underspending for several years back. And so the limits on those make uses limited to be repetitive. These aren't funds that we could use for anything across the department.
Okay. Yeah. Yes, Representative Stover.
Thank you, Mr. Mann. I just have a quick question. If TANF block grant funds used for this purpose aren't expended, not used for this purpose or any other, they are returned to the federal government, correct?
We accrue those balances.
Are you able to carry those over for the next, or
generally, yes, I would have to, they carry over from year to year if they're not used.
I guess what I'm trying to get at is doing this program will help people get out of poverty and back on their feet, the way that I read it. And also it's not a burden to the TANF block grant because there's enough money in there to do that.
I would certainly agree with that.
Thank you.
Let's see here, Representative Craven.
Thank you, Mr. Chair. I know that there's been some other efforts made to get people back to work, and that TANF, leftover TANF funds were used for that. So is getting people back to work one of the areas where the use of TANF leftover funds are allowed?
Yeah, this program, similar to Working Cars for Working Families, and this expansion of the Transitional Transportation Initiative is definitely an allowable and eligible application of TANF funds on the block grant side.
Representative Madigan had a question.
Yes, I just would like the department answer to be clear that this program, the use of these funds stems from a bill that had broad bipartisan support because of the excess TANF balance we had been underusing it, and that those funds need to be used for at-risk families, so that this was something that was agreed upon that be a good use to get people back to work. Is that my understanding? That's my understanding of it, and I wonder if you guys could speak to that.
Yeah, I would agree with that description. I think the goals of this program are generally in alignment with the prior one that was passed into law. The next language piece repeals that. There were technical issues with that. The original legislation directed us to spend TANF block grant dollars from 2017 and 2018. Those balances are no longer available. There's a federal requirement of first in, first out. So you spend your oldest dollars first, and by the time rulemaking and everything was over, those balances are no longer in the block grant. There's different surplus balances in there that would pay for this program. But the intent of the legislation is similar, exactly that, at-risk families and making sure that they can they have the resources for transportation, mainly for employment services.
Senator Moore, did you have a question?
Yes, I did. Well, that explains about the 6 million, because I was asking that part of it again, Ben. But then what is our balance in our block grant, in our TANF block grant? How much do we have available in the fund?
I do not know that off the top of my head. I can get it for you though.
While we wait for that, did you have something, Anna?
Yeah, I just wanted to point out that I'm going to share my screen for a minute here, if I can manage to do it. This is the definition section, and I just wanted, there was the questions about the non-farm income official poverty line. Somebody mentioned they hadn't heard this before, and you can see that the definition in the TANF chapter uses that language, and non-farm income official poverty line and federal poverty level are used all through this statute. So that's not odd. Now I'm going to unshare if I can figure it out.
Thank you for
That's all.
thank you for that information. Yes, that's usually how that's done, percentage of non-farm income.
And if I could just add to that, the Federal Register was recently updated in late 2019. That makes no distinction between non-farm and regular poverty levels.
Huh.
And the poverty level for a family of 4 in 2021 is $26,500.
If are you saying that you could just use federal poverty level in that language?
Yes. The exact words were the poverty guidelines do not make a distinction between farm and non-farm families or between aged and non-aged units.
Thank you for that. Any other questions about this piece? All right. So do we want to talk about changing the language of Part N to reflect that the distinction has gone away between, and just eliminate non-farm from that line?
Mr. Chairman, do you need a motion, or is this just discussion?
Well, I'm sort of running it up the flagpole to see if somebody says we can't do that. But my inclination is to ask for a motion to remove non-farm from the fourth line of Part N.
So moved.
Is there a second for that? Representative Craven. Second that. All right. With that change, and I don't see any other references. Oh, it does. It also includes non-farm in the underlined portion at the bottom of that paragraph. So we're talking about removing non-farm wherever it appears.
You just want federal poverty level, really, right?
Exactly. And it's in the summary, although I know that doesn't get published. Yeah. Did I see it? I'm learning. Okay. So we have a motion to make that change. So that's the motion on the floor. So I guess at this point, Carrie, it's up to you to call the roll to make sure we're okay with eliminating non-farm and going with poverty level income.
Representative Zager.
Yes.
Representative Lemlin.
Yes.
Representative Stover.
Yes.
Senator Baldacci.
Yes.
Representative Perry.
Yes.
Representative Griffin.
Yes.
Representative Connor.
Yes.
Representative Craven.
Yes.
Representative Madigan.
Yes.
Representative Javner.
Yes.
Senator Moore.
Yes.
Representative Meyer.
Yes.
Senator Claxton.
Yes. And we could have done that by entertaining the language change as part of a motion, but now I'd entertain a motion about section Part N to be included in the budget.
So moved.
Second.
That's thank you, Senator Baldacci and Representative Stover. Is there any discussion about section N at this point? Any further discussion? So I guess you're up again, Carrie. Oh, Representative Lemlin. I'm sorry.
Yeah, before we vote on it, I'd like to be heard. I oppose it. Still, it's not a matter of the language of the farm. It's a matter of the fact that if we can roll this money over, I'd rather roll it over, because giving money to people who are making 200% over the poverty level for transportation, I think that's wrong. I don't think the Maine people want that. So I know the people in my district don't. So thank you.
So just to be clear, the way I read it, it's income less than 200%, but your point doesn't change.
No, because it's still what's the difference? 199, 1 point,
Sure.
you know,
Okay.
1 point doesn't change anything.
Okay. All right. Any other questions or concerns to be expressed related to this one? Senator Baldacci?
Hi, I just wanted to indicate that for the record, that I've seen the work of this program in terms of helping people. And so as a general idea, I support it, but I just like it noted for the record, this is the Bangor Community Connector Bus, which serves 5 communities: Bangor, Brewer, Old Town, Orono, the University of Maine, and Hamden. All are served by the Community Connector, and the Community Connector receives what it is for their budget, significant money from this program and other kind of similar programs. So there's both a general support of the idea, and there is reasons for the local support, because it provides important service which helps everybody, whether they're going to be receiving support into this program or just regular everyday bus drivers and passengers. Thank you.
Thank you. Any other comments or points to be made? Representative Zager.
Thank you, Mr. Chair. I also would like to state it for the record that while I do support initiatives to help people get out of poverty, I recognize that in certain rural areas, it's especially relevant. But I would rather wish that there was some way to have carbon neutral or more environmentally friendly transportation fostered. But I recognize that that is not the main thrust of this language change. Thank you.
Any other comments? I apologize if I slow to recognize people, but sometimes the hand shows up in a bright part of your picture and I can't see it.
Do you mind if I respond to Representative Zager just briefly? I think
Sure.
That's one of the benefits of doing the program this way, is that this transitional transportation program can support a number of different types of transportation, whereas the program as originally envisioned, Working Cars for Working Families, was specifically around cars. And so I think we are also very excited at looking at new and hopefully less impactful more carbon neutral ways of transportation across the state, in line with a number of other initiatives.
Yes, Representative Perry.
Yeah, sorry, I had to get in. But when I'm looking at a rural area, I think this is where I really do get concerned, because I have had patients who are trying to even make it to work, get a car breakdown, have no place and no transportation to get where they need to be. And with that, disability ends up jeopardizing the ability to keep the job that they have. So I like the multifactorial approach, but I think that when we get into the rural areas, public transportation does not exist. And we need to have the people who have jobs be able to keep them. And for me, this program is important. Thank you.
Thank you. So now I think it's Carrie's turn. So is there a motion on the floor about Part N at this point, to move in or out of the budget?
Yes, I think it's been moved and seconded.
Okay. All right. So the motion's on the floor to move in. Thank you. And now, Carrie, thank you.
Representative Zager.
Yes.
Representative Lemlin.
No.
Representative Stover.
Yes.
Senator Baldacci.
Yes.
Representative Perry.
Yes.
Representative Griffin.
No.
Representative Connor.
No.
Representative Craven.
Yes.
Representative Madigan.
Yes.
Representative Javner.
No.
Senator Moore.
No.
Representative Meyer,
Yes.
Senator Claxton,
Yes. Okay, so that takes us to part O.
So let me share my screen again. I took it down there during the discussion. I think that might make things a little easier. So part O, this part repeals the Working Cars for Working Families program.
Any questions about that one? I don't see any questions on this one. All right, so I'll entertain a motion about part O. Yes, Representative Zager.
I move to move part O.
I'll second that motion.
Okay. Any other discussion? So there's a motion on the floor to move repealing language into the budget. So Carrie, it's your turn again.
Representative Zager,
Yes.
Representative Lemlin,
Yes.
Representative Stover,
Yes.
Senator Baldacci,
Yes.
Representative Perry,
Yes.
Representative Griffin,
Yes.
Representative Connor,
Yes.
Representative Craven,
Yes.
Representative Madigan,
Yes.
Representative Javner,
Yes.
Senator Moore,
Yes.
Representative Meyer,
Yes.
Senator Claxton.
Yes. So Luke, that takes us to part P.
And part P, this part allows the Department of Health and Human Services, Office for Family Independence to carry up to $1,335,770 to reimburse the federal government for penalties incurred in the Supplemental Nutrition Assistance Program in federal fiscal year 2019.
Okay. So are there questions about this one?
I would make a motion to approve.
Second.
Second.
Plenty of seconds there. Okay, any other discussion? So the motions on the floor is to accept part P as part of the budget, move it in. So Carrie,
Representative Zager,
Yes.
Representative Lemlin,
Yes.
Representative Stover,
Yes.
Senator Baldacci,
Yes.
Representative Perry,
Yes.
Representative Griffin,
Yes.
Representative Connor,
Yes.
Representative Craven,
Yes.
Representative Madigan,
Yes.
Representative Javner,
Yes.
Senator Moore,
Yes.
Representative Meyer,
Yes.
Senator Claxton.
yes. So that's Q.
So part Q, this part amends the transfer of funds to the Fund for a Healthy Maine dedicated revenue to $14,500,000.
And that money comes from,
This was money, this language part that you see here, PL 2019, Chapter 343 was the biennial budget for state fiscal year 20 and 21. And this part, BBBB, transferred funds to the Maine Care Stabilization Fund. And this portion of it, section BBBB4, transferred up to, as it says here, any remaining balance up to $14,500,000 on June 30th, 2021 to the Fund for a Healthy Maine. This just clarifies the language by taking any remaining balance up to and says shall transfer 14.5 million. So it basically says now the transfer back will be $14,500,000.
and that's because, That's because that money wasn't necessary for the main care stabilization fund.
I would reframe that slightly. I think it's important to keep the main care stabilization fund sufficiently resourced, but the $14.5 million from the Fund for Healthy Maine is required to have the Fund for Healthy Maine budget balance in the upcoming biennial.
Okay.
I move it in.
So Representative Craven has moved to move it in,
Second.
and Senator Baldacci has seconded. Discussion, questions? I don't see on any. We're ready to vote.
Representative Zager,
Yes.
Representative Lemlin,
Yes.
Representative Stover,
Yes.
Senator Baldacci,
Yes.
Representative Perry,
Yes.
Representative Griffin,
Yes.
Representative Connor,
Yes.
Representative Craven,
Representative Craven?
Wait, yes.
Representative Madigan,
Yes.
Representative Javner,
Yes.
Senator Moore,
Yes.
Representative Meyer,
Yes.
Senator Claxton.
Yes. All right, that gets us to R.
Part R, this part authorizes a transfer from the unappropriated surplus of the general fund to the main care stabilization fund of $25,500,000 and authorizes the main care stabilization fund to transfer for main care payments of $40 million.
Okay.
I would move to include part R as part of the budget.
Thank you, Senator Baldacci.
I'll second it. Lemlin.
Second, Representative Lemelin. Thank you. Are we ready to vote? We're ready to vote.
Representative Zager,
Yes.
Representative Lemlin,
Yes.
Representative Stover,
Yes.
Senator Baldacci,
Yes, sorry. Thank you.
Representative Perry,
Yes.
Representative Griffin,
Yes.
Representative Connor,
Yes.
Representative Craven,
Yes.
Representative Madigan,
Yes.
Representative Javner,
Yes.
Senator Moore,
Yes.
Representative Meyer,
Yes.
Senator Claxton.
Yes. And S.
That actually completes your parts of the budget. That is the last language part that's for HHS.
So we've dealt with the numbers portion of the budget. We've done with the language portion of the budget. So we're finished with what has been sent to us for review, but we also have a amendment to the budget that's being proposed. And we have Laura Cordes is having joined us. So I'd like her to introduce the amendment and the intent. Since it's brand new, I fully understand that we may not be prepared to vote for it today and may need some more background information to carry over to a third work session that would admittedly be shorter on the budget. So this was a last minute addition, and as long as we were talking the budget, we wanted to get it at least on the table. So Ms. Cordes, are you with us?
Good afternoon.
Okay,
Senator.
and Anna, is this something that you have access to, such as you could share, screen share, or let us see it since we've not seen it to this point?
I only have the email that you sent me. Would you like me to share that? I don't think I have anything else.
Okay, then why don't we ask Ms. Cordes to introduce the
Concept?
concept of it,
Sure,
and then we'll make
Senator.
provision in a subsequent work session to consider this particular amendment.
Yes, thank you for the opportunity to review it this afternoon with members of the committee. My name is Laura Cordes. I'm the Executive Director of the Maine Association of Community Service Providers, MAXB. I did have the opportunity to speak, I think, with almost all of you via via Zoom or YouTube earlier in the week during the combined hearing around the supplemental budget. I know you've already had some very long days. You know, it's really what we, the type of relief that we're looking for is short-term to help the intellectual and developmental disabilities service provider community in our state get to the other side of this pandemic. Two of the things that proposals that we had put forward in our testimony on Tuesday really have to do with how we go about looking at the stabilizing direct support professionals, DSPs, about 10,000 of them that we had at the beginning of the pandemic, which we've seen a precipitous loss of. Folks are still leaving for other positions, higher paying, lower risk, and we are wanting to keep folks in place to keep caring for vulnerable populations and keep support for community supports programs throughout the state. The concept of the amendment that we had discussed with the senator was looking at and outlined in my testimony from earlier in the week. It's really focused on one of the avenues, and that is to go back into the state's CMS approved Appendix K waiver. And there are, and I know folks have emailed me to say, well, is it still active? And I think you all have heard a lot about the Appendix K over the last several days. And yes, my understanding is it's still active, but the components can shift based on what the department originally created or how they amend it. You may also be familiar with, there was a temporary short-term rate increase of 10%. And what we have proposed in the concept of amendment would be to go back into the K and amend that for a temporary increase of 25% for a short-term period of 4 months, January through April. Again, just to get us through the other side and keep a valued staff in place throughout the state. The estimated cost of that after the federal match would be an estimated $4 million per month, or approximately $15.7 million over the course of 4 months. So that's one piece of the concept of the amendment. The other piece is to look at community supports programs, and these are center-based community supports that are medically necessary for adult individuals in Maine with intellectual and developmental disabilities. And I asked our members just to go back before the pandemic and look to see what the average revenue was per month for them. And then I asked them to look at the end of the year. You may know, because of the surge of COVID cases, the department directed our programs to close center-based programs. And for most of our programs that started in October, but certainly by November, as we saw red counties across the state, our programs have now been closed for about 3 months. Their ability certainly to do some in home, there's certainly ability to do some by telehealth or remote virtual supports, and that's been very appreciated, but we just have not been able to sustain activity and revenue. And so I asked our members and we looked at those numbers, and 29 members were able to get me some data very quickly. And we saw for those 29 members, there was $3 million a month combined in revenue, down to about $1 million at the end of the year. So that's about 29%, 30% loss in revenue. Now, the other part of the Appendix K in this proposal has to do with the ability of states to ask CMS for short-term retainer payments for these community supports programs, knowing that they are medically necessary and that we need to stand them up if they get shut down, as they have has happened in Maine. We wanted to make sure that providers are still able to pay rent, facilities, and the cost, and some part of those dollars there to keep those programs in place. So when it's safe for folks to return, they will certainly have the ability to come back into the programs to ensure skill development, exploration, and real integration and engagement in the community, as they were both designed and have been actively doing for many years now. Looking at that, that's where the proposal would be to look at a 15% retainer payment over 3 months. And that would be going back to a time when we could look at the revenue from the time before the pandemic, take that percent and provide it to the programs. My understanding, and I'm sure folks from the department know this better, but we had 30 states in a country, 31 that applied for and were approved from CMS to do this. Maine was not one of those states yet, but we know they've approved it. We know they do it, I think, for 3 periods, and it's a formula based on bed hold days. So I'm sorry that I don't have an estimate for you, because bed hold days are something in the nursing home community that I'm not as familiar with. But I can say not one of our providers is expecting to be made whole. We just want to be there for the people that we're dedicated to serve on the other side of the pandemic. And that's why we certainly ask for your support immediately in the supplemental budget. I'd be happy to answer questions. Thank you.
So thank you for bringing that to us. What would happen from here is that you would work with our analysts to get it into a form that we could present to the committee for discussion at a later date. Is that an accurate summary, Anna?
Certainly.
Okay. So as long as we have you here, you're introducing a concept for an amendment, and there's more work to be done to refine it. Are there any questions that the committee wants to ask Ms. Cordes while she's here? I don't see, Senator Moore.
My question is just understanding if this would all be federal funds, or is it part state or part, how does that work? Where is the funding going to come from?
Yes, Senator Moore, thank you. This would be the numbers that I have proposed and estimated in my testimony showed both the total cost and then what would be the federal match, and then it would, I would imagine, come from general funds. So when we earlier, when I was speaking of the Appendix K, the increase proposed for 25% for a 4-month period after the federal match, in general funds, the estimated cost would be for those 4 months of $15.7 million.
And I'd like to be clear, just for the record, that I was supportive of getting the amendment to the committee. I haven't had a chance to review it any more than you have to understand the math. So I just wanted to be clear that I was supporting the process, not necessarily the amendment. Yes, Representative Javner.
Thank you very much, Senator Claxton. I appreciate the impetus of this amendment for sure, especially concerning is from your testimony I have had actually communication from families that are receiving services in the Portland area in particular that now are having to deal with an $18 emergency wage rate. And I think that that is really the key issue here. And so as we continue to discuss about, bringing in $15 million, I understand the concern for sure for the IDD communities and in what is happening specifically in the Portland area as they deal with that. So this will be interesting conversation. Thank you.
Thank you. Representative Madigan.
Yes, I understand the difficulty community service providers are in the IDDD community. I just want to, I feel like over the years I've been on this committee that I can be sort of a broken record about this, but I just want to remind people that behavioral health providers provide the same type of services to people with serious and persistent mental illness, many of whom need services at home and in their communities, and that these are folks that are not included in this and were not included in things we did last year. And I think there's a history of and I don't want to name names. I could be here all day, name names, but of pitting one group against the other. I don't think that's useful here. I support the need for these workers, but I also support the need of workers working with other difficult populations that need services that often don't have family members that are as strong advocates as folks in the IDDD community are. I've worked in mental health for a long time. I rarely get a call from a family member because those folks are often very estranged from their families. And the fact that they don't have family members advocating for them, like this community does them a disservice. So I just want to go on record that it's really important that we don't forget there are other workers that are providing frontline services during this time that also need assistance.
Thank you, Representative Madigan. Representative Lemelin.
Yes, thank you, Senator. Did you last year, did the governor grant you any of the $1.2 billion she received for COVID? And if yes, how much?
No, Representative, not from the CARES Act, the Coronavirus Relief Fund. No, we did present, we looked to other states, and our neighboring states of Vermont and New Hampshire had used CARES Act dollars to quickly set up a stabilization or hazard program those CARES Act dollars went through the providers to DSPs who stayed on the front lines, giving them a stipend of $1,200 a month if they stayed, or a weekly stipend. So we did have a chance to put together a proposal, the table of which is in my testimony, for a similar program here in March. We did have an opportunity to speak with staff from the governor's office, the department, and DAFS, and talk through some of those numbers. And, we were, certainly seemed very promising. I know there were a lot of requests, but we were not included in the end.
Okay, you did request some of that money though?
Yes, we
and
did.
You were denied?
From the
CARES Act.
From the CARES Act, yes, we did make a proposal to the administration, yes.
And you got nothing?
That's correct. From the federal dollars, yes.
Me. Thank you.
Senator Baldacci. Oh, sorry, Mr. Mann, did you have something to contribute there?
If I may, I would just offer that IDD providers were eligible for the partnership between DHHS and the Department of Economic and Community Development Economic Recovery Grant Program. Those were grants that were provided to businesses across the state in different rounds. And and all businesses were eligible to apply for that. And those all the numbers, I don't have the numbers off the top of my head for the amount of money, but it was it's all on the governor's COVID website if you're interested in the amount of money that was provided through those recovery grant programs to private businesses.
And if I may, Senator.
Please.
Yeah. You know, it may be an opportunity to say there were certainly in the department lifted up many opportunities, you know, when there was something from the federal government or certainly the state grant program. Even when it was expanded, our members were excited to see that because many in the first round thought, well, I have more than 250 employees in my large network of different services. But in the end, while as promising as they were, many of our members just simply weren't eligible or couldn't show a 20% loss, even though, you know, but they still don't have the dollars to give hero pay or incentive pay to keep people in these positions because the stagnant wage rate component of, you know, many of these IDD services. So I do appreciate you mentioning that, you know, that the department did put those pieces up, and there's certainly been some flexibilities, but our ability to have incentive hero pay when those temporary increases ended last May, we just haven't seen anything to support that moving forward.
Senator Baldacci had a question, and then Representative Connor.
Thank you, Mr. Chairman. First of all, thank you, Laura, for this is an important issue. It affects thousands of families across the state, and it's a common issue. The issue about not paying direct care providers is a chronic problem. I think it would be helpful. I thought Representative Lemelin had a great question, and it would be helpful probably to have a copy of what you proposed to the administration for CARES Act funding, just so we have to at least give me some context as to what exactly you were looking for from them and what might qualify as CARES Act funding. I think, you know, obviously I'm going to need we need the fiscal impacts, you know, before we vote on this entirely. But what was under your proposal, what was the total amount of federal dollars coming into Maine? So it was 15 million state, and how much would that generate from federal dollars?
Okay, I think there's two pieces to this, Senator, and thank you for your question. One would be, I'm happy to send you the detail of the documents we shared with the governor's office and DAFS and the department. We did, I think one of the challenges at the time is from where I sit, you know, those were federal dollars. There was not going to be, you know, a match back to that. You know, it can't necessarily double dip.
Oh yeah, no, I understand that.
So the federal dollars at the time for that, well, and I'm glad you did. I think early on when we were trying to figure that out, we weren't exactly sure. But when we looked at that, total amount was about 40 million over the course of 4 months. And I'm happy to send you that table.
Okay, so it would bring into it would be a total generation of $55 million. Correct, for wages or no?
And you know, I think I just need a quick calculator to deduct. I think.
My point is that I think that we also, as part of this discussion, need to know how much federal money that would bring in as well.
Yes, exactly.
Because we are in the middle of a pandemic, and so I think that context would be very helpful to these discussions. Thank you.
Yes.
Representative Connor.
Yes, thank you, Mr. Chairman, and please forgive me. This is drinking from a fire hydrant for me. I'm new to all of this. So my question is, some of your providers are private businesses, if I'm not mistaken. I'd like to know if any of them actually applied for the PPP loans individually, not necessarily through the state, or is that one and the same, what you guys are already talking about, just for clarification?
No, it's actually, it is different. And thank you for your question. It's, and you know, 30% of, we have about 70 members, and of those members, 70% are nonprofits, 30% are business, but all of our members, if I'm not mistaken, were certainly, generally speaking, nonprofits, business were all eligible for PPP loans. I think the majority of them who applied were successful, and that was great support early on. And I would say of all the pieces, the PPP loans, as well as the early 3-month temporary increase were the things that really helped people early on be able to stabilize staff and cover some of those initial costs.
And were any of them, or do you know if any of them have subsequently applied for the second round of PPP?
No, I do not, but I'm certainly happy to ask.
Thank you. That's all I have, Mr. Chairman.
Thank you for those questions. It also occurs to me, based on Representative Lemlin's question a couple times, that I'd like to see the pie chart of the CARES money distribution and where it went in slices. So if that's something that Anna and Aaron could come up for, I think that would help establish a context for some of this conversation, further establish the context. Any other comments about this particular concept amendment? So again, what would happen from here is that Ms. Cordes would work with our analysts to come up with language. The language would be shared, and then we would have some time for consideration and then discussion before voting at a third work session on the budget. Is everybody comfortable with that process? Okay. All right. I appreciate the flexibility of our book reporters to be willing to put off their book reports until a time that doesn't take us beyond 5 o'clock, which is what we're looking at. So there being any other business before we adjourn? And thank you for the folks from the budget and finance world for helping us through some of these things that we're still learning about. So thank you, Mr. Mann and Mr. Wiley, and Luke is stuck with us. So thank you for your help. Any other comments? Then I think we should adjourn until, thank you. Anna, did you have something you wanted to say?
I just wondered if you were anticipating the next budget session being on Tuesday after everything else, because that's one of the
if you have enough time to do that work and get the thing distributed, that would be great, but I didn't want to presume.
okay, it's just, I just want to remind you that the report back is Friday, not
Yes,
tomorrow, next Friday.
Next Friday. No, I knew that, and that's why. So I knew you knew that, so I figured you'd get it to us as quickly as you could, so that we could consider it.
We'll do our best.
I know. All right. So before we go, that takes us until next Tuesday at 9 o'clock, which would be February 2nd, according to my calculations. Okay. Thank
Mr.
you
Chairman,
all.
I move to adjourn.
You've got a bunch done. So thank you all for this work.